السلام عليكم ورحمة الله وبركاته، وأسعد الله صباحكم بكل خير. نحييكم ونرحب بكم في اليوم الثاني من أيام مؤتمركم، مؤتمر سلام الدولي الثاني للرعاية الصحية المنزلية. سعدنا بوجودكم يوم أمس في اليوم الأول، ونواصل اليوم الجلسات العلمية بعد أن انتهت الجلسة الرابعة مساء يوم أمس. هذه هي الجلسة الخامسة من جلسات المؤتمر العلمية، ونيابة عن سعادة الدكتور أشرف أمير رئيس هذه الجلسة لتواجده في اجتماع طارئ الآن، أتشرف بأن آخذ هذا المكان المرموق وأن أقدم المتحدث الأول في هذه الجلسة سعادة الدكتور إياد السبيعي. I'm proud to introduce to you Dr. Iyad Sibai, Director of Jeddah Center for Liver and Digestive Disease, Chairman of Department of Medicine at Arfan and Bagado Hospital. Dr. Sibai, Fellow in American College of Gastroenterology and Fellow in American Society for GIT Endoscopy. Founding member of the Saudi Gastroenterology Association and former president of Mecca region branch of the association. Dr. Sibai, co-founder of Jeddah Gut Club with Professor Shubukshi, Atalallahu fi umri, and former president of Gut Club. Dr. Iyad Sibai, founder and co-owner of the Urgentology and Urgent Care of the Urgent Care Center in Dallas, Texas, USA. Dr. Iyad, welcome as the first speaker in this morning session, and the floor is yours.
Salam alaikum wa rahmatullahi wa barakatuh. It's my pleasure to give my presentation today. And before doing that, I would like to thank Professor Ashraf Amir and all the organizing committee for inviting me to give this presentation in this prestigious and very interesting conference. And I wish the success to the conference, inshallah. I'm going to talk today about the harmful effect of non-steroidal anti-inflammatory drugs in causing peptic ulcer disease, particularly in elderly. And this is the question: is to be or not to be? How can we make it not to be? As we know, non-steroidal anti-inflammatory drugs, or NSAIDs, from now on, I will keep saying NSAIDs easier. NSAIDs is widely used because it has a lot of variety of interesting benefits, including its analgesic effect, its antipyretic effect, as well as anti-inflammatory properly. According to their mode of action, they are classified into two classes. Class 1, non-selective, general, non-steroidal anti-inflammatory drugs, and the selective COX-2 inhibitors. The non-selective, they work on both COX-1 and COX-2 inhibition, while the selective one are selective COX-2 inhibitors. The deleterious effect of NSAIDs, which include, the gastroduodenal peptic ulcer disease, the renal toxicity, are mainly due to inhibition of COX-1 inhibitor, but also the cardiovascular damaging effect is related to inhibition of COX-2. So both of them are deleterious. In general, all NSAIDs are harmful to the GI tract, and their harmful effect varies from one brand to another, depending on how long they would stay in the system, their way of their metabolism, and their inhibition to COX-2 or not inhibition to the COX-2 only. There are several factors which make the harmful more, including the dose of the medicine that is given, and if the patient has other drugs, which is drug-to-drug interaction, the presence of other illnesses, comorbidities like renal disease, cardiac disease, COPD, etc. Especially in the elderly, as we're going to see, the age by itself is a factor that makes the NSAIDs more damaging than in young individuals. The damaging effect may occur even after 1 week of taking a general NSAIDs like indomethacin. So we have to be careful when we give these kind of medications to our patients, as we're going to talk about it. In general, God created protective factors to prevent formation of ulcers and inflammation, including the most important is the COX-1. The COX-1 stimulates the production of prostaglandin, and the prostaglandin increases the mucus thickness of the mucosal surface of the gut, increases secretion of local secretion of sodium bicarbonate, which will make the pH barrier against the acid to damage the epithelium of the gut, and then the tight junction between the cells. The prostaglandin also enhances the mucosal blood flow to help nourish the epithelium properly and prevent damaging effect, and also enhance the secretion of what is called the mucosal growth factor, which help regenerate any damaged tissue that may happen. So all these preventive factors, if we give a medicine that blocks the COX-1, then damages happen, like, using aspirin or NSAIDs. There are some other comorbid illnesses. The age, as I said, by itself, if the patient has a previous history of peptic ulcer disease, and also there is some sort of genetic predisposition through metabolizing the drugs. Some patients, the drug stays in their system longer than others because it's not metabolized quickly, and that will cause more harm. Helicobacter pylori, very notorious bacteria now. Unfortunately, it became now in the mind of many doctors that it is responsible for everything. Even if their toes scratches, they think, oh, because you have H. pylori. So we have to put it in its perspective, neither to neglect it and nor to let it carry more than what it is for. But for peptic ulcer disease and for non-steroidal, it's very important factor, as I'm going to talk about it in details. Simultaneous intake of many other medications, as we're going to see, may make the harmful effect of NSAIDs more. And especially, as I said, the age by itself. Number one, because of the age. Number two, because of the presence of too many other comorbid illnesses. And number three, because these kind of patients, they take too many medications that they may synergize with each other to cause more harm on the gut. H. pylori, as I said, it is the most common cause of peptic ulcer disease. And if we look at those infected individuals with H. pylori compared to non-infected, we find that those who got infected with H. pylori, the incidence of ulcer is 4 times more than those who do not have the bacteria. On the other hand, we know that NSAIDs by themselves, regardless of the bacteria, also are harmful, and the risk of taking NSAIDs increases triple times the incidence of ulcer as compared to those who do not take NSAIDs. Now, if we have both of them together, NSAIDs as well as H. pylori, the risk even becomes double, so which is total, making 8 times more risky to have ulcer if you have the two problems at the same time. Therefore, it is important to look for this kind of bacteria and treat it if you want to start the patient on long-term treatment with PPI. Glucocorticosteroids like prednisolone or whatever, dexamethasone or whatever, in the mind of many doctors that it may cause ulcer. In reality, it is not. By itself, if it is given by itself, as you can see here, the odd ratio is almost the same as those who do not take corticosteroids. So corticosteroids by themselves are not that harmful toward peptic ulcer disease. However, if the corticosteroids are taken at the same time with NSAIDs, here are the risk. As I said, the risk of NSAIDs to cause ulcer is 4 times. Now, if we add to it corticosteroids, then the risk will become more than 5 times, or doubles the risk. So combination
أنه شريك
and corticosteroids is very, very harmful to create ulcers. So we have to keep this in mind. SSRI, the antidepressant serotonin reuptake inhibitors, they were found to cause more harm and create more GI bleeding from NSAIDs. Why? Because the SSRI deplete the serotonin from the platelets. So the platelet will not aggregate. Once bleeding happens, the platelet will not aggregate good enough to stop the bleeding. And that's why we find the risk of bleeding is almost 6 times in those who take SSRI together with NSAIDs as compared to those who do not take. So this is very important factor. Other harming factors, smoking. Smoking is extremely dangerous, especially in elderly and especially if the patients are taking NSAIDs. The risk of peptic ulcer disease in smokers is 3 times those who are not smokers. Why? Because smoking It reduces the mucosal prostaglandin. It reduces the secretion of local mucosal bicarbonate, decreases the production of epidermal growth factor, which prevent ulcer formation, and also decreases the eradication of H. pylori. If we look at group of patients who have H. pylori and they are not smokers, the eradication is much faster and much easier than those who smoke and have H. pylori. So we have to keep this in our mind. Alcohol is another also harming factor, which has direct damaging effect into the epithelium and increases the incidence of ulcer and the GI bleeding. Now, on the other way around, don't think of other harmful factors aside of these from the diet. There is no need to put the patient on any special diet. Like, indeed, if we have a diet that is rich in fresh fruits and vegetables, that is very good as provide the patient with antioxidants, which will help them in general. Coffee is not harmful, contrary to the belief of too many people. Coffee is okay and is safe to be taken, no problem with it. Emotional stress by itself is not a problem, but the problem is the emotion may lead the patients to take antidepressants, or it may lead them to have some abnormal bad behaviors like smoking or drinking alcohol. So, but stress by itself is not a harmful effect toward peptic ulcer disease. Of course, as I said, there is some genetic predisposition is very important, especially in group O, blood group. The symptoms and signs, if ulcer formation, the typical one is epigastric abdominal pain that increases with hunger and relief temporarily with food intake to reoccur again after that. But if there is a pyloric channel ulcer, then the abdominal pain become immediately after eating and may have vomiting. And if patients have, a posterior duodenal ulcer, it may penetrate into the pancreas and cause epigastric pain radiating to the back. All these symptoms, indeed, and the physical findings may not present, especially in elderly. As a matter of fact, there are many patients, they present for the first time with the complications rather than symptoms. So a doctor, primary care physician, has to be careful not to think himself that is expected to listen to typical symptoms. Elderly may not volunteer information, may not give proper descriptions of their pain, so they have to be very cautious about it. Complications of peptic ulcer disease, 20% of the patients may present for the first time with the complications of peptic ulcer disease, like GI bleeding is the most important and most serious and most common. Complications of ulcer, perforation of the ulcers comes, then stricture may cause gastric outlet obstruction, and if the posterior wall duodenal ulcer occurs, it may penetrate into the pancreas and cause picture like pancreatitis. How do we diagnose? The gold standard is endoscopy. However, as endoscopist, I would like to warn you that sedation of elderly is very important, and you have to be very cautious when you want to sedate your patients for endoscopy. Sometimes we may do CT scan of the abdomen, especially if there is symptoms of obstruction, rather than starting with endoscopy. I would like to warn barium study. It should not be used ever, because this very viscous material, it may stick in the bowel and the stomach of the patients for a long time. When you want to do endoscopy, you cannot do it. It will block the visibility. And it is neither accurate nor sensitive nor specific. There are unfortunately some doctors that still order the barium study. It's very bad. If we have to do a contrast study, then we can use gastrographin. Gastrographin is water-soluble substance that can be easily, if there is even partial obstruction, the gastrographin can pass down to the bowel. And even if endoscopy needed to be done, then they can be aspirated easily with the scope. So in the elderly, it's better to go directly with endoscopy rather than to do H. pylori testing or if you are suspecting ulcer disease. Of course, these factors here, if they present what they are called red flag symptoms and signs, then endoscopy becomes more important. Among them, the most important is the advanced age with a suspicion of peptic ulcer disease. How do we prevent the development of peptic ulcer disease? First, we have to determine who are the patients at high risk. The high risk, according to the American College of Gastroenterology, classified into high, moderate, and low risk. The high risk are those with history of previous ulcer or complicated ulcer, or those who have more than 2 factors of these, which we are showing here. Moderate age, above the age of 65, high dose of NSAIDs intake, previous history of uncomplicated peptic ulcer disease, and concurrent use of aspirin or other medications, as we talked about. Now, moderate risk are those who have 1 or 2. High risk are those who have more than 2 of these risk factors. So if we have a patient at moderate or high risk, we have to think also one of the options is to use selective COX-2 inhibitors. They have less incidence of peptic ulcer disease. However, in the USA, most of them were withdrawn from the market, except the celecoxib, which is Celebrex, that is present in the USA. And here in Saudi Arabia, we have another one. It's a heterocoxib, which is Arcoxia, that is also available. However, we have to be cautious about their effect on cardiovascular thrombosis. That's why we have to use very low dose. We should not use that, like the celecoxib, we should not use 200 BID, but only 200 once daily. Now, those who want to take COX-2 inhibitors, if they are taking aspirin, then COX-2 inhibitor is not selective anymore. The damaging effect become like any other non-selective COX-2 inhibitors, to keep this in our mind. How do we prevent from peptic ulcer disease? The best proven beneficial medicine is actually proton pump inhibitors, because H2 antagonists are very weak. They don't have enough protective effect against NSAIDs. And prostaglandins, they are good, but you have to give a very high dose. And the problem with the side effect of the prostaglandin, and here in the Saudi Arabia, it's forbidden to be given. I think it's withdrawn from the market because, you know, if it is used topical, like a vagina, placed in the vagina, it may induce abortion. That's why the government, the Ministry of Health, decided to remove it from the market, which is an excellent approach. So the prevention actually is to go with the PPI, and the benefit of PPI, like in this study, we find it lower the risk very significantly of forming peptic ulcer disease. Now, if you use both COX-2 inhibitor, selective COX-2 inhibitor, and PPI, that will give you the most important preventive effect. Esomeprazole doesn't need to be high dose. 20 milligram a day is good enough to protect against peptic ulcer disease. So the best prevention in high risk factors, as I said, you may give combination of PPI. And as I said, if H. pylori is present, we should eradicate the bacteria before we put the patient on long-term treatment with NSAIDs. So in conclusion, my colleagues, it's important for the primary care physician to keep in his mind the following points. Number one, try if you can to avoid using NSAIDs through the mouth. Use alternative like paracetamol or acetaminophen. Use topical NSAIDs like cream or gel or patches, skin patches, or even you may use preparations like capsaicin, which is the الحر بتاع الفلفل هو الكابسيسين. It's available I don't know in Saudi Arabia, but in America we have it. It's skin patches that you put it on the joint, and by creating pain sensation in the skin, burning sensation, it blocks the deep painful effect of the arthritis. That's the main mechanism of action of capsaicin. If there is strong indication, use the least effective dose and for the shortest period of time. Don't just automatically renew the medicine whenever the patient comes to your office. Look for other comorbid factors, especially, as I said, if there are any heart disease, kidney disease, etc., and look for other harmful medications. And those who are on high risk or moderate risk, then we have to add proton pump inhibitors to their medications. And if they don't have high predisposition to thromboembolic effect, you may use selective COX-2 inhibitors plus the PPI as well. Careful taking history is very important. Remember, the patient, the elderly patient, do not volunteer typical information. And if there is any suspicion of anything, please do not keep taking care of yourself alone. Try to consult your GI colleague. And thank you very much.
Thank you so much, Dr. Iyad, for this wonderful presentation. And I will just apologize from our virtually attending guests and the physical, because we are running short of time. And I know Dr. Iyad has an obligation. So thank you so much, Dr. Iyad, for being with us here today. And ladies and gentlemen, I would like to welcome you here in the second day of the second International IMC International Salam Home Healthcare Conference. And in fact, it was a very pleasant day yesterday where we had a very fruitful discussions on a varieties of topics that enrich all of us in the field of home healthcare with a different perspective from different specialties. And I think it was a quite successful day. It couldn't be a successful day without your contribution and without your attendance with us. So without any further delay, I would like to introduce my colleague, Dr. Masoud Ahmed Al-Ghamdi. He's a laparoscopic and colorectal surgery consultant at King Fahd General Hospital, Jeddah, Saudi Arabia. He's a certified in a clinical fellowship training in colorectal surgery. He's certified in Saudi Board of General Surgery, and he's a member of Saudi General Society, and a member of the American College of Surgeons, General Surgery Residency Training Programs Director in King Fahd Hospitals, and a chairman of organizing committee as a speaker of the first Colorectal Cancer Awareness Day in King Fahd Hospital, Jeddah, Saudi Arabia. In fact, the CV is quite rich by the contribution of Dr. Masoud for his specialties and the contribution in his scientific activities. And he will be shedding a light today on the stoma creations, indications, and care. And I think this is one of the very important and challenging subjects for all of us as a home healthcare providers that we encounter these kind of cases. So I'm very sure that we'll be having a very interesting session by Dr. Masoud. And I would like to thank you for accepting our invitation, Dr. Masoud. And I'll just leave the floor for you.
Assalamu alaikum wa rahmatullahi wa barakatuh. Sabah al-khair. I would like to thank organizing committee and our attendants, either on the floor or Zoom. So today, inshallah, we will talk about stoma. It's a long subject, but inshallah, we will make it in brief and simple for everyone. أنا من النوع اللي يحب يتكلم ويتحرك. معلش اعذروني. First of all, just our topic will be about stoma definition and classification, stoma indication, what we have to do with the stoma, which one is the best stoma, colostomy or ileostomy, what are the complications for this stoma affect, it will affect the life of the patient or not, it will affect it, the stoma nails, the action of the stoma nails, and what he will do with the doctor and the staff. Then after that, we will talk about a new method instead of stoma, we call it Flexi-Seal. And after that, we will conclude our presentation. So as we know, we have classification for the stoma. So either according to the anatomy, so we have colostomy and ileostomy. As we know, the colostomy is coming from the colon and the ileostomy is coming from the jejunum or ileum. So the duration for this one, we call it either in a temporary in some cases, or it will be permanent. Unfortunately, in some cases, we have to keep the stoma for alive, and it will not be closed. The other one, it can be end or lobe stoma. So what are the indication for the colostomy or ileostomy? We have a lot of indication for that one, either protecting bowel anastomosis in cases of surgery, tumor patient, or inflammatory bowel disease, protecting repair in anal sphincter repair, or complex, we call complex fistula, or any trauma to the perianal or anal area. Infectious disease, one of the most common diseases in our life in diabetic patients, it's Fournier gangrene, and it's coming with the infected area of the perineum and anal area. So in these cases, we have to do stoma in these cases. Pediatric cases, we will not talk about this one. So this is the other schedule. It's look like the same, just indication for the stoma. So as we know, we have different types. So where is the location for the stoma? It should be in the rectus muscle, because the muscle will affect as valve. So if we will insert or we will do the stoma far away from the it's not coming out. Not a thing. So if we will do the stoma far away from this point, the prolapse and herniation of the stoma, it will be common. So before stoma creation, we have to see the patient before surgery. We have to sit with the patient, the doctor and the nurse, and they have to localize the location for the stoma. It's dependent on the, sorry. So the patient at supine position, sitting position, bending position, and standing position, because we have to keep the stoma far away from the belt and far away from the bone structure. So this is, as we said, the ileostomy is coming from the small bowel. It will be functioning within تقريبا first day or second day. And this is the location. It's one of our patients, and the criteria of the ileostomy. And then we have to create about something we call spout. It's about 2 centimeters. So then we have to make the lobe of the bowel about 2 centimeters far away from the skin. So the secretion of the pancreatic and bile juice, it will not affect the skin. Colostomy is coming from the colon, any part of the colon. The function of the colon, it will delay, not like the ileostomy. It will take up to 5 days. So don't worry about your patient if he's not passing the stool for first and second and third day. Sometimes we have to wait up to 12 or 15 days. But if there is any sign of obstruction, like a drala, like vomiting, abdominal distension, so we have to take action about this one. So this is the difference between the colostomy and ileostomy. Colostomy, it will be attached to the skin, no need to make a spout. So the secretion only, it will be stool. There is no pancreatic or bile juice. So what we have to do in patient who will create for him stoma, the most important, we have to advise the patient to drink a lot of water, because if he will not drink a lot of water, he will develop like dehydration, and the stool will become hard, so it will be difficult to pass a stool. Then about the food, we have to avoid and drink the material that cause a lot of gases. So the patient, he will complain of a lot of gases in the stoma. So it's important to let him drink and avoid or drink any material that cause gases. So ileostomy, we have to tell the patient to avoid high fiber diet. And in colostomy, we have to tell the patient to eat a lot of high fiber diet. It's opposite together. So in general, how can we differentiate between ileostomy and colostomy? It's like one of the important, and the ileostomy, it will be in the right side, but can be also on the left side. Colostomy, it will be in the left side. Secretion or the shape, as we said, it's look like there is a spout in the ileostomy, and in the colostomy, it will be flush with the skin, no need to elevate it up. The secretion of the stoma, ileostomy, it will be like liquid, and the secretion of the colostomy, it will be like stool. So how do you know this patient is passing a lot of or minimal or enough amount of the secretion? So in the stoma, we have to calculate how much secretion per day, because if it's more than 1,000, the patient will be dehydrated. If it's less than 500, the patient he will develop overload. And the colostomy, nothing, it's not emergency to count how much, but the important one, the patient is passing the stool or no. So this is what the type of the food that we have to start with the patient after creation of the stoma, and we have to give him IV fluid. First day post-op, we can start with clear liquid, or we can start by soft diet in the second day post-op. So before stoma creation, we have to sit with the patient, doctor and stoma nurse, and they have to tell the patient about the indication for the stoma. They have to tell him where is the stoma and how to deal with the stoma, and the bowel prep before the creation of the stoma. And the patient, he has all the right to either agree with the stoma or not agree. But in some cases, we have to tell the patient it's mandatory to create stoma for him. This is the guideline. It's okay, no problem there. No need to discuss this one. And this is the closure. It's okay. And the other one, complication. So just we will talk or concentrate today about the complication of the stoma. So what are the risks of the stoma? Unfortunately, most of the cases will present as emergency cases. So unfortunately, these cases will be operated night time. So no time to sit with the patient, and the stoma nurse, maybe she is busy with other cases, or maybe she is at home because only the surgeon he will be available. So one of the risk factor for the complication or emergency cases, obesity patient, they have risk of retraction and infection and prolapse. Female gender also, elderly patient, they have risk of complication type and site of the stoma, and the other factor will affect the stoma. So one of the common presentation of complication, we call it parostomal hernia. Sorry. So parostomal, this is the stoma, and this is all hernia around the stoma. So it will be like this one. So the stoma here and part of the bowel is outside. So how to deal with this patient? If the patient he has no obstruction, so we can continue just conservative management with him. If he has constipation or obstruction or huge hernia, so we have to go for surgery in these cases. So what's the benefit for or what's our target in this management? And we have to fix the stoma to the rectus muscle, either surgical by repair or to apply mesh. And they found in the mesh application for this one, it will decrease the rate of recurrence. So hemorrhage, one of the commonest complication that can common, but it's not too common like parostomal hernia. It's either coming from the vein or artery, from the mesentery of the bowel, or from the bowel itself. So if it's minimal, it's common, can be happen. So just need pressure on the bleeder and it will be controlled. We can use also epinephrine for 2 or 5 minutes, just pressure, and it will be closed. In some cases, we have to close it by suture, but if there is significant bleeding and we cannot be controlled as bedside, so we have to take the patient for surgery to control the bleeding. One of the cases, also this is the complication, paresis, it's common with the liver disease patient, alcoholic cirrhosis. So the bleeding here, we have to control it also like by suture, by cauterization, by embolization. Sometimes we have to take the patient also for surgery to control the bleeding. One of the complications that it's bad, but we have to deal with this, and parostomal, we call prolapse or stoma prolapse. The skin and the wall of the abdomen is fine, but the problem of the mesentery will be weak, so the bowel, it will come outside. So if there is no sign of obstruction and the segment is short, so we can keep it, no problem. The problem with this one, the bag, it will not accommodate with this part of the bowel if it's outside. So what we have to do, and we have to take the patient for surgery. So it can be done from the side of this wound. So we can cut the part of the bowel from here and just fix it to the skin. It will be fine. But sometimes if it's difficult, we have to take the patient again for surgery and do for him refixation. Like this one. So either we will cut it from here and refix it like this one, or we have to take him for revision and closure of the defect. So as we said before, small bowel, it's more common for the dehydration. So we have to know how much the patient is taking fluid and how much the output of the stoma. So if we calculate it and it will be the same, so it's fine. But if the output is high, so we have to give the patient and do correction for the electrolyte and fluid. This is one of my patients. He was referred from the private hospital as a case of query TB, query inflammatory bowel disease. So the diagnosis was not clear. So we took the patient for surgery emergency and we create for him ileostomy. So this patient, he developed, we call dermatitis or inflammation around the stoma, like this one. So in this case, it's just we can give him some medicine and we can give the stoma nurse. She has a lot of work in this patient. Unfortunately, the patient, if he is fine and he will follow our instruction, he will be okay. But some patients, unfortunately, they will not follow our instructions, so they will develop like this one. This is also stomal granuloma. It's not malignant. It's benign lesion. It's look like nodular, multinodular around the stoma, like this one and like this one. So it's nothing serious. The management of this one, just we can apply silver nitrate like cauterization in this one, or we can use some cream, or we can refer the patient for dermatology to do cryotherapy for this one, and it will disappear. It's one of the bad scenario with the patient if we operate the patient and we create for him stoma, and unfortunately the blood supply is less in the stoma end, so he will end by stenosis. So stenosis, it's mean the patient, sorry. The stenosis mean this is opening is less than 2 centimeters. So if it's a stoma, ileostomy, so the patient he can pass, but if it's colostomy, the patient he cannot pass a stool. So this is either we can do dilatation bedside for this patient, or we have to take him for surgery to do revision for the stoma or creation of the new stoma, like this one. Stoma retraction, it's common with obese patient because the stoma would retract it because the mesentery is short. So in these cases, we have to take the patient for surgery and refix or readjust the stoma. One of our cases, we operate the patient at night time. The patient, he has a risk factor of ischemic bowel, and we create for him stoma, and he developed like this one, blackish. So the management of this one, it's not mean the stoma is failed. There is two steps in this cases. If just only the stoma, the mucosa is black and the submucosa is clear, so no need to remove or no need to create a new stoma. So just we can wait for up to 1 week or 2 weeks, and the mucosa, it will go outside, and the submucosa and the layer below this one or underlying this one, it will be healthy. So if the mucosa and submucosa become black, so this one we have to take the patient for surgery. This is okay, no problem. So ileostomy diarrhea, it's look like the previous one, just we have to calculate the output. In some cases, the patient, he will come, he has a stoma, and he will come, unfortunately, after a few days, and he said, no, I cannot pass a stool, I cannot not pass secretion from the stoma more than 6 hours. So this is, we call temporary obstruction. So just we will advise the patient to drink a lot of water, do massage around the stoma, and we can just let him to relax his muscles so he can bend his knee, and everything will be fine for him. So this one, I want to jump because of the time. So if the patient, he has a stoma, this is mean, no, he cannot do his daily activity. No, he can do his daily activity. He can wear his clothes, no problem about this one. He can walk, he can do his daily activity without any restriction. So I think this one, the patient, most of the patient, they will ask, can I take shower or no? They can take shower either with stoma or without, or he can use some plastic sheet to cover the stoma and take shower. This is the activity. He can run, he can travel, he can do anything with the stoma. It will not affect the social life, it will not affect the pregnancy, but they have to discuss with the primary doctor. Even for this one, if there is a day in first Saturday of October, they call it the stoma day. So this is International Day for all the stoma patient. And for the religious, the patient, he can pray, he can go Makkah, he can do Hajj, he can do anything. It's nothing restriction for him. So what's the role of the stoma nurse? The stoma nurse, it's one important part of our management in this patient. So we need the stoma nurse before surgery and intraoperative sometime, and after surgery, she has a lot of effect and a lot of action with the patient and dealing with the stoma. So the last point, just I will talk about a new technique. And if the patient is refusing the stoma and he has band wound in the perineum or perianal area or bed sore or bedridden, so this patient is refusing the stoma, what we have to do, we can use something called FlexiSeal tube. It's tube that diverting the stool from the anus far away without creation of stoma. So it's look like, so this is the tube. This is the balloon that we have to insert it inside the anus. We can inflate this one with saline. The maximum volume for this one, it's about 45 milli. So we can adjust according to the size of the anus of the patient. So it will be in the lower part of the rectum. Just we will inflate it by the tube here. There is one inflation for the irrigation. This is the irrigation, the fluid and the saline. We will push it inside. So it will lubricate the stool here and make it as a liquid, so it will pass through the tube from here. So no need to create a stoma in some cases, and I did it in maybe 4 cases in our hospital, and mashallah, all the cases they got great healing for the wound of the perineal and perianal area, and they discharge without creation of the stoma. So unfortunately, I forget my picture of my patient, but I brought this one from the internet. It's look like this one. So this is the tube that the stool will pass through this one, and there is a small tube for irrigation here. So this patient, he has bed sore, no need to create stoma, and the complication of the stoma, as we said, there is a lot of complication. So this one, it will be fine. It will take from 2 weeks up to 4 weeks for complete healing. So what's the contraindication for the using of this tube? And if there is rectal or anal injury, hemorrhoid, significant hemorrhoid with congestion, severe rectal anal stricture, or suspected of rectal mucosa implant, or confirmed rectal or anal tumor, because it will be painful for this patient. So conclusion, and stoma has several indications and also a lot of complication, but we can deal with this complication. Morbidity rates are high with some patient. Prevention is the best in all patients. According to the feasibility and evidence, there is no big difference between colostomy and ileostomy. And each ileostomy and colostomy, both of them, they have advantage and they have disadvantage. So thank you, and see you inshallah.
Thank you so much, Dr. Masoud, for this nice presentation, which was really practical for all of us. And in fact, I have a couple of questions here I received from the audience. They said the lower part of the high stoma output, will it change the microbial flora for the lower part of the colon?
No, it will not change, but the most important, the problem, it will be affected. The high output, it will affect the electrolyte and we call the amount of fluid in the body. So it will cause dehydration and electrolyte disturbance. But for the microflora, it will not be affected.
So there is no recommendation for any kind of probiotics or
Nothing.
any kind of, okay,
Nothing.
perfect. The other question is usually we encounter that the patient are resistant for the decision of colostomy, although there is a medical indication. So what is your approach to convince them?
And sometimes we have to sit with the patient, with the relative. We have to tell the social worker to sit with us, and we have to discuss with the patient. The patient, he has right to reject or refuse to creation of stoma. So if he has complete rejection, we have to take decision of two consultant, and this is top emergency, and we have to sign the consent for this patient. If he is still refusing, so this is mean no, he is not agree to our plan, so we have to give him his.
Well, the flex seal tube will be the proper way to manage those patients who they don't want to get into colostomy.
This tube just we will use it if there is like perianal injury or wound or bit sore or something, but it's not solution for if there is a sign of obstruction intra-abdominal. So it's just for extra peritoneal injury, the flexi-seal tube.
All right. You said elegantly, Dr. Masoud, the competency of the stoma nurse, but this is the stoma nurse in the hospital. So how about our colleagues who are dealing with this stoma care at home? If there is any certain competency or a special rule that they have to adapt their skills to manage those patients?
We unfortunately in our hospital we have no stoma nurse, but we adjust or we teach some nurses. Or some nurses they have capability to be helpful in the stoma and creation of this one or deal with this one. So we have home care nurses. Sometimes they are visit the home and they are teaching the patient before discharge about how to use or how to remove the bag and how to measure the amount of this one. So the home care, they have good idea and good information about dealing with the stoma. So they can teach the patient, they can teach the relative, and most of the patient, we have to tell him how to deal with the stoma before leaving the hospital.
Okay. Thank you so much, Dr. Masoud. This was quite enlightening and a very nice topic. I think our colleagues who are nurses and engaged with the stoma care, I think they will get benefit of what they have heard today. Thank you very much for you. And we are having another session, Dr. Salim. Okay, okay. Okay. In fact, ladies and gentlemen, today we are going to have a different varieties of topics that touch different varieties of specialty, and with a special focus on the challenge that we encounter in home health care. So I think this will be quite interesting session for all of you, and I would like to urge you to stay tuned with us to enjoy this kind of presentation, which will be highlighted by highly and very meticulously selected speakers. And never, don't forget to pass by the exhibitions so you can get oriented with the different presenting companies that they will tell you exactly what are the different presentations of medications or interventions that we can enhance our capacity to deal with our patients in our challenging home healthcare setup. So we are waiting for Dr. Salim Bazara. He was supposed to be with us virtually, but he decided to come physically. So now he's on the way. So now, ladies and gentlemen, I would like to introduce the next speaker, Dr. Salam Muhammad Bazara. He's a special dear colleagues of mine. We have been going together through a very unique story that changed the career of our prospective profession. We were together in Faculty of Science, and we decided to be a doctors, right? And then we went all the way to a very long career till we settled our dreams and made it come true. So I'm very proud of seeing Dr. Salim, because he always inspired me, in fact, with that mission that was impossible, yet by tawfiq Allah subhanahu wa ta'ala, it became real. So Dr. Salim Bazara, he's assistant professor and consultant gastroenterologist, hepatologist, and interventional endoscopist, College of Medicine, Department of Internal Medicine, GI Division, King Abdulaziz University in Jeddah. He's a director of liver transplant program endoscopy unit, Dr. Salam Faqih Hospital, Jeddah. And he's the chairman of Pharmaceutical and Therapeutic Committee, the PNT Committee, King Abdulaziz University Hospital, since 2009 till today. And he a co-chairman Education Resource Committee for the Canadian Accreditation's King Abdulaziz University School of Medicine. He's also director of Internal Medicine Department, Dr. Suleiman Faqih Hospital, and he's a Saudi physician representative to the Dalhousie University, Halifax in Canada. He has a very inspiring, CV, and I cannot go more than this. In fact, there is many to come, but I will just leave the floor for Dr. Salim to enrich us, in fact, with the topic which is really important, and it's a challenge for us, which is a fatty liver and the liver cirrhosis approach and treatment. So thank you, Dr. Salim, for accepting the invitations, and I'm looking forward to hear from you.
So, السلام عليكم ورحمة الله وبركاته. سعيد صباحكم جميعا وكل خير. شكرا to Amir for all this introduction. We went through a lot, and it's for if any of the young generations here, nothing is impossible in life if you are determined and you took the right routes to it. You will really achieve it. Alhamdulillah. Thank you for the organizing committee for inviting me to contribute to your meeting today. So we'll talk about fatty liver, and it's really one of the very important topics that I want everybody in internal medicine to be aware of. Most of us will see now and then a patient who comes to you and you will tell him there's a fatty liver in the liver, and he will tell you, oh, that's fine. I mean, they told me years ago I have fatty liver, and they told me don't worry about it. No, if anything you're going to change today is make sure it's something to worry about it. It's nothing not to worry about it. Fatty liver is very important. Fatty liver, in few words, basically, it's becoming now the leader cause for liver transplantation in this country and worldwide. So I try to make my lecture as simple as possible. The objective is to project the importance of fatty liver disease in health and its health burden, identify the important risk factors for liver disease, and to review the new diagnostic and therapeutic options available for us. What is fatty liver? NAFL, or non-alcoholic fatty liver, and then called fatty liver disease after that, is basically presence of fat in the liver tissue. That's basically what it is at the beginning. And in that case, you have to exclude any other cause of liver disease. And we will come later to know why is that important. It's a clinical histopathological entity or histological features that resemble alcoholic liver disease, but it occurs in people who are not alcoholic at all. There are two stages of fatty liver. There is the NAFO, the non-alcoholic fatty liver, and then there is the NASH. And the difference is that in the NASH, you already have inflammatory response in the liver. The NAFL is basically where you get fat accumulation in the liver. And then the next process is to get the inflammatory response, which is NASH. And that's where the deterioration starts. Here is the diagram that simply tells us how it progresses. So it starts as a steatosis or fatty liver, which most of people tell you Yeah, a few years ago, I have done ultrasound and I've been told you have fat in your liver, but don't worry about it, it's fine. No, it's not fine. Once you have fat in the liver, the red flag should be raised and we should take care of it. 10 to 20% of those who have a fat in the liver and told don't worry about it, they will progress to have NASH. And when they have NASH, 25 to 50%, they will have fibrosis. And once you have fibrosis, then about 2 to 5% per year, you will go on to cirrhosis and some will go to develop hepatocellular carcinoma. I will not be exaggerating if I tell you that in this month only, 2 cases of HCC, one of them is still in the hospital, simply because of fatty liver. They have no hepatitis C, no hepatitis B. They've simply been told years ago they have fatty liver and now they have HCC. The fatty liver had been taken care of years ago, would have not been reaching this stage. So it is very alarming and very important topic to talk about. Pathogenesis is a bit complicated when it comes to the pathophysiology of how does fatty liver develop. But 2 important things you have to keep in mind. We keep telling fatty liver is only for obese people, but it can also affect the lean people, people who are not obese at all, and that's because of the genetic predisposition. So 7% of the lean people who are slim, healthy, exercising, they may still have fatty liver, and they get astonished and they go cerebral when you tell them you have liver. I'm not obese, but there are genetic predisposition to it. The whole story starts at the insulin resistant, either at the periphery in the adipose tissue or at, sorry, what I did. Do you have a pointer here? Yes. Yeah. So insulin resistance is a very important issue there at the peripheral tissue, at the adipose tissue, or inside the liver itself. Once that cascade started and you have insulin resistance, you will start accumulating triglycerides in the liver tissue. And that's the cornerstone for the whole process. Now, the most acceptable cascade or pathophysiology for this issue is the 2-hit phenomena. And the 2-hit phenomena, the first hit comes in a normal liver where what you have is insulin resistance because of any factor, either because you are genetically predisposed to it or because you have any of the metabolic syndrome that we all know. That will stimulate or start provoke the triglyceride deposition in the liver, and you will get what we call NAFL, which is purely fatty liver. You do ultrasound for any other purpose and you find the fat in your liver. The second hit comes from the gut itself. And in the gut, where we have the gut-derived endotoxins, inflammatory cytokines, all of the stressful inflammatory provoking factors that may hit the liver, which has fat into it, and start to provoke an inflammatory response, and then the NASH start. And once the NASH start, you get inflammation from outside, inflammation from inside the liver, and you end up by having fibrosis. I keep telling my patients in a simple way, it's the same way as you get a burn on your hand and leave scars in your arm or your hand. The same thing happens in the liver. It's inflammation happens in the liver, end up with scarring, and inflammation keeps going on. If you don't do anything to stop it, you will end up by having cirrhosis or having cancer. Simple as that. This is basically the 3 stages in the pathophysiology, where you have fat deposition from triglycerides, and the inflammatory cascade starts, and you get the steatohepatitis or the NASH, and then end up having fibrosis and then cirrhosis. Again, another simple slide to describe what's happening. So you get a normal liver there. You get insulin resistance because of any of the factors we talked about earlier. You get a de novo lipogenesis and start having hepatic lipid accumulation. And if that keeps going on, inflammatory response is going to start by the liver tissue. You get lipoperoxidation, inflammation, and then your Kupffer cells and stellate cells are going to be provoked, and you have fibrosis. And once you have fibrosis, you will end up by having cirrhosis. Now, here, if anything I want to say is that the beauty about fatty liver is that you can reverse it. Humans have done a tremendous job to deal with hepatitis B and C, And it would be now it's like when you hear somebody with hepatitis C, it's like a history. We have done a great job in Saudi Arabia to eradicate it almost completely. We don't see any more Hep C related need for liver transplantation unless they have from long time ago. So C become a history. B, inshallah, very soon will be like the C, a history. Now the main issue for transplant is fatty liver. Epidemiology, the prevalence of NAFL is 14% to 34% in the general population. Biopsy proven NASH occur about 3 to 5% with significant greater prevalence in the obese people, of course. Factors that may be associated with the increased prevalence is obesity, stomach hypertension, dyslipidemia, any of the metabolic syndrome that we know about. Again, epidemiology is a worldwide phenomena and disease. Everywhere you go, you will find it. With the expansion of the fast food all over the world, is becoming another factor that makes it worse. NASH prevalence in Saudi Arabia, unfortunately, the expectation for it to be really almost doubled by 2030. So 2030, we are looking for our dreams and to become true. But in the other side, we are really fighting a bad disease, which is again one of the signs of civilization and changing our habit and our diet. The same thing happened in UAE, in Arab Emirates. They have the same problem as we do. They are expecting doubling of their rate of fatty liver and NASH in the future. Now, what about the presentation clinically? And that's the bad side about NASH or about NAFL, that you don't have really symptoms that they come to you with. And when they have symptoms, it's too late. And that's why it's very important. So you have to pick it up before the symptoms start. Because when they have symptoms, either they have the hepatitis or they have already the fibrosis, or most of them, they are already compensating or having SCC, same as the guy we have in the floor now lying, may Allah ishfi inshallah. So mostly are asymptomatic. Some they may complain of fatigue, malaise, I don't feel myself, I get tired early, which can be a general symptoms and may indicate that it's already they are in the NASH phase. Because in the NAFL, nothing really of symptoms you can pick up in NAFL people. They complain sometimes of right upper quadrant pain, and ultrasound shows fatty liver. And I keep telling them that be assured that this fat has nothing to do with the right upper quadrant pain at all, but the pain was a mercy from Allah for you to pick up that you have fatty liver to take care of it. Hepatomegaly also, and if they have hepatomegaly, that means they have extensive fat accumulation. That's one of the things. And hepatomegaly usually not a symptom, it's something that you may pick as a doctor as a sign, or the ultrasound will raise the alarm. They'll see that they have a bit of big liver. Diagnosis, very simple. Ultrasound can pick it up, and if ultrasound shows what they call change in the echo pattern, and they have a fatty liver infiltration, as a physician, you should put an alarm card in that patient file that you should be followed vigorously and accurately. MRI can even quantify the amount of fat in the liver for us. When I start my training, we used to do liver biopsies, maybe 7 to 10 cases per day for people who have different liver problems. Now, the liver biopsy in the current practice of medicine is not done anymore that frequent, and because of the decrease in the skills, and we don't do them that often, we tend to give them to our radiology colleagues to do it for us, because they can do it ultrasound guided, and that minimizes the risk. But in the time when we started our training, because we do it in daily basis, we just do it a bit side for liver biopsy. It still remains the gold standard for diagnosing fatty liver, but nowadays we only do it if your diagnosis is confused with other diseases. We have something else now that we can do. Do we have liver biopsy on everybody with fatty liver? The answer is no. We don't have that in everybody, unless you're in current practice, because we have some more sophisticated and accurate non-invasive tools to help us diagnose fatty liver, such as the FibroScan. FibroScan is very non-invasive, very simple, same as ultrasound, but different kind of waves that will transmit through the body and go on the liver tissue, and it will give you the stiffness of the liver, and that can be converted in how much fat that you have. There has been so many scores, clinical scores being used to diagnose fatty liver. I think now many of us are now using these scores, and that's because of the fast progress and development of new technical parameters that you can use. So again, elastogram or fibroscan is a very accurate. Actually, it uses the same criteria of diagnosing and staging the fibrosis and the fat as the ISHAG criteria, which is the criteria used in the histopathology staging. So with the fibroscan, you can say I am too close to histopathology when it comes to fat liver or fibrosis. But if you are looking for a cause of your fibrosis, then biopsy is still needed. The same just about illustration of what the mechanism is. This is the tool, actually, small probe, and you have the screen there, and gives you texture of the liver and gives you a stage from F0 to F4, same as HAG criteria. F0 is normal liver. F1 you start to have fibrosis. F2 is intermediate. F3 you are in deep fibrosis, and F4 you are almost at the cirrhosis. It also gives you in a converting equation the amount of fat you have. S1 is 0, S1 is 2, S3, and S4 for steatosis. That's the stage I'm talking about. So F0, F1, F2, F3, F4, and the same for the fat is 0, S1, S2, S3, S4. And by that, you know that your patient has fatty liver, how much fat, or what the stage of fat accumulation he has, and what the degree of fibrosis he has. You can predict from that technique. Why should I care about NAFLD and NASH as a physician, or tomorrow as endocrinologist? Because most of the endocrinologists, they see most of our patients with diabetes and hyperlipidemia, and they are the ones they will be dealing with the fatty liver. And also a general practitioner, you will see most of these people. So why should I care about it? As we said, two-hit hypothesis, and I keep emphasizing the two-hit process or hypothesis, because if you pick the patient at the first hit or in the beginning of the second hit, you can reverse the disease and prevent sequelae such as HCC and cirrhosis. Same cascade, so it's all about lipid and fat consumption in our daily diet. Again, how fast does NASH progress? Studies have been seen that an increase of one stage of fibrosis every 7 years. So if you start having fat in your ultrasound, you did your fibroscan, and you found that is F0, so normal, no fibrosis. In 5 to 7 years, if nothing has been done, you'll find your patient is now F1. And if he's F1, he'll be F2 in 5 to 7 years. So that's why it's very important to pick them early and intervene early. There has been, this is the genetic predisposition. And as I said, obesity, it makes things faster, but even lean people can still have fatty liver if they have the right genetic predisposition to fatty liver. Now, how do I treat fatty liver? Okay, I diagnosed my patient, and diagnosis has become very easy and simple now. I will conclude later about how do I approach my patients when they come with fatty liver. But basically, you treat them, the pillars are the cornerstones for treatment is diet and exercise. Okay, I always tell my patient when they come to me as a referral that there is no magic treatment in earth that will reverse your fatty liver. It's only you who can do it. And that's by diet, exercise, and reduce your weight. If you fail to do that, no medication, no pill in earth that's going to help you at all. The pills only start to help you to do the job, or to protect your liver from the damage of the fat on it to some extent. But if the fat continue to accumulate, there will be no pill to protect it from the damage. So prevention, as we said, cornerstone, very, very important. Diet, exercise, take care of your weight if you are obese. Primary therapy for most patients is weight loss. As we said, weight and obesity is number one alarming and risk factor for it. Lifestyle modification is very important. Studies all over the world have shown that at least if you can take out more than 5% of your body weight, you can really has been shown to reduce your liver fat accumulation. If you can take more than 10%, it has been shown to improve inflammatory immune response. So if you take only 5% of your weight, you are doing fine to reduce your fat. But even if you start to have the NASH or the steatohepatitis, and you can take your weight down by 10%, you can instead even reverse the inflammatory process in your liver. So that's why I keep telling people that lifestyle and fatty liver, you can always reverse it to the last minute. Once you have cirrhosis or you are decompensating, then forget about it. Am I okay on time or you are? Right, so diet rich in polyunsaturated fats is very important, and it has been shown Mediterranean diet has been shown to really help reduce fat, and there has been so many randomized controlled trials to see that if you give people Mediterranean diet or polyunsaturated with compared with other diets, there have been significant reduction in weight and significant reduction in the fat accumulation in the liver. Now, people who add sugar is a killer, and مثل العام اللي بيقول بعد ال40 أو 50 أحذر الأبيضان الملح والسكر. It's really true. Sugar is very killing for us, especially after a certain age, and even added sugars, even the sweeteners with the economy sweeteners is also important. Now, people are crazy now about fruit, and don't forget fruit has fructose in it. And in the media, we all seen these guys who come and try to market that mango and fruits are good for your blood sugar and good for diabetes. I'm sure there are people in the platform here who know more about diabetes than I do. And that's, of course, not true, because fructose is one of the stimulating factors to accumulate triglyceride in the liver. So yes, food are good, but don't go to the extreme with it and don't overuse them. Coffee, there have been some studies that showed that coffee may help reduce your fat accumulation and actually good to suppress the inflammatory response in the liver. Now, we're talking about coffee, not about Starbucks and McDonald's cappuccinos and coffee latte and creams and milk. I mean, that's not coffee, by the way. Coffee is coffee. So if you go and drink cappuccino or coffee latte full of cream and milk and sugar, then the coffee there is just like a spit in the ocean. But we're talking about real coffee here. Coffee is moderate consumption of coffee. It will help to burn out a bit of your fat in the liver, and it may actually suppress the inflammatory process. However, people who have GERD, because I'm also a gastroenterologist, they may have a question about, you tell us don't drink coffee, and now tell us go and drink coffee. So what's the story exactly? Modest use of coffee is very important to everybody. Coffee as a coffee, not coffee sugar, not coffee milk, not coffee with cream. But too much coffee, or the habit that we have here, that we wake up in the morning before we even wash our face, we go to the coffee machine and drink our coffee. That's bad, because that will increase your acid in the stomach, and that will make your GERD worse. So everything Allah have given us in this earth has a good corner and a bad corner, and He gave us a brain to know where we stand. So modest use of coffee, it may be good, but also if you make too much, it may be bad for other part of your body. Intervention therapy, there has been a lot. We talk about a lot, and I talk myself here and internationally about the weight reduction. And every new technique that we invent in earth as humans is a mercy from Allah to help us tackle our disease. So weight reduction, there has been medication, there has been intervention to help us lose weight, but all have a limit to work. Now, when I myself, although I do a lot of bariatric endoscopy, But I think we have been misusing our tools to lose weight in this part of the world compared with any part other of the world. People who are interventionists like me or surgeons, they, of course, because they love doing what they are doing. And if a patient comes to you with obesity, of course, I can offer you a surgery tomorrow. But is that the right approach? If I've been asked it, no, it's the wrong approach. And I think people with obesity, they should start from a dietitian. And then after 6 months of tackling them, they should be screened by the dietitian. Are they good for intervention or not? And if they are good, then they go to endoscopy intervention or to go to the surgeon. Because they come to a surgeon, what you know is to cut and close. If you go to endoscopy who have intervention, the same thing, we have intervention to use, and the patients are eager and don't do it. They will tell you, yeah, doctor, khalas, and I gave up, I've been trying. And I've been trying, he hasn't been trying at all. If he stop, go on diet for a week or two, he's sick and want to stop. And this is the failure. That's why we have all the new maneuvers of weight loss intervention in this country, but still we have the highest risk of failure to maintain our weight after intervention because of poor education to the patient. What is this intervention supposed to do to you? And I am one of these people in the same boat, but it's a really very, very high challenge for everybody. Medication, the same thing. I'm sure you guys know about more of the medication available, the Victoza, the Saxenda, the Ozempic, all these varieties are there to help us lose weight. Losing weight, very important. On the other hand, as hepatologists, losing weight very fast, it may actually harm your liver. And I keep telling my bariatric surgeon that don't do surgical intervention in people who already have late fibrosis because of fatty liver, because that may put them into decompensation. And we have seen cases like that, they end up with liver failure. Endoscopic intervention, there are again a lot intragastric balloons. There's the endobarrier, which I think I was the only one or one of two people who did endobarrier in this country. It's dramatic improvement for your glycemic control and for the weight as in the same time. It has been paused internationally because they are trying to modify the device, and we're waiting for it to come back. Endoscopic sleeve, again, because the surgical colleagues will cut the stomach. We endoscopy don't cut it. We just take it inside and suture it. And again, as I said, these all tools are a mercy from Allah for us to tackle our diseases, but there are certain indications we should not abuse them, because if you abuse them, you end up with high failure. And if you get high failure, then there's no point for them. There has been a lot of literature to indicate how effective are these interventions to reduce the steatohepatitis stage and the fatty liver. Surgical, as we said, gastric bypass and gastric sleeve. Again, a lot of literature have proven their efficacy in tackling the fatty liver and NASH. However, as we said, that the surgical, they usually have very fast weight loss. And if your patient is at late stage of fibrosis, then there is a good chance he may end up with decompensation and liver failure. Medication proven, that when we talk about medication that may help lose weight. Now, medication that you may use for people who have fatty liver or NASH. Now, the role of the medication when it comes to fatty liver per se only comes if your patient is in the NASH. Now, how would I know if my patient is NASH or fatty? If the patient ultrasound says he has a fatty liver, but liver enzymes are normal and there are no signs of fibrosis. Now, don't get deceived by normal liver enzymes, and we struggle a lot with the insurance colleagues. Liver enzymes are normal. Why you want a fibroscan? The fibroscan, the patient may have liver enzymes normal, but he has already cirrhosis. So he doesn't have any more hepatocytes to burn to give me liver enzyme elevation. So fibroscan is still important once you have a fat, because I want to quantify the fat and I want to quantify the degree of fibrosis. Now, if the patient has inflammatory process, so if the patient is cirrhotic already, then forget about the medication. You're not going to help him. Okay, if the patient has a fatty liver, liver enzymes are normal, and the fibroscan says if zero, again, the medication not going to help him. So when are your medication going to help? The vitamin E and other medication, they're only going to help if the patient has a fatty liver, he has liver enzyme elevation, and maybe F1 or FT fibrosis. What they do, vitamin E and also deoxycholic acid, they just protect the hepatocyte from the irritation of the fat and reverse the inflammatory process and give the patient chance to work on his fat to improve his problem. Again, for orthofolic and silymarin, same efficacy, only for hepatocyte protection, nothing more. This insulin sensitizers, again, they have shown that they can improve liver enzyme profile in NASH people if they are obese and diabetes. Obticholic acid, the same thing, it's only a protection. Now, when do I refer my patient to hepatologist? If I am a general practitioner or even endocrinologist and I have a patient with fatty liver. If you can deal with them and you have the capacity in your clinic to follow them, if they are only fatty liver on the liver and you did your fibroscan, you send them for the hepatologist for fibroscan and he told you he's only F0, liver enzymes are normal, you can still follow them. But if your patient has any degree of fibrosis on fibroscan or have liver enzyme elevation, please send him to hepatologist. It's very important you and him to follow the patient parallel. So in summary, NAFL is a leading cause of cryptogenic liver cirrhosis. Cryptogenic, before people who are non-B, non-C, we call them a cryptogenic liver cirrhosis. Now we know that 80% of these people are actually because of fatty liver. It is of a growing economic and health burden for sure worldwide and more in our community. Prevention is the key factor for these people, and early detection is very important with the multidisciplinary teamwork. Dietitian has to be involved. You as a practitioner or as endocrinologist has to be involved, and your hepatologist has to be involved. Ultrasound should also be done usually. So I recommend to every family physician, general practitioner, endocrinologist, any internal medicine physician, if your patient has obesity, hyperlipidemia, hypertension, or diabetes, or age 45 and above, please do ultrasound, look for fatty liver, even if they have no complaints. If ultrasound tells you they has a fatty liver, send them for fibroscan and check the liver enzymes. One last issue I want to talk in my summary about people who are hyperlipidemic and they have fatty liver and the liver enzymes involvement, they have liver enzyme elevation. The physician, they struggle about statin going to increase my liver enzymes. Patient already have steatohepatitis. What do I do? If your enzymes are less than the 3-fold of the upper limit, please don't stop your statin. They have a role to play in the fatty liver as well. If your enzymes went up 3/4 or more when statin started, then at the time you can say statin is playing a role on my hepatitis. And thank you very much.
Thank you so much, Dr. Salim, for this wonderful presentation. I think all of us has to be referred to you for fibroscan. We have a central obesity and most probably we have a lot of fatty livers. So we have one question here. Tafadali, Doctora. Can we give the mic?
Dr. Bazara, Dr. Huwaid Al-Ashkar, General Surgeon from King Fahd Hospital. My question, we receive a lot of patients with gallstones, and most of them, they have fatty liver. Do we need to send every patient with fatty liver for fibroscan? And is it eligible to be requested by a general surgeon or family physician? Or should be through gastroenterologist?
No, the question is, do we need a fibroscan for every patient going for bariatric surgery?
No.
Yeah.
Any patient with fatty liver discovered through ultrasound for gallstone,
Yeah.
do we need to send him for fibroscan?
Oh, yes.
No. But is it eligible to be requested by a general surgeon, fibroscan? Usually, as I know, fibroscan in our hospital done by the gastroenterologist.
Right. As the surgeon, doctora, once I did my ultrasound for gallstones, and that's the common scenario, by the way. It's the commonest scenario. You go for gallstones, ultrasound, and it comes common as a fatty liver. First of all, the accuracy of ultrasound for fatty liver is very low, by the way. Okay. Now, When you have a fatty liver, my message today, if any one message want to take home with us, don't stop at ultrasound says fatty liver and just dismiss it. It should refer him to the right person. You as a surgeon, you don't have the time for fibroscan and you cannot do it. And if you do it, maybe you cannot interpret it, and that's fine. Send him to a hepatologist to see what the fatty liver is. And this is, I'm not saying it's a guideline, but if I am to be in a committee to set up a guideline for fatty liver in Saudi Arabia, that would be number one. Because the patients we see and the guy I see now in the floor with HCC, this has been told he has fatty liver 30 years ago. Okay, you tell me what this is a lifespan. He's in, no, he ended up with HCC without no B, no C. He's not even diabetic. Been having fatty liver for 30 years and continue to eat Mendi and everything and Semna and then HCC. That's a disaster. That's not the medical care we're looking at 2030. Okay.
Okay, thank you so much. Dr. Salim, you know, the name of the game is insulin resistant for many of our pandemic medical issues, diabetes, dyslipidemia, obesity, on top of it, the fatty liver. So now we have been approached by many patients who are looking for semaglutide or Ozempic for weight reduction. And we implement this kind of concept, you know, for a certain period of time, but there is always a relapse. So what is the future plan? And what is your opinion regarding Sulfad, your expertise, because Sulfad, this is one of the medications that they recommended for fatty liver.
Yes.
So how the family physician, the primary care can depend on this, along with the antioxidants as well, to treat fatty liver?
Yeah, good question, Jeremy. Number one is weight reduction, and I mentioned them in my lecture, all of them. So nobody would say I'm biased for endoscopy. Medication for weight reduction, either the injection, the oral medications, the bariatric surgery, and endoscopy bariatric. My message to all my colleagues, I do bariatric endoscopy, I do endosleep, I do balloons, I do endobarrier. Actually, I was the first one who worked and did 70 cases of endobarrier in this country. And we've been in the news with that. Now, all these interventions, if you do not do them in the proper approach, you're going to end up with a very bad outcome and you're going to stop doing them. And what's the approach? The approach that patient comes to us and they want help to lose weight. And you prescribe them Ozempic or prescribe them whatever you can prescribe, or you go for a balloon, and we all do that. And you don't have maybe enough time to speak to convince them that go do your diet, do your homework first, and come for help. Our problem, we don't do our homework as patients. And we as endocrine or internal medicine, we don't have that much time in our clinic to the patient, listen here, medication are there for you, I can prescribe it, but have you done any effort? They have done zero effort. That's why you give them medication, they respond to medication and they stop it and they relapse. I'll give you more worse than that. They cut their stomach and they come to you, when am I going to be okay to eat like other people? So what's the point of cutting it? You can have left your stomach there and eat like other people. Absolutely. So the concept of why they are doing the medication is not there at all. That's why I think they should start with a dietitian. They start with psychologists. They start to get the inside change first. And then you come to you for the medication or for the balloon or the endobarrier or for the surgeon to cut their stomach. We have the highest number of gastric sleeve in the world maybe. And we have the highest number of relapse after sleep.
Yeah.
Why? Because nobody like us. And if you are in this, I was in Canada, you guys were in Canada and all over the world. If you go for a sleep, that means a journey of 2-3 years to go from dietitian, psychologist to assessment to and then to get your appointment for your gastric sleeve. Here you can go today and cut your stomach tomorrow, no problem. And after 5 years, they come to us. I cut my stomach 5 years, my weight going up now. What's the solution? No other solution. I'm sorry, you are stuck.
Absolutely.
The sulfide is one of the good medication for fatty liver, but the use for it is only for people who have NASH, which means they have fatty liver and the liver enzymes been elevated. It's very excellent drug. You can see dramatic decrease in your enzymes within a month or two.
Well said, Dr. Salim. And in fact, many of our patients who did bariatric surgery, they are a candidate for semaglutide and Ozempic after this. So they are going all the way in a vicious cycle, you know, from time to time. With this, I would like to thank you, Dr. Salim, for this wonderful presentation. And thank you for being with us here today. Thank you. So Ladies and gentlemen, we will have a break for 5 minutes, okay, just to have a refreshment, and we'll be back again to start the next session. Thank you so much.
Assalamu alaikum. Can anyone hear me? Assalamu alaikum. Hello? Alaikum salam.
السلام عليكم ورحمة الله وبركاته. نرحب بكم في اليوم الثاني من أيام مؤتمر سلام الدولي الثاني للرعاية الصحية المنزلية، ونحن الآن في الجلسة السادسة من اليوم الثاني. We are going now to start the sixth session in our conference, and I'm proud to introduce the chairperson of this session, Dr. Maha Al-Ata. Dr. Maha Al-Ata is a well-known figure, and I don't need too much to speak or introduce her in much points, but I want to remind she is a consultant in the family medicine and deputy director of the Family Medicine Scientific Council of the Saudi Commission for Health Specialties. I will keep like this. I will not add more, saving time. Welcome, Dr. Maha. Atfadali.
Assalamu alaikum wa rahmatullahi wa barakatuh. Good morning, everybody. This session, inshallah, it's going to be interesting and very beneficial. It is my pleasure to welcome Dr. Arij Ghazi Matar. She's the founder of Palliative Care Services at King Fahd Armed Forces Hospital, Jeddah. And she was the former program director of Residency Training Program, Medicine Department. She joined King Faisal Specialist Hospital and Research Center till 2021. She has worked at the City Mid Hospital Riyadh till November 2021 as a palliative care medicine consultant and director of the palliative care and home health care services. Dr. Arij has joined the PSMMC at November 2021 till present. It is my honor and pleasure to welcome you, Dr. Arij. Please, the floor is yours. Thank you.
Thank you very much, Dr. Maha. يعطيكم العافية. I hope that my slides as well as my voice are very clear to everyone. Assalamu alaikum wa rahmatullahi wa barakatuh. Good morning, ladies and gentlemen. Are the slides clear?
Please start presentation, please.
I can't move the slides.
Stop sharing and begin sharing again, please.
Sure. Are they clear now?
It's PowerPoint only. So please أبدأ السلايدز من تحت.
They are with me. It's on the PowerPoint slide presentation mode.
Full screen بس نبغاها.
It is full screen. It is full screen with me.
سوي شير سكرين كامل يعني مش للباوربوينت فقط يعني قفلي وابدا شير سكرين للسكرين كامله عشان نقدر نشوفها.
Can you just control it from your side? And whenever I ask you for next, you can just go for the next, please.
طيب, okay.
Thank you. So, Assalamu alaikum wa rahmatullahi wa barakatuh. Good morning, ladies and gentlemen. It's really a delight to present today for the second time in 2 consecutive years in such a great gathering for home healthcare shaping the future. A special thank goes out to Dr. Amir and the scientific committee for the very kind invitation. Next, please. Yeah, keep on that. No, keep on that. Abraham Lincoln said, "It's not the years in your life, but the life in your years that matters." And whether we measure life in years or sometimes as for our patients, we measure it in months or weeks or even days. Our goal is always to help patients have the best possible quality of life for as long as possible. And that's what we do in palliative care service as a team. Next. And the goal here is the same for any one of us, to have the best quality of care and best quality of life for as long as possible. And it's especially true when we are dealing with serious illness, whether it's dementia or heart failure or cancer. The question here is, how do we have the best quality of life and how do we fill our years with good life? Next, please. And I want to share with you this metaphor that has to do with the work that we do, and it's about a plane. So just imagine with me that your life is a plane flight, and if your life is a plane flight, you realize that you sort of need a lot of attention from the pilot. And when you first take off, and it's true, when we are born, there is often a need for some medical care, potentially maybe when we take off. But then generally things are pretty smooth flying, a little bit of turbulence here and there. The challenge, of course, is that in modern medicine, we think we can just keep the plane up forever. And we don't think the planes have to land. Of course, we all recognize all the planes have to land. And too often in medicine practice, we ignore the fact that every plane must land, that every life must end. And we think we can just fly the plane around and around. And when the fuel gauge is going down, we are just flying the plane. And then one engine goes down and we're still flying the plane until we are out of fuel and the plane crashes and burns on the ground with the passengers inside. Patients, their families, and their loved ones are usually the casualties of the crash. Next, please. So how much better to savor the flight, and as the fuel gauge goes down, to land the plane gently. And in our field of palliative care, we try to think about how can we bring the plane in for soft and safe landing, and how do we prepare for that landing? So we land at the right airport at the right time and at the right way. And that's metaphor that I find helpful in thinking about the work that we are doing or trying to do in palliative care, and in thinking about what we are trying to achieve, that soft landing in the field that thinks about the soft landing. Next, please. And it turns out when we talk about serious illness, there is good news as well as bad news. Well, let me first give you the good news. And after being flat for all of human history, human lifespan has increased dramatically over the last 100 years. And in year 1900, we lived on average to be aged 55. And today, we live on average to nearly age 80. And that's very tremendous. And this is the good news. So what's the bad news? Well, the bad news is that over this exact same period of time, the death rate has remained remarkably stable at 100%. And I'm sure, of course, you didn't need me to tell you that. But what's less obvious is that while it is true that on average we will live longer, it's also true that we are likely to live some of that time years or decades with serious illness. And when that happens, it's exactly like a plane is plummeting to the ground. Next, please. So the tendency for people with serious illness, their loved ones, even us as physicians and nurses, is to turn away from what's really going on because it's just too sad or difficult to face. We have to do better for each other instead of turning away. We have to find the courage to face reality, no matter how sad or difficult a situation, because patients with serious illness, they know what's going on. Years ago, I met Mona, 58 years old woman with very advanced breast cancer. As I was about to go into Mona's room, her daughter stopped me and she said, "Whatever you do, doctor, please do not tell her that she has cancer." And I could feel the love and the caring that motivated her request. And then I thought, well, what does your mom think she has? I mean, she's been coming to oncology center for the last 3 years, and there is huge sign on the outside of the building that says cancer center. And she reads. When you have a serious illness, you know what's going on. And when you get weaker, you know. When your family gathers from the 4 corners of the earth, you know. But now I got it as a physician. It's out of love and caring that we turn away from reality. And we don't want to make person we care about sad or take away their hope. And I understand the worry that talking about what's really going on will destroy their hope. But guys, in my experience, it doesn't work that way. Next. Hope is very essential, fundamental part of the human experience. And it's the powerful and durable and persistent, even in the darkest of times. It's positive emotion like joy, gratitude, and love, and it makes us feel better. Hope is an antidote to sorrow and despair. And so, if we want to express true love and caring, we have to find the courage to talk about what's really going on, and the courage to talk about hope, because courage means doing what it's hard even when we are afraid. Actually, in fact, we can't really have the courage, or we don't really need it unless we are afraid. And it's exactly and precisely in those moments as the plane is hurtling to the ground and we are afraid of dying, afraid of loss, afraid of future, that we need to find the courage to face reality and to talk about hope with kindness, with compassion, and with empathy and love. Next. One of the challenges we have is that we in healthcare often make it worse when we lack the courage to see what's going on and anticipate for it. Next. In this study, which was published recently 2 years ago about communicating with oncology, communicating oncology prognosis with empathy, they discovered, or they concluded, that the importance of clear communication between healthcare providers and patients with cancer and their caregivers is helping aligning them, understanding the disease prognosis, and then plan for it. Also, they recommended the importance of hope in a realistic conversations about prognosis that necessarily for patients and families in allowing them to make plans and create meaning. And actually, in fact, they voted for a communication tool that serves as a promising mechanism to enhance patient-centered communication about prognosis for patients with incurable cancer. Next. So palliative care, the work that we do, is care that we provide as a team, to team sport, physicians, nurses, social workers, spiritual advisors, and pharmacists, who come together to think how can we provide the best possible care to our patients and their families, and we really provide expertise in 3 areas. Next. Our job, 1, is really around pain and symptoms about shortness of breath, nausea, and fatigue, and how do we help patients feel well in their bodies, recognizing that if we are in pain or if we have nausea, we can't really think about the things that are important. You can't say the goodbyes that really matter to us. And so our expertise really first and foremost is focused on physical symptoms control. And we also realize it beyond that. And once we get beyond symptom control, there is a lot else to think about and to talk about. Next. And the other expertise that we are expert in is to bring to bear is in how we talk with patients. How do we understand what is that somebody really wants and what's important to us as we face end of life and imminent death? What are the decisions we want to make? What are the treatments? What are the right for us? And when we talk about these treatments, we think of them not only in terms of medical care, but in terms of a whole person, the entire person within the context of our life. And this is the true definition of empathy. Next. And then we think about how do we provide support, how do we provide social support, psychological support, spiritual support, recognizing that illness and the end of life is not a biological process exclusively. It really is a process that we all go through in many different ways with many different experiences. You think about the heart, the mind, the soul, the spirit, and that's why we practice as a team in order to address all these issues for patients with families. And now, if we provide care like that, that's really focused on symptoms and taking away pain and shortness of breath and helping patients make decisions that are really important to them and supporting them in that way, does it make difference? Next, please. And I'm glad and pleased to be able to tell you that it makes a tremendous difference. And that's being studied in other places in multiple literatures. And for example, in this study, they enrolled, which was published 10 years ago, it's kind of old study, but it's very important because it's built up the basic of the importance of palliative care involvement for such patients. So in this study, they enrolled 151 patients with metastatic lung cancer, which is a serious illness at that time. And patients with this illness lived on average of for 9 months with treatment. And all the patients on the study received the state-of-the-art chemotherapy. And then half of the patients were randomly assigned to receive palliative care in addition and alongside the chemotherapy. So what did they find? They found that everything good we want to have happened to people. They had less pain, less shortness of breath, they had less depression, they had a better quality of life, happened to the people who received palliative care in addition to and alongside the chemotherapy. And the patients who received palliative care lived longer on average by 3 months a year versus 9 months for patients who received chemotherapy alone. And fortunately, today we have treatment for lung cancer and many other illnesses that help patients live longer and better. And now treatment are on the horizon. But the basic finding for this study remain the same. Palliative care helps patients with serious illness to live better. And we often think there is a trade-off between quality and quantity of life. And what we are finding is that quality produces quantity of life, and that is not a trade-off. And any thought that there is a trade-off is really a false trade-off, because we can achieve both. Next, please. Isa was a devoting, loving husband and father of 2 kids, 9-year-old daughter and 8-year-old son. I've known him for the last 14 years in health and sickness, and I was privileged to be his palliative physicians conducting home care in the last 10 months of his life. He was in his late 40s when he was diagnosed to have renal cell carcinoma with liver metastasis. And when he approached palliative stage, I talked to him about what exactly important to you. What do you hope will happen? And he said, well, I want to show my kids the snow and teach them a basic snow skiing sport. And I haven't seen my brother or his kids in a long time, and I wish to visit. And I wish to perform Hajj before my death. And we talked about that in terms of his treatment. What did this mean for his immunotherapy that he was thinking about? And the more we talk about, we realized that it was better to go first to make all the trips, because it is highly possible that the combined immunotherapy would make him so sick that he could not achieve his wish. And his oncologist was supportive. And it wasn't about whether the tumor had a certain genetic profile, and it wasn't about where exactly it had spread. And it was really trying to understand what was important to him as an individual. And we think about it in the ultimate, in personalized medicine. And this is very important concept. We need to think about how to personalize our medicine practice, because it's directed at the person, at the whole person, and not just as a disease. Next. And it was very beautiful that Isa got to achieve the things he most hoped for. Next. And because we not only had the courage to ask about hope, but when Isa told us what was the most important, next, we had the courage to say, if that's what's important, we have to do so now. Next. And if Isa thinks he's gonna make it, and we think he's not gonna make it, then what he has is not a true hope. It's a kind of false hope. And false hope is no hope, because it's not based in reality. And you might wonder, oh, what's the harm of a little false hope. I mean, let him believe that it's gonna make it. The harm actually is that we squander our time, that we pursue and accept treatments that are more likely to hurt than help. And most importantly, that we miss the opportunity to achieve what is possible. We have to be in a realistic hope business, the true hope business, because while we may not be able to achieve all of our hopes in the face of serious illness, there are many hopes that we can achieve, like performing Umrah or visiting a hometown, knowing that we can experience joy, gratitude, and love. And when time comes, we can hope to land the plane gently. Next. Margaret Mead was giving a lecture, and at the end of the lecture, someone raised a hand and said, asking her, what is the earliest sign of civilization? And abruptly, she said, a healed femur. Femur? And is it a sign of civilization? Person was very curious. How is that a sign of civilization? And then she explained, 15,000 years ago, if you broke your femur, you would die unless a community took care of you. And that's in order to survive the 6 to 10 weeks would take to heal that fracture. You needed to be cared for by a community. They needed to protect you from predators. They needed to provide you with food and shelter. And it's that caring for each other that is the first demonstration of civilization. Next. Looking in our society, the sign of civilization was clearly demonstrated and consolidated more than 1400 years ago, when Prophet Muhammad, peace be upon him, said, you see the believers as regards their being merciful among themselves and showing love among themselves and being kind, resembling one body, so that if any part of the body is not well, then the whole body shares the sleeplessness and fever with it. Next. And when I think about palliative care and how we take care of each other, how we take care of patients who are seriously ill, approaching end of life and death, I think that the important word in palliative care is actually the care part. And that's how we care for each other matters tremendously to each of us. It matters to our institutions. It matters to our society. And we think about that in the work that we do on daily basis. We think how we can take care of each other in a way that provide comfort, dignity, and meanings. How can we do that even in the face of serious illness by having the courage to face reality and the courage to talk about hope? All our hopes, because that at any time in our lives, we have to remember that it's our hope that makes us who we are, our hope that reminds us of what's important, and that hope will never die. And by this, I conclude my presentation. Thank you very much. Next.
Thank you so much, Dr. Arij, and thank you for stating that palliative care, it's a multidisciplinary teamwork, and you work together to achieve a quality of life for the patient and his relatives, so the journey could be better. Thank you so much. It is my honor and pleasure to welcome my friend, Dr. Ashraf Amir. He is one of the foremost and pillars of family medicine at the IMC. He's the chief medical advisor and for time management group, but I wanted to say something else before that. He is the executive medical director of the health program at the IMC, and he is the chief medical officer also at the IMC. Dr. Ashraf Amir has so many contributions and membership related to family medicine and other aspects of medicine. It is my honor, Dr. Ashraf, to present you and joined us for your speech. Thank you.
بسم الله الرحمن الرحيم الحمد لله رب العالمين والصلاة والسلام على سيدنا محمد وعلى آله وصحبه أجمعين. Ladies and gentlemen, dear colleagues, Assalamu alaikum wa rahmatullahi wa barakatuh. First of all, I would like to thank the organizing committee for inviting me here today to talk about a very important topic. And as it was said elegantly by Dr. Arij, what is a sign of civilization? It's a healed femur. I can say the signs of civilization, it's the tsunami of diabetes. So this is what we are going to talk today. فين محاضرتي؟ لا اللي هو ALA ليش ما هي موجودة عندك؟ نزلتوها يا جماعة. ALA اسمها ALA. لا اسمها So all of us, we have agreed, I'm very sure that we will agree on a single statement that says, because of the civilization and modernization, there have been a total transformations of the pattern of disease, in fact. And 50 years, 100 years ago, our medical concern was infectious disease, malaria, cholera, and others. But now, because of the civilization and the modernizations and the way we live, the pattern of disease has been changed to non-communicable disease. And if you just go a little bit along the road to identify that we are going to be hit badly by a tsunami that calls diabetes tsunami. And of course, I would like just to meet the facts that about diabetes remained to be the 9th major cause of death globally. And it was very bad statement, which was stated by the American Diabetes Federations, that stated that the Kingdom of Saudi Arabia, one of the top 10 countries globally for the high prevalence of diabetes. This was in 2015 and 17 as well. 50% of the patients with type 2 diabetes, they have a macrovascular complication. So they die because of diabetes. And out of 10 patients with diabetes, 8 of them, they die because of the cardiovascular mortality and morbidity. 27%, they have a microvascular complications. So they have retinopathy, nephropathy, and diabetic peripheral neuropathy. 25%, they have diabetic kidney disease. That's why majority of our patients with diabetes in our society, they are in all the way down the road to chronic kidney disease. Ultimately, they need a dialysis and they need a kidney transplant, and they are in a queue. Out of 10, 8 of our patients with diabetes, they die because of the cardiovascular disease. And diabetic neuropathy is the leading cause for non-traumatic amputations of lower limb extremities in the kingdom after road traffic accidents. So definitely, ladies and gentlemen, we have demonstrated a total failure in managing our patients by the current practice of our medical professions as a family physician or even as a general practitioners and even by a subspecialty. But the good news that we have been bombarded by a lot of medications that has been kept on the table for us to be a different varieties of choices to manage patients with diabetes. So we have sulfonylurea, we have metformins, we have SGLT2, we have GLP-1, we have small molecules of insulins. More than 38 different molecules has been given to us in the past 10 to 15 years. But what happens? Did we achieve the goal? We did not achieve the goal, and still the hemoglobin A1C below 7 is just only 50% in the highly sophisticated countries, and in our country, in the Kingdom of Saudi Arabia, it's just only 37%. Those patients with diabetes, they have reached the target goal. So we did not do good for our patients. So if you just look into the prevalence, how much we achieved of controlling diabetes across the globe, let's go to Dr. Saud Al-Sifri, our colleagues in Taif. He did a survey and he found that in the Kingdom of Saudi Arabia, we have our patient majority and the mean perceptions of hemoglobin A1C is 9.7, while we know very clearly that it should be between 6.5 and 7%. And we know for fact that each 1% reduction in hemoglobin A1C is always associated by 37% reductions in the microvascular complication, as if we are protecting our patients from diabetic peripheral neuropathy, kidney disease, and even retinopathy. But unfortunately, we have a lot of complications of diabetes, as we know. So diabetes could do a stroke. It could be cause for diabetic retinopathy, and it's one of the leading cause for blindness, as well as we said, cardiovascular mortality enhanced with patients with diabetes. And there is a diabetic nephropathy where there is a lot of patients in the end-stage renal disease. And the most important part, which I'm going to highlight today, is diabetic neuropathy. And unfortunately, I can say it clearly, ladies and gentlemen, that this is the forgotten complication of diabetes most of the time by all of us as physicians. We care for the heart, we care for the kidney, we care for the eye, but we always forget that there is an important organ that has to be taken the same concern and same care of us as a physician to take care of us. So when we talk about diabetic peripheral neuropathy, we have to identify what is the definitions of pain. Pain is defined as unpleasant sensory and emotional experience. So there is a perception, sensory perception, and there is a social and emotional perceptions in bad quality of life because of the pain. So what is the neuropathic pain? Is it the regular pain that we have? No, because the usual pain that we encounter is, we call it nociceptive pain. So there should be a noxious stimulus. There should be an injury to the bodies, then we can have the perception of pain. But the one we are going to talk today is the neuropathic pain. This is another type of pain that usually caused by a primary or even a secondary dysfunctions of the nervous system. And that's why it's very important to differentiate between both of these two pains, because this is one of the pitfalls for most of our physicians when they treat neuropathic pain with non-steroidal anti-inflammatory, which will never work and subject the patient for uncontrolled pain. So nociceptive pain is usually like pain due to inflammation, due to osteoarthritis, due to fracture, and usually is aching and throbbing pain. And usually we treat it with non-steroidal anti-inflammatory. But the neuropathic pain that I'm talking today is usually we perceive it in patients with diabetes, patients with the post-herpetic neuralgia, patients who have stroke, patients who have spinal cord injuries. So the categories of patients that they might have this kind of pain. How the patient represent this? They usually come and say, we have a burning sensation, we have a tingling sensations, we have pins and pricks, we have electrical shocks. And this is the main prescriptions of most of the patients. And usually, most of the time, when you look to the feet of the patients or to the pain organ where the patient complain of, is obviously healthy. There is no injuries at all. And so this is one of the things that we usually encounter as a challenging point. So we have to know that neuropathic pain could be central neuropathic pain or could be peripheral neuropathic pain. Central, like multiple sclerosis, like pain after stroke, but this is not our issue now today. Today we are focusing on the peripheral one, like those who are in chemotherapy, or those who have amputated lower extremities and they have phantom leg, or diabetic peripheral neuropathy. So these are the fibers that we usually encounter in pain. So we have to focus on the small fibers, which is C fibers and A delta fibers. They are very minute types of fibers that get damaged by the glucotoxicity, and it get affected, and usually it get necrotized, and ultimately the functionality of that particular pain will be lost, and ultimately the patient will get into diabetic peripheral neuropathy. So the peripheral diabetic neuropathy types, we have a sensory neuropathy, the one we usually encounter with our patient, the lower extremities, when they come and complain of burning. It could be a motor neuropathy when there is a wasting of the intrinsic muscles of the foot. And this is another stage, an advanced stage of diabetes. But the very severe stage of progression of diabetes towards complete involvement of the nervous system is the autonomic nervous system, when there will be atrophy of the skin and dry and brittle toenails and claw toes, and even charcot joints is one of the causes for autonomic neuropathy. So this is the examples of the neuropathic pains. We have post-herpetic neuralgia, almost 80%, 8% of the patient with herpes also, they get post-herpetic neuralgia. And now we are running a campaign to educate our elderly patients and those patients who are above the age of 50 to receive the herpes zoster vaccinations. Painful diabetic peripheral neuropathy is 26%, and there is other types of neuropathic pain. So this is the early detections of diabetic peripheral neuropathy is very important for us. Why? Because we don't want to get our patient landed up with this diabetic foot ulcer, and ultimately amputation will be the end result of this. So why it is a challenging type of pain? Why? First, because it's very common. About 20 to 50% of our pain in the clinic because of diabetic peripheral neuropathy. It has a multiple physiology. It could be central or peripheral. It has a lesion, maybe peripheral or central, and it's experienced by the patient by a part which usually looks fine. And the patient, we usually ignore the patient concern, and we don't believe the patient. We say the patient is malingering. No, he has the pain, but he's not, we are not in a position to appreciate it. And it is a chronic and severe. So the patient lives with this type of pain for a long period of time. And it's associated with disability, because at the end of the road, the patient will be having charcot joint, and he will be depressed, anxious, and ultimately the quality of life will be quietly disturbed. So the neuropathic pain in the Kingdom of Saudi Arabia, I'm very sure that all of us will never be able to treat diabetic peripheral neuropathy unless we know how big is the problem that we are encountering. So this is a very important identification, that it is, unfortunately, it is undertreated, mistreated, underdiagnosed, badly diagnosed, or even not treated appropriately. And it's usually associated by disability, poorly treated. And the risk of the foot ulcer for those patients, it's reached up to 34%. If we don't jump on this problem on timely manner, we are going to have the patients with diabetic foot ulcer. 15% of diabetic foot ulcer, they don't heal, whatever you do, because of the glycemic control and because of the other comorbidity which is usually associated with patients. And unfortunately, the result in 20% of hospital administrations. And now we are talking about the value-based healthcare. We have to optimize, we have to use our resources efficiently. There should be no waste of resources. So if I get a patient who have uncontrolled diabetes with a diabetic foot ulcer admitted at hospital, I'm not utilizing the resources at the hospital perfectly. Why? Because I did not prevent this from happening at the early stage. Halawa in 2010, he identified that majority of our patients with diabetes, 65% of them, they have a diabetic peripheral neuropathy. So it's a huge number of patients that we should encounter. But there is a difference between the Middle East and the Western populations in the way they presented with a painful neuropathy. So you can see here in Halawa, in diabetic neuropathy, it's almost 65% in the kingdom in the Kingdom of Saudi Arabia, while diabetic peripheral neuropathy in the Western region just only 15%. There is a lot of confounders for this. The way we manage patients, the way the patient perceive their problems, and the shared understanding. And the problem, we failed to convert the patient from inert, inactive patient into active, proactive, interactive patients. So this is our role to manage our patients. So these are the pathophysiology. Why there is a lot of perceptions of pain in patients with diabetes, because there is a peripheral neuron hyperexcitability. So the neuron lost its potential to regulate the pulses, electrical discharges, and that's why it lost control. So there is a hyperexcitability or loss or inhibition control, or it could be a central neuron. And ultimately, all of them, they will lead to abnormal discharge of electrical discharge, and ultimately the patient will have neuropathic pain. I don't want to tackle this point, but I would like just to summarize this slide. The name of the game in hyperglycemia is glucose toxicity that damage all the nerve endings by increasing the nerve sorbitol and decrease the nerve sodium and potassium and causes the signs and symptoms of neuropathy. So this is, we thought long time ago that if we just tackle the diabetes and control it, we are going to prevent diabetic foot ulcer and diabetic neuropathy. It was totally wrong. Why? Because this slide, which has with this presentation, this trial, which was published in New Journal of Medicine, England of Medicine, they found that there is another confounders like hypertension, dyslipidemia, obesity, smoking. All this confounded has to be tackled as one package for this patient in order to manage the problem effectively. So how to diagnose, ladies and gentlemen, this always remember the patient have a signs of burning sensation, tingling sensation, pins and needles, electrical shock, starting from the lower extremities all the way up. So sign and symptoms progress from the distal, proximal over the time upward. So that's why many of our patients, they get into the stage where they have a stocking and gloves distribution of neuropathic pain. So what are the positive sensory symptoms? I just want you to remember it's hyperexcitability, but just forget about everything about hyperexcitability and just remember something we call allodynia. Allodynia is a perception of pain by a stimulus which usually do not provoke pain. So I remember one of my patients, he came to me, he said, "Doctor, if something touched my fingers by a linen or a carpet or something, I cry after screaming because if this is perception of a pain, which usually doesn't provoke pain." Or some of the patients, they came and said, if the wind just passed by my hair or by my feet, I feel extensive pain. So this is allodynia, and this is one of the very important signs of neuropathic pain. But of course, down the road, the patient will develop from hyperexcitability to hypoexcitability, and the patient will get into hyposthesia, anesthesia, complete loss of the sensation in the lower extremities, and ultimately the patient will have this kind of symptoms. Burning sensation, tingling sensation, shooting, electrical shock, and numbness. And this was highlighted by Halawa, and he mentioned that 68% of our patients in the Kingdom of Saudi Arabia with diabetic peripheral neuropathy, they have a burning sensation. So once the patient comes to you and say burning sensation, keep in your mind this could be most probably diabetic peripheral neuropathy. 66% they have numbness and so forth. So the problem is not all about pain. The pain and its consequences in spoiling and damaging the quality of life, the sleep, the interest in life, and even subject the patient for mental disorder in terms of depression and anxiety. And that's why this is the graph will show how the usual day-to-day activity has been totally impaired by the patient who doesn't sleep, who doesn't focus, he doesn't enjoy the life, he doesn't have any social activities. And that's why when we put the goal for assessment of patients, we have to achieve the diagnosis of pain. We have to diagnose the first, is it susceptible pain or a neuropathic pain? And then we identify the comorbidities and treat other comorbidities like hypertension, dyslipidemia, obesity, smoking, and evaluate the psychosocial factors. All of us as a family physicians, we know that the impact of the problem, not only from the physical part, but also the psychological and social part. So the package, which is a biopsychosocial model, has to be implemented correctly in this kind of cases. Then set the goal. Usually your goal should be 30 to 50% reduction of pain. And this has been identified to be the most successful percentage of pain management in diabetic peripheral neuropathy. So you have to reach to a shared understanding. Your patient should not understand that if you give the patient medication, he will have 100% reduction. No, 30 to 50% is acceptable, and this is the way to go. In this part of the world, in the Kingdom of Saudi Arabia and nearby countries, we use a screening tool we call DN4 questionnaire, where there is 7 questions. We give it to the patients and 3 physical examination. We do it, and it yield about 90% sensitivity. And this was done by Bouhseira, he's Algerian endocrinologist, in 2005. And that's why if you just use the DN4 and please implement it in your practice, you are in a position to reach up to 70% of your patients are correctly diagnosed with diabetic peripheral neuropathy. So this is the DN4 questionnaire that we usually use, 7 different questions, and then 3 examination. We use the monofilament test in 10 different points to identify the hyposthesia to touch, and we use all of the pinprick to identify the hyposthesia to pinprick, and we use the brush, to identify localized and static allodynia. So we usually use the 3L: listen, look, and locate. Listen to the patient's his complaint, look for the site of the pain, and locate whether this patient has a peripheral neuropathy or some other types of located neurologic deficit. One of the new modalities that has been invented shortly is the conofocal microscopy. This is, we examine the fundus examination, and we can see the different types of the nerves that supply to the cornea is very minute and very delicate. It is almost less in diameter than the C fibers and A delta fibers. So the first signs of diabetic peripheral neuropathy happens in the eye before we appreciate it in the lower extremities. So how to treat and what is the guideline? We usually treat in patient in total. We never fragment the patient into different parts, the legs only. So we have to diagnose, and then we reduce our intention to reduce the pain by 30 to 50%. And we treat the comorbidities, and we treat the underlying cause for diabetes, for example, and we treat the psychology. And of course, we have many drugs. I don't want to bombard you with this, but the management of diabetes peripheral neuropathy is very interesting because it's very unique. We have to identify the pathophysiology. Is it a pathogenetic problem or a symptomatic problem? Most of the medication that we have, it tackles the symptomatic problem. So we relieve the pain, but we never go all the way to treat the root cause of that particular pathology. So that's why in pathogenic problems, we have oxidative stress and we have inflammation. And that's why we have to look for certain medication that work on these two types of mechanism. But if you are interested just to relieve the pain, the neuropathic pain modulators, we have many of them. And of course, one of the things that I would like to highlight it, and it's new, in fact, in our practice, is the alpha-lipoic acid. This is the most well-researched nutrient for peripheral neuropathy, and has been used in the treatment of peripheral neuropathy in Europe for decades. But in our country still did not reach to that particular level of perception by patient and by physician. Alpha-lipoic is a powerful antioxidant and anti-inflammatory as well, that both had fat and water soluble. It attacks the waste product and help recycle other antioxidant and extra cell productions. So this is in Toronto expert panel in 2011. They mandated that antioxidant alpha-lipoic acid was recommended for the pathogenetic treatment. It's not symptomatic treatment, pathogenetic treatment. So you can use both of the modalities. Other guidelines, like the one we had in German, and this was by Don Ziegler. I met him many times, and we are working together in one of the articles. Alpha-lipoic acid is recommended as a pathogenetic treatment in German guidelines in 2018, yet we did not get it in our guidelines in the Kingdom of Saudi Arabia, but we are in the process. So this is one of the trials which has been done as a consensus of Egyptian experts. They have proposed the pathogenesis of the diabetic peripheral neuropathy is not fully understood, and they recommended alpha-lipoic acid to be is the only available option that should be considered. Why? Because it's available, it's cheap, and it's efficacious at the same time. This is one of the studies that showed alpha-lipoic acid was a powerful antioxidant, and clinical trials proven its efficacy. And the conclusion was the combination of therapeutic should be suggestive in patients with the pathogenic and symptomatic. So these two types of modalities we can combine in order to have these benefits. ALA, alpha-lipoic acid, possess a beneficial effect, and ALA potent antioxidant, and this is different studies all over the globe. But the final conclusion was, in summary, the current meta-analysis demonstrate the promising impact of ALA, alpha-lipoic acid administrations, and decrease the inflammatory markers and reduce the CRP, and reduce the interleukin-6 and the TNF as well. So all the inflammatory markers could be suppressed. And this is to show if you use alpha-lipoic acid, there will be a reductions in the work disability score, in the social life disability score, in the family life and disability. So the quality of life will be quietly improved by this. So let's go to the other. So we were talking about the pathogenetic types. Now for the symptomatic treatment, we have the pregabalin, gabapentin, duloxetine, tricyclic antidepressant, and these are the different modalities. And we are very familiar with the use of Lyrica, which is a pregabalin, but the problem is the dizziness and the somnolence and the fall tendencies and so forth. So instead of, and it's one of the control medications that we can still use it, but of course with the combination with alpha-lipoic acid, you might reach a better stage. Duloxetine, which is antidepressant as well. But the problem with the duloxetine that we have to use a lower dose, which is 30 milligrams, which is not available here. This is just to reduce the sense of nausea and vomiting when you start. And then amitriptyline, tricyclic antidepressant, and it's very cautiously you have to select your patients because the cholinergic side effects of the tricyclic antidepressant is quite devastating in elderly patients. And then tramadol and others, opioid. This is one of the guidelines that we have published. This was in 2010. This was the first guideline for the pharmacological treatment of peripheral neuropathy. This is the expert panel. And we came up to conclusion that the first line management is pregabalin, gabapentin, and tricyclic antidepressant. Duloxetine was not there at that time. And the second line was SSI, that duloxetine was in the second line. So the treatment algorithm after diagnosis of patients with diabetic peripheral neuropathy, you use the first line management, which is duloxetine, amitriptyline, and pregabalin, gabapentin, and then you have to keep the patient for at least 6 to 8 weeks on that particular medications, at least for 1 to 2 weeks maximum dose before you go to the second line management. And this is the way we usually go. And then we usually go for combination. There is combo trial where we can use duloxetine and pregabalin and even alpha lipoic acid in different combinations in order to achieve the maximum benefits. This is the national guidelines. In 2013, we published the guidelines along with Ministry of Health, and it was also published based on our previous experience, and it has the same recommendations for the first and the second line management. And then in 2017, in Madrid, we published the do's and don'ts for painful diabetic peripheral neuropathy for the primary care guideline. And I'll urge all of you to look into this article and this manuscript because it summarized the whole expertise and the whole key success to manage your patients with diabetic peripheral neuropathy. So our recommendation, this was the first international recommendation to put the DN4 into recommendation to use it as a screening because we have experienced a very good success by implementing the DN4. And of course, the first line management was pregabalin, duloxetine, tricyclic antidepressant, and duloxetine. So in IMC, we have did an initiative just to capture those patients early stage. So we thought that we did at the first Diabetic Nursing Academy, we involved the nurses. Why? Because we believe in you. Because you are not only the angel of mercy, but you are also an important gatekeeper for our healthcare system. So we educated the nurses in order to identify those patients who are diabetic. So when you are taking the vital signs in the nursing station, you ask the patient, are you a patient with diabetes? And then the process of initiation will be highlighted. So we identify in the patient journey, there is a nurse, there is a patient, and there is a doctor. So what happens? The nurse in the nursing triage will ask the patient, are you a patient with diabetes? And if it's yes. So she will give him the DN4 questionnaire. He will answer the 7 questions. And then the patient will go to the doctor. The doctor will ask the permission to examine the feeds. And then the patients will be examined for the monofilament test, for the tactile allodynia, and for the pain prick. And then once it's positive, so the patient will be diagnosed immediately as a patient with diabetic peripheral neuropathy, using the early intervention as a proper preventions of the late complication. So our role in the management of diabetic peripheral neuropathy is to screen patients with diabetes by using the DN4, and all patients with diabetes should have food examination. Please pay attention to the food, the way you take attention of the heart and the lungs and even the kidneys. And I always ask my patient, I tell them, please take care of your feet the way you take care of your face. So it deserves a lot of attention from both of us. And treat the underlying cause. Never always treat diabetes only or treat only the painful diabetic peripheral neuropathy. Comorbidities has to be treated. And identify the red flags for the patient, refer the patient to neurologist, and educate the patients about the nature of the disease and the expectation that he might encounter while he's. And always remember, we never work alone. We always work as a team. We always work in a multidisciplinary team approach. So that's why we provide the service, which is high quality safety service with highly professional multidisciplinary team in a patient-centric approach, in compassionate, integrated care that yield an outcome to save the patient's life, and ultimately it should be cost effective as well. So with this, ladies and gentlemen, I would like to end my presentation by saying a word. It's not about working hard. It's always about working better. And this is what I'm expecting. Thank you so much.
Shukran, Dr. Ashraf. Really, the lecture was very beneficial, and you said all the management steps for us and for the health team in a nutshell. Thank you so much. It is my honor to present the second chairman for the second session, Dr. Abdullah Al-Ahmadi. He's a consultant and assistant professor of the Department of Family Medicine at King Saud University National Guard. تفضل دكتور عبد الله.
Good morning, everybody. Thank you, Dr. Amaha. It is my pleasure to introduce Dr. Aya Omar Saad. She's a consultant of internal and geriatric medicine at King Faisal Specialist Hospital. She holds a board in both geriatric and internal medicine. She also has another medical board on pharmacy controlled substance and on a board of medicine physician. She is a member of several international society, including the American Delirium Society, the Wound Care Educational Institute, the American Geriatric Society, and a member also of the American College of Physicians. Without further ado, Dr. Aya, please take it away. Thank you.
Assalamu alaikum wa rahmatullahi wa barakatuh, everyone. I hope am I clear? Can you guys hear me? If someone just can give me a clue. Assalamu alaikum.
Yes, Dr. Aya, we can hear you. Thank you so much.
Okay. Thank you very much. Okay. طيب. Assalamu alaikum wa rahmatullahi wa barakatuh. First of all, I would like to extend my thanks and appreciation for Salam for inviting me again and allowing me to participate in their success and in this wonderful conference. Today, I'll be talking about management of anemia in older adults. I have nothing to disclose. And these are my objectives for the talk today. So first, we're going to talk about how common it is to see anemia in older adults. What is the definition, the clinical relevance and impact of anemia with aging, different causes of anemia, and the concept of inflammation, and then our diagnostic approach. And briefly, we'll talk about therapeutic options. It is no surprise to say that anemia is most frequent in older age. The prevalence of anemia actually really depends on where are you looking. If you're looking in the general population and a cohort of older adults above the age of 65, it can reach up to 17%. But if you look in the hospital where we have more sick patients and more sick older adults, you can see the prevalence goes up to 40%. And of course, if you move forward to a nursing home where we have the sick and the frail older adults, you can see the prevalence shoots up high, all the way up to 50%. Now, of course, because we know that the population is aging, we know that the number of anemic patients will be even much higher. This is a graph that shows the prevalence of anemia in both women and men, women in red and men in blue. And you can see here that not only the prevalence of anemia is increasing, the prevalence also is increasing as we advance and progress in years. For instance, here you can see here that in older men above the age of 80, the prevalence can go all the way up to 50%. What is the definition of anemia? According to the WHO threshold, which was established in 1968, anemia is defined as a hemoglobin level below than 13 in men and below than 12 in women. Now, of course, there are some racial differences, and we know that the white men, they would have a higher reference value in order to call them anemic. However, we are still sticking to the WHO thresholds in order to define anemia. What is the optimal hemoglobin with age? Different studies showed correlations between unfavorable outcome and lower hemoglobin level. And some of the studies, for example, here, the cardiovascular health study did show that the optimal hemoglobin concentration for men should be around 13.7, and for women should be around 12.6 in order to have a better survival. Another study showed that in order to avoid hospitalization and mortality, the optimal hemoglobin value for women should be around or between 13 and 15, and for men between 14 and 17. What is the clinical relevance and impact of anemia with aging? Lower hemoglobin levels are the risk factors for all of the following: for cardiovascular diseases, cognitive impairment, insomnia, impaired mood, restricted quality of life or poor quality of life, reduced executive functioning and physical performance of the adults, increased risk of falling and fractures, more frequent hospitalization and longer days in the hospital, and most importantly, there's a accumulating body of evidence that suggests it's a marker of mortality. I apologize for this busy slide, but here you can see several large prospective studies that was done both in the States and Europe that's showing the association between anemia and adverse clinical outcomes. Now, the essential question that we should ask ourselves, which one came first? Is it the egg or the chicken? Is it the anemia that determines this unfavorable outcome, or is the anemia just a surrogate marker for an underlying process such as chronic inflammation and chronic kidney disease? I would say it's the additive effect of both, of the anemia as well as the underlying disorder. We have studies that shows we have highest mortalities in the anemia that is caused by nutritional disorders, chronic renal disease, and chronic inflammation, versus or compared to unexplained anemia alone. Even mild anemia is a relevant prognostic parameter, and in most cases, the anemia is usually a marker of an underlying subclinical disease. So in summary, I would say anemia in older individuals should definitely trigger a workup or trigger your attention and should be taken seriously and hence worked up. Moving to the causes of anemia, in older adults, I would say that according to the pathogenesis and basic mechanism of anemia, I would divide it into three groups. The first anemia is nutritional anemia based on, iron deficiency, folate or vitamin D deficiencies. That's the first group. The second group is anemia developing in the context of a chronic inflammation or chronic disease, such as chronic kidney disease. And then third group would be the unexplained anemia, as well as the clonal anemias. This is a busy table here, but again, it goes through the most important causes or pathologies underlying or causing the anemia. We have chronic inflammatory disease here, such as different rheumatological diseases, such as chronic infectious diseases and chronic inflammation. And here I would like to bring your attention to, osteomyelitis, patients who have chronic wounds, whether it's diabetic foot, diabetic wounds, or even pressure sores, which we see very common in older adults who have these chronic wounds that are definitely consuming a lot from those patients. We have also malignancies, non-hematopoietic malignancies, whether it's GI or outside of the GI. We have endocrine and metabolic causes, such as low erythropoietin, which we see commonly in chronic kidney disease, and thyroid dysfunction, as well as diabetes. Blood loss as well, whether it's from the GI tract or outside the GI tract, is one of the common causes of anemia in older adults. Increased consumption or destructions of the RBCs, whether it's mechanical or non-mechanical, and the nutritional deficiencies, as we mentioned, iron deficiency, vitamin B12, and folate, and so on and so forth. And then, very importantly, in older adults, is drug-induced anemia. whether that because of the toxic effect of the medications, such as chemotherapy, or because of the interaction that we see a lot we know that polypharmacy is very common in older adults, and we see a lot of medication that can either cause affect the absorption of certain nutritional factors, or they can impair the function of both kidneys or liver, which of course can lead into some disease processes that can lead into anemia. Iron deficiency anemia is very common, and I would just like to bring your attention to two things that definitely as we age, there are some physiological changes that happens into our GI tract, which affect the absorption and and availability of iron. And the polypharmacy, as I mentioned, as well as the social isolation, different, I would say, social, psychological and physical causes for decreased oral intake in older adults. This is very common and we see it a lot. The other deficiencies that we see is the vitamin B12 deficiencies and folate. Pernicious anemia is usually a disease of the young, so it's rare to see it in the older adults. We see H. pylori infection rising up in older adults, and using the acid-reducing agents. I'm sure you all know that PPI or H2 blockers are one of the common medications that our older populations are taking. And unfortunately, because they are reducing the acid in the stomach, they are causing or affecting the absorption and manipulation of vitamin B12 specifically. Anemia in the context of chronic inflammation and chronic kidney disease, we see it because of either the reduction in the production of erythropoietin, or because as we age, we have blunted response to the produced erythropoietin. As we age as well, there is an increased uptake and retention of iron by the reticuloendothelial system. And then because of the decreased level of both estrogen and testosterone, we see an increase increase in the expression of hepcidin, which goes in the opposite direction of iron. So we have more hepcidin, we have less iron. And then there is something called eryptosis. This is simply as we age, the plasma membrane of the RBCs get disturbed or changed, and that would trigger phagocytosis of these RBCs. This is a figure here, a diagram that shows all the previous groups that we talked about, the causes or the pathophysiology underlying the anemia in older adults and how they interact among each other. And you have to know from this picture that it's not a one-man show in older adults. It's always multifactorial. We have more than one thing that leads into the disease. This is again a very busy table here that's kind of beyond my expertise as a geriatrician, but it shows you the different clonal changes that happens to the RBCs, which can lead to either clinically significant disease or not. This is something that usually we ask our hematologist colleagues to help with. Now, moving to something that I'm more familiar with as a geriatrician, which is inflammaging. This term was first described by Franceschi in 2000, and it was offered as a potential model to explain the higher prevalence of both anemia and specific age-associated disorders, including sarcopenia, asthenia, weight loss, and frailty. It is described as low-grade pro-inflammatory states that happens with aging and cause immunosenescence. It's characterized by an upregulation, chronic upregulation of the inflammatory immune response, and increase in the levels of certain cytokines like IL-1, IL-6, and tumor necrosis factor. This is a diagram that shows us what happens as we age and how the age and disease, kind of intercept. So as we age, we go through a lot of variable lifelong challenges, which we either interact in two ways, either by having changes in epigenetics, which will lead to eventually senescence, or by adapting in immunoadaptation inflammation. But in general, we are alternating between these two things, and there's always a homeostasis between these two processes. As we age, this turns into inflammation. The inflammation, the end result of the inflammation, either you are having a good response, and which leads to longevity, or unfortunately, you would have the worst part of it, which is having those diseases and which are age related or age specific, like dementia, like chronic kidney diseases, frailty, and so on and so forth. Moving to diagnostic approach. Of course, we have our primary lab evaluation, a complete blood count to look for the hemoglobin, how bad is the anemia. Look at the size of the RBCs by the MCV and MCH. Look at the function of the bone marrow by the reticulocyte count and doing serum electrophoresis. And then moving to find out what is the underlying pathology by checking the ferritin, transferrin, iron levels, vitamin B12, folate, and so on and so forth. Looking at the erythropoietin level, if there is any underlying chronic inflammation by CRP, ESR, LDH, haptoglobin, looking at the function of the kidneys and the liver, creatinine, kidney function, and liver function, as well as thyroid function. And of course, depending on the clinical context and the clinical picture, you might go for further investigation by doing, for example, upper and lower scopes, or by doing further imaging if you are suspecting malignancies. Bone marrow aspiration and biopsy is mandatory, actually, to exclude hematological disorders, including MDS in the older adults. Now, most of the causes of the anemia will be diagnosed by now, 90% by whatever we said previously. However, sometimes we still have those unexplained, unclear etiology anemia, and for those, you would go for advanced, more cytogenetics and molecular testing in order to reach a diagnosis. And sometimes, even with all of that, all of the above, you might not be able to reach a diagnosis. Now, very important thing to keep in mind when we are talking about older adults, every time we have to keep in mind that we need to look at the patient, we need to weigh the risk and the benefits of anything we are doing, of any diagnostic approach, of any therapeutic recommendation. We always need to discuss with the patient and or their family what are the risks of doing so and what is the benefit from doing so. And of course, what is the situation of that patient? What's their goals of care? What's their what's their life expectancy? How bad and what is the burden of that disease on them? How much is it affecting their quality of life? And of course, the other comorbidities. And you have to weigh all of that and discuss it with them before you proceed for further workup. What are the therapeutic options? Management of anemia in older adults really depend on the severity of the anemia, the symptoms of the anemia, how much of the burden of that disease on them, how much is it really affecting their quality of life and their day-to-day activity. And then, of course, it depends on what is the underlying condition, if you're able to identify them. And as I said, patient-related factors, including their life expectancy, their goals of cares, and other comorbidities. Most of the time, anemia is multifactorial. There are several causes that contribute to anemia. So it's not just one pill that will fix it all, unfortunately. And again, before you proceed with anything, please put in your mind that the potential side effects and potential impact of whatever you are doing or whatever you are implementing on those patients. For the iron deficiency anemia, there's a talk after me, so I'm not going to go through that. I'm going to move to anemia with chronic kidney disease. erythropoiesis stimulating agents remain the cornerstone for treating anemia and chronic kidney disease. However, using the same agent for other subtypes of anemia and chronic diseases is still not approved, and the data are limited. I just want to bring your attention that you have to always, if you are using the erythropoietin stimulating agents, you have to keep in mind to keep the hemoglobin levels between 9 and 11.5, because above that, with increased hemoglobin level, there's always the risk of thromboembolic complications. Blood transfusion, this is the first and the most effective option for treating anemia in elder patients, especially if the anemia, only if the anemia is severe and symptomatic. There is no specific cutoff to say when should you go ahead and transfuse. It really depends on the baseline hemoglobin of the patient, and it really depends on the severity of the anemia and how much it is affecting the patient, especially in terms of the oxygen need. And those with chronic with the cardiovascular disease, those who have CHF, you always have to be very careful because blood is a volume. So when you transfuse them, it has to be very slow, and you have to, always you have carefully monitor them, and it has to be unit by unit basis. So you cannot just say 2 units and from the get-go. No, you have to give slowly monitor the patient and see if they still require a further unit, then you can proceed with that. In general, for cardiovascular patients, it's recommended to keep their levels, hemoglobin level around above 9 and around 10 to have a better outcome. So these are my take-home messages. Anemia is a common and frequent issue that we see in older adults, and it's usually multifactorial. A thorough workup is necessary to define the cause of anemia. But again, before you proceed with this thorough workup, look at your patient and decide if you want to proceed or not. The management of anemia really depends on the underlying cause, and inflammation is a very important concept that we need to keep in mind when we are talking about anemia, and it can explain anemia in some senior patients. You should have a lower threshold to refer patients to hematology, as sometimes we have an underlying bone marrow disorders, and sometimes we need to do further advanced workup that can be done by our hematology colleagues. And that's it. Thank you very much. I'm happy to take any questions.
Oh, thank you very much, Dr. Aya, for this nice presentation. Shall we have question now or after the second presentation? Okay. Thank you, Dr.
You're welcome. Thank you.
Yeah, it is I have the pleasure to present the second speaker, Dr. Uthman Omar Radawi. He was graduated from King Abdulaziz University in Jeddah with the honor degree. He holds a fellow of the Royal College of Physicians of Canada, Internal Medicine and Hematology. He has a diploma in American Board of Internal Medicine. He is currently Assistant Professor, Division of Hematology, King Abdulaziz University, Jeddah. He has several international membership, including the Saudi Society of Hematology, the Saudi Society of Blood Disorder, the American Society for Transplant and Cellular Therapy. He received a local and international award, like travel award from the American Society of Hematology. And Dr. Uthman, the floor is yours.
Assalamu alaikum. Shukran, Dr. Abdullah. I was never introduced like this in my life, so it was like a weird feeling. But I think I still am far behind anyone in the room, and I need to work my best. So thank you also, Dr. Aya, for the elegant presentation. Actually, it have risen the bar for me to make a better presentation as well. But I do apologize beforehand if any redundancy happens in my talk, from the previous talk. And I'm also thankful for Salam for having me here actually as well. Very excellent presentations and mind stimulator as well. So today, inshallah, we talk about new approaches in iron deficiency. And I had to make a word that's a hard problem, but the solutions, alhamdulillah, are very soft, inshallah. So objectives for today is actually when to think of anemia, when is the patient just going to tell you I'm anemic, or when actually we need to think about anemia, how we attempt to approach the iron deficiency anemia as part of the anemia workup, and why the iron deficiency happened in this patient. We also want to know to prevent further problems down the road, and what options to give my patient, and who decides who to give the intravenous management for the patient with iron deficiency anemia. So as Dr. Aya mentioned, WHO definitions for anemia, we always know these numbers classically teaching from medical school, different by ages, different by age group. But the numbers are basically from all of our experience, we sense from the CBC, yes, the patient is anemic. This definition is actually, the numbers are actually considered, you consider the ethnicity, as Dr. Aya mentioned, white men have high hemoglobin than others, and also high altitude. So if you have a patient coming from Asir, coming from At-Taif, you expect his hemoglobin to be higher than a patient who's coming from a sea level like Jeddah. Anemia prevalence. So this is WHO, not me. They mentioned that 1 out of 4 would have anemia across the world. So the prevalence is high. Old data though, but this is the Saudi data from 2019 telling us 1 out of 5 in our country would have anemia. Not necessarily iron deficiency anemia. There are other types of anemia. But I would like to update you with the new WHO numbers that they're telling from out of all pregnant women, 40% would have anemia. Out of children less than 5 years, 42% would have anemia. So this is actually a huge number. It needs to be addressed with any visits that a patient would have in your clinic as well. So anemia itself, it's not the disease. You have to investigate what's causing this anemia in particular. Anemia classification, we all know this probably, the size of the RBC, which is the MCV. Is this microcytic, normocytic, macrocytic? Is this inherited or acquired for any environmental physiological cause? Is this hemolysis, for example, immune and immune, and you start to work it up? Is this intravascular or extravascular happening in the spleen? So different variations of classification for anemia. And then it goes to this busy slide. Do you memorize it or not? I hope everyone do, but it's sometimes hard and difficult. But the more you treat patients with anemia, the more you're trained, and you find this approach is too easy for you. So clinical features suggestive of anemia general, we all know this: fatigue, headache, poor concentration, hair fall, which is my get to go, and postural symptoms. So I usually ask the question: لما تصلي وانت ساجد توقف تحس بدوخة؟ فيقول لي ايوه اقول خلاص يلا we will work you up. Dyspnea, chest pain, and there are some causes that are specific to certain type of anemia. Like the patient can present with peripheral numbness, ataxia, like the wobbling gait, geographic tongue, يقول لك لساني فيه له حاجات بيضة غريبة بتكتشف انها ما هي fungal, and then you find out no, it's actually B12 deficiency, and vitiligo. How about iron? Nail spooning, dysphagia, angular stomatitis, يقول لك اطراف فمي بحس انها مشقوقة. بيكا او بايكا، بياكل ثلج، بياكل طين، او حتى المريضه اللي جاتني قبل يومين بتقول لي باكل رز ني. ايش هذا؟ Okay. Once the anemia is actually fixed, you're gonna treat the patient will actually have all these symptoms go away. And also chronic bleeding, epistaxis, vaginal bleeding, so many causes that can come as a cause specific, clinical features. So a very simple approach to diagnose iron deficiency anemia, and it would be a holistic approach as well. First of all, do a CBC. Assalamu alaikum حقي في الكلينيك. فين CBC حقك? So low hemoglobin طبعا, it's anemia. Low MCV, we know this is a microcytic anemia. High RDW, it's an indicator that comes in the CBC. So if you know these weird terminologies that you see or weird acronyms in the CBC, usually a hematologist would have an eagle eye look on it actually. So the RDW would be high platelet count. 1 out of 10 of my consultation to my clinic is basically thrombocytosis, which is a high platelet count. And just fixing the iron deficiency actually fixed the platelet count as well. So iron profile, I know most of us would tend to do only the serum ferritin, but this is only one phase of the whole problem. It's better to do the whole profile together. So serum ferritin, total iron binding capacity, serum iron, and not all labs, like the lab you do work with, do the transferrin saturation, but you actually can do it from a simple calculation by the serum iron over the total iron body capacity multiplied by 100, and the magical number is 15 or 20%. So is iron deficiency the same as iron deficiency anemia? So the patient doesn't suddenly become anemic, but he can be iron deficient, and those also have symptoms. So, oh my God, the slide is not really visible here, but we can see that actually you can start as a normal patient with a normal hemoglobin, normal MCV, and normal ferritin. And then you have NADE, which is no anemia, but iron deficiency. And the hemoglobin is normal, the MCV is almost normal, but the ferritin starts to drop. So the first sign of iron deficiency is do the serum ferritin. Then iron deficiency with microcytic hypochromic, still not anemic. Still the patient is not anemic. It depends when the patient did the CBC. Till he end up having iron deficiency anemia with everything going into the low side. So general anemia features can happen with iron deficiency anemia, but some specific features can happen, like the spooning of the nail, which we call it cholinikia. This is a girl eating mud, actually. So it is common as well in iron deficient patient. Restless leg, that's a guy sleeping with a restless leg. The patient will tell you, my partner does not sleep with me at the same bed because I keep kicking her or kicking him. So this is also a restless leg, and also hair falling as a sign. Special populations, so children population, I would go quickly through most of them. We have our special pregnant ladies, as well ladies in general, and also bariatric surgery population, which is, I would like to bring up attention about them, and also our elderly, which we had a very nice talk about them. So for children, it's the highest incidence. It's a poor diet. They're always a picky eater, or they don't want to eat anymore. So, and most of the time we keep fortifying the food with more iron. They also sometimes have different types of allergies, like cow milk allergy or any kind of allergy. So that will prevent the absorption, good absorption of iron from the diet. This is brought as a nutritional fact from one of the common cornflakes brands that we actually, probably one of us ate it today morning. And it's actually, even the iron there is actually 14 grams out of 100 grams, which is a good percentage of iron in the cornflakes, if you want to eat it. Ladies, definitely, I've just brought the issue of ladies because we need to have a very honest discussion and history taking about their menstrual cycle. So all these questions has to be asked for any lady who you encounter, even if she's coming for a different reason. Because this, in our culture, we tend to shy away from asking these questions. So frequency of period, duration of the loss, how many times she changes her pads, whether the pads get soaked with blood or presence of clots on their sides. But what I found actually very interesting, that once the lady tells me this sentence, I cannot leave the house on those days, this is probably that lady do have iron deficiency anemia. And always keep this friend with you most of the time, even if you have it in your office drawers, tranexamic acid. So 1,500 milligram on heavy bleeding days would keep iron deficiency anemia away from those ladies. Bariatric surgery, it's the common theme going on these days. Even people who do bariatric surgeries, we understand they do not tell the doctor sometimes they had a bariatric surgery in the past, either because they forgot it or because they don't want to disclose the secret. So different types of surgeries. Once you fiddle around with the anatomy of the gastrointestinal tract, expect all these micronutrients. Probably the patient will have a deficiency in them. And this is not going to be shown on the first year or second year or third year, 5 years. Because remember, this person actually who had the surgery was eating very well, right? So he has a very good storage of all these nutrients, and he will lose it after 5 years. So options for therapy, we always tend to say you have a non-pharmacological and you have a pharmacological approach. And I always like the non-pharmacological one. I'm one of those doctors who do not give medication more frequently. So non-pharmacological, stop the bleeding or try to limit the bleeding as much as possible. Improve the diet. Ask the patient, what's your meal? How many meals a day do you finish your meal? What do you have in your meal? Do you mix meat and vegetables or not? And then the pharmacological, we have the two common options are oral iron, IV iron. So iron-rich food, so animal sources are the best. 40 to 50% of the iron in the food, in the animal sources would get absorbed by the human body. If you mix that meat, the animal sources of iron with plants, it will give you a boost of 15% as well. If you add vitamin C, you will go to 60% of iron absorption. So there are many foods rich of vitamin C, any citrus kind of fruit. And I just brought these two for our attention, that these are two labels from a very common meals, or not meals, snacks or semi-snacks taken by our youth and generation. We always, whenever we try to look, we always focus on the calories because this is the common themes these days. But I might, as a hematologist, I look at the iron in those. Sorry if it's not really well shown, but we have the iron in the left one. There is actually 4 milligram in 85 grams. So very little amount of iron, but they write it. It's not there. And also on the other side. So who can guess the food? Who can guess these labels from what type? Chocolate? Yeah, almost close. Yeah, true. So one of them is Indomie and the other one is Oreo. So, and here I actually, I remember what Dr. Aya actually said in the presentation. Basically, the elderly are actually getting neglected. So there's actually a social neglect. And many of the elderly who come to my clinic, by the way, I wanted to be a palliative physician and geriatrician, but انحرفت وصرت hematologist. They actually come with only eating Indomie as their meal every day and night, because the caregiver for them, this is the easiest and quickest way to provide them a meal. So there is a social neglect for our elderly population. I would like to bring that attention. Apparently, and I'm sorry. So for oral iron, we have many brands, many types in the market. If you go over the counter, they will give you different options, different formulations. I would like to bring your attention to a few things. Try to improve the oral iron by taking it 2 hours before the meal. Iron absorption can be reduced by having so many other medications on the board, especially for pregnant ladies. We give her calcium and multivitamins, folic acid. Iron is like thyroxine. It does not like to be combined with other medications. Multivitamin supplement, the one that everyone is selling over the counter, please, they are not used for iron at all. Whatever iron in it, even it's not going to be absorbed. I can tell you this. This is not out of science. This is just out of experience. And avoid taking iron supplement with tea. Tea has a tannic acid and it actually prevents absorption of iron. I'm not telling you do not drink tea, but space it out. So why oral therapy usually fails? Basically because intolerance, or there is inadequate absorption, or the bleeding is higher than the absorption of iron that you have, or probably you have diagnosed iron deficiency in a wrong way. The problem is not iron deficiency. So should I give iron 3 times a day, twice a day, once a day, or every other day, which is every 48 hours? So in the last 5 years, many trials actually has been going on. And most of the results are actually leaning towards giving iron every other day. So you don't need to give it, it's logical to think I have to saturate the iron, giving it 3 times a day, giving it actually every other day. إذا اللفظ يسمح إنك تجوع الجسم للحديد. جوع الجسم للحديد. So once every other day, he will absorb that iron fully. So this is a quick tip. I saw it many times in my clinic. So this is طبعا teeth, okay, which is the only part of the body I don't understand, because ما كانوا يدرسون في الكلية لهم كلية الحالة. But actually, whenever you examine the mouth, you will find it stained with iron. So who can guess where these iron stains came from? So there is actually a new formulation, not new, it's new to me, but there is a formulation in the market called chewable iron. So people can chew the iron. And if they chew the iron without swishing their mouth and spit it out or even drinking it, that iron will stay in the teeth. So even we have to take care of that part as well. So when to think of IV iron? Now we finished with oral iron, when to think of IV iron. So we'll just go through underlined words. So if you have an intolerance, non-compliance, or lack of efficacy to IV iron, if you have a pregnant lady, quickly think of IV iron, please. Would you like to give an oral iron that caused constipation on top of all what she's going through? It's sometimes hard and difficult. And think about it also in the postpartum period. We take care of our pregos during the pregnancy, but after they bled for 6 weeks, no one is actually replacing whatever she bled that time. So also intestinal malabsorption, if you have an inflammatory bowel disease like Crohn's disease, ulcerative colitis, if you have bariatric surgery for sure, if you have the losses that exceeding actually the capacity to absorb. We would like to prevent also blood transfusion. I can tell you, and I'm standing on this podium, the worst medication ever is blood transfusion. So try to avoid blood transfusion as much, and this is coming out of a hematologist. Try to avoid blood transfusion as much as possible, but if needed, please give it, but try to avoid it. One way to avoid blood transfusions frequently is actually giving intravenous iron. And then chronic renal impairment, as Dr. Aya stated. So are all IV irons preparations the same? I have to go quickly, probably. So we have 3 IV iron in the market. We have the Ferinject, the Monofer, and the Ferrosac, all with the scientific name on the left side. And the reason why I brought only those 3 out of the 10 known IV iron formulation, because these are the 3 that are approved from the Saudi FDA. So you can actually use one of those 3. Now let's go to the 3rd column of this table. How many doses usually we need to replete iron in those patients? So for Ferinject, you probably need to bring your patient twice. For Monofer, it's a 1 shot, and inshallah, he will the iron deficiency will get better. And the Ferrosac, which is the common classical one we need to give, it's not even 45. I had a patient yesterday in my clinic has received it for the 10th time, and was not me who prescribed it. So how much IV iron should I be given? We always taught in the school the Ganzuni formula. You measure how much hemoglobin. I didn't have a time even for my exams to remember it, though I should have, but I didn't. So people actually jump and give the simplified way of dosing IV iron. So it depends on your the desired hemoglobin level you want to reach. Sorry, the actual hemoglobin right now, if it's more than 10 or less than 10, you would give those doses of iron. But are these doses achieved by the different preparations of IV iron once or twice? Sometimes no, because Ferrosac, for example, you cannot exceed a 200 milligram mil on the same visit. You have to give it multiple times. Sorry. So even the UK guidelines for iron deficiency in pregnancy, they're stating in the yellow that use the simplified table. Do not try to shy away from the formulas because it's actually difficult to calculate. Even the European consensus for inflammatory bowel disease, they're saying use the simplified way. So it is actually an advice for everyone to use that simplified way. IV iron, so the one on the right side of the screen is actually the old iron. Actually, before we tend to give iron, the red core as it is. And actually, it's logical to think it's even better, give it through the IV as it is, it will be better. Unfortunately, it led to people to die quickly. So we had to cover it with a carbohydrate layer, which is the yellow one, for slow release. And that carbohydrate layer, by the way, it is what is causing hypersensitivity reaction. So we had to go from a 1st generation of IV iron to the 3rd generation, like iron isomaltoside, or the other name, diazomaltose, which is the same as Monofer. So new generation, slow release, nanopart with a good technology that are actually going to achieve results in better way. So there are different molecular properties of IV iron, as I mentioned, and here we're going to go through it, try to go through it quickly. So iron sucrose, which is the 2nd generation of IV iron, we can see actually it will reach the free iron in the body quickly, but then it will go. And the free iron, we do not like it, by the way. It causes a lot of problems. So we want something that is going to be sustainably released, and the newer generation, which is the black and the red ones, they actually go slowly. We tried to think, should I compare different IV preparations against each other? And yes, this is the best way, evidence-based medicine. So we randomized, for example, iron maltoside against iron sucrose, and on the right side of the screen, we can see the blue one is winning through, which is the iron maltoside with a quicker hemoglobin level achievement, quicker serum ferritin improvement, quicker transferrin saturation, and serum iron. But you can see and observe that by week 5 or week 6, they all go together. So if you want, but if you want a faster one, use the newer generation of the IV iron. And the cumulative dose is actually even better you get more iron when you give the new generation. We tried to say, okay, should I give my patient a 1,000 milligram the same visit, or should I extend it or make it less? Because we all tend to use the 200 milligram. Is it suddenly I'm going to give more than 1,000 to my patient? Well, it was randomized. Those who actually received the more than 1,000 at 1 year, which is 52 weeks, 83% of them did not require a repeated IV iron dose. So the more iron you give from a single visit is actually better. So the benefits of one visit would be safety, because remember, it's actually any medication would come with a dariba, with a tax, would come with side effect profile. So if you give it once, it's better. You have less chance of having side effects. You have your time and cost efficient. The IV iron should be given in a controlled setting. It should not be given in the doctor's office. It should happen actually where actually there is an IV room with a crash cart available around. Everyone is controlled and ready to deal with the reactions. It's more effective because, as I said, less likely the patient will come back again for IV iron, and it's more convenient. This is quickly going through the side effects. So before the IV iron administration, like the 1 day before, the patient memory and concentration will be afraid. He will also be anxious. Oh, tomorrow I'm going to get an IV iron treatment. The same day, the staff always, oh, now we have a new patient. Extravasation, you put the line in a different place, okay, and the iron does not go into the veins. It actually goes outside of the vein. It will cause problems, especially hyperpigmentation. Okay, the IV iron has started, and now it's the first 5 minutes. The patient is telling you, I feel my face is red, or I'm having a little bit of muscle sores and pain. This is called Fishbane reaction. Fishbane is actually, it's a name, Stephen Fishbane, he's a nephrologist who saw actually whenever they give a dialysis patient IV iron, they have these same symptoms. What you need to do at that time, stop the IV iron, have a clinical assessment. If there are no signs of anaphylaxis, you can resume with a slower rate of IV iron. Now, what happens after 5 to 30 minutes? There is a chance the patient might develop a severe hypersensitivity reaction, anaphylaxis, and we talk about 3 organs or 3 systems in the body: the breathing, so stridor or wheezing; skin reactions, so flushing all over, redness; and the third one would be even the GI. The patient might even lose control of his bowel and actually have an accident in the room. So if the patient have 2 out of these 3, this is an anaphylactic shock. You have the cash card available. You are trained to do those things. What's the percentage of having these with the more modern medicine? It's actually 1 in 2 million of IV irons injections. We can have these things. With the second generation, the old generation, 1 out of 100, you might have these reactions available. So modern medicine actually has improved the reactions. And here is actually, I will skip this. These are trials, comparing head to head between different IV iron. We can see always the iron isomaltoside in terms of reactions is actually winning. In terms of against another 3rd generation, which is ferric carboxymaltose, actually have less side effect profile. Here, actually, it's a condition called hypophosphatemia. You know the patient, he's calling you after 3 weeks, doctor, since you gave me that IV iron, I'm still having low energy, low things. Please check his phosphate level, and the phosphate level is probably going to be low, and replace it easily with oral supplements, and it's actually going to get better. To end my talk, I'm just asking you, please remember your colleagues, the hematologist, if the oral iron fails, better to call the hematologist, and he will guide you through how to give the IV iron. And moderate to severe anemia with unknown cause, this is not probably not iron deficiency anemia, this is something else. Gastroenterologist, if you think it's a GI bleed; the gynecologist, if there's abnormal uterine bleed; and also the dietitian, nutritionist, because you want to improve their diet. So take home message: is my patient anemic? Do a CBC and iron profile. Is my patient having iron deficiency anemia? Do history and investigation. How should I tackle this? Treat the cause. IV iron is definitely better than oral, and the newer the generation, actually, the less side effect profile. This is a QR code for anemia clinical pathway published by the Saudi Commission of Health. If you'd like, you can take a picture. And by this, I conclude my message, my presentation. Thank you so much.
Thank you very much. Informative, practical, concise, on the spot. Thank you.
الآن طبعا انتهينا من هذه الجلسة وسوف ناخذ بريك for praying and taking lunch. And we will be here back, please, after 45 minutes exactly to start the next session. Thank you. السلام عليكم ورحمة الله وبركاته. مساكم الله بالخير. Good afternoon. I welcome you in this session and I am proud to introduce the chairperson for this session, Dr. Muhammad Saeed Al-Ghamdi. He is a consultant family medicine in the National Guard Hospital in Jeddah. Member of Scientific Council of Family Medicine and a member in Zamzam Society for Health Services. He is the supervisor of health committee in this society. I will Welcome Dr. محمد سعيد الغامدي. اتفضل.
Assalamu alaikum wa rahmatullahi wa barakatuh. I'm honored that to be with you in this conference. And our first speaker is Dr. Zaki Al-Qasimi. Dr. Zaki, he is Vice President of the Western Business Unit at the Health Holding Company. بالعربي شركة جدة القابضة ونائب الرئيس. بالعربي تعطي شوية هيبة أكثر من بالإنجليزي. Dr. Zaki, he is the Primary Healthcare Surveyor and the Saudi Central Board of Accreditation Sibahi, and he is master holder in public health. Welcome, Dr. Zaki. He will talk about the experience of home health care in the new model of health. تفضل Dr. Zaki.
Assalamu alaikum. I would like first to thank Salam Home Healthcare to allow me this opportunity to speak about the transformation and what we are doing in home care in the Vision 2030 and the healthcare transformation. So first, my presentation or my part will be around the Saudi vision for the healthcare, what the new model of care is and what we are doing in the new model of care, and how we are redesigning the healthcare, how we are designing the healthcare, and then we zoom into the new model for the home care. So the vision started with everything started with the Vision 2030 and the three pillars around vibrant society, thriving economy, and ambitious nation. However, we cannot achieve this, the other two, without having with a vibrant society, and we cannot achieve the vibrant society without health and improving the overall health of the people. In our current status, we have burning platforms. We have population that pursue unhealthy lifestyle that led to increase in chronic diseases. Currently, we have 5 million people with chronic disease. We expect the number to reach to 8 to 10 million people with chronic diseases if we do nothing. And that will increase the cost of the healthcare on the system, and also the premature death or preventable deaths due to non-communicable diseases. We are 42nd% of our deaths due to non-communicable diseases, which can be prevented. So the design principles and what is we are doing currently, we want to separate regulation from provision. So Ministry of Health will be pure regulator for the whole ecosystem and super regulator. The provision of care will be done through corporatized entities, and then the funding also will be out of Ministry of Health and will be done through the Center of National Health Insurance. These are the programs that started in the vision, what will drives the whole transformation in healthcare. And it's all related to the people and to the citizens, and how we can help them, from corporatization or model of care, or the governance, the payment, all is directed to how we can help citizens and patients in the ecosystem. Those three will be enabled by the workforce and enabling workforce, leveraging technology, and private and third sector participation. The country was distributed into 20 clusters across the region, and this distribution is based on the population size
access to care and the availability of healthcare services in each region. The main aim of these clusters is to be integrated. So how we can integrate different service layers between in the model to better care for the population. And that is the main focus of what we do. So everything will evolve around the integration. The new model of care introduced 3 service layers. It starts with the activated person at home and how we can empower people to take care of themselves. That person, the activated person, is surrounded by a healthy community that enable people to pursue a healthy lifestyle, and then advance technologies to provide care virtually before going to the classical primary, secondary, tertiary care. All these service layers is integrated through systems of care. We call them the pathways, the disease pathways. So how the chronic care, for example, will be managed across the 6 service layers, what we can provide to the patient at each different stage. And that is how we imagine the care in the future, where people will take care at each and every step of their journey from home to home. So it's the care start at home and end at home as well. In the model of care, there are 42 programs that aim to either enhance the services available or a new service introduced in the system to make sure that we fill the gaps, especially in terms of the integration. Some of them are specific to pathways or systems of care, and some of them are common that support each one of the pathways. And those pathways represent, we think, more than 90% of the service, from prevention, keep well, to last phase of life or the palliative care. Home care is one of the cross-cutting, and it's linked to the resource control center. So how the home care will help the prevention, the planned care, and all other systems of care, because it's a cross-cutting intervention that will help all the pathways. And the mindset that we aim for in the new model of care and in the new system is to shift from hospitals to home, from activity-based system to outcome-based, and from treatment to prevention, from institution to integrated system, from physical building to virtual, and from fragmented care to integrated care, and from a passive recipient to active participants. And I want to focus on the first one, which is we want to shift care outside the facilities, outside hospitals. Whatever we can provide outside hospitals, either in the primary care or virtual or at home, that will be better. And we need to be bold about it, and we need to take aggressive steps to move care and admit patients even at home. In terms of home care, what we have done in the past, and in the past 3 to 5 years, we went into two levels. First, current state assessment, what we have today, and then we link it with the future. And this is the third dimension, which is in each of those interventions or specialty will serve different pathways or different across functionality at certain points. So how we can link home care with rehabilitation and with the long-term care, and how they are linked to the model of care, and then how they are linked to the pathways. So the design principles for the home care is to enhance access to care, and that start from postnatal to palliative. So the whole continuum of care, we need to enhance it. The second is clinical care. So clinical care, whether primary, secondary, tertiary care, what we can provide at home and non-clinical care, the social aspect of the care. Because we are talking about home care, not home health care. Home health care is a subset of a wider care that we can provide. And then we need to make sure that we provide home health care or home care in a multidisciplinary team. And we need to empower patients to take active role in managing themselves and managing their families at home. And the last is to decrease the load on the primary and secondary care. So how we can make sure that our first line of defense is actually the home. It's not the primary care. And when we did that, we analyzed home care with our pathways and the system of care. We found this. So the well-being, wellness at home, primary care at home, hospital at home, rehab at home, or nursing at home, hospice at home. So the whole spectrum again and the continuum. And we benchmark it with internationally with multiple countries. And what we find is there are so many interventions and services can be delivered at home. What we have today in our system, in the Ministry of Health system and most of the private sector system, are around 4 elements, which is the nursing and skilled care, mechanical ventilation, and this is limited, chronic mental illness, and the infusion therapy. Some pocket of excellence you might find more, but the rest are gaps in the system that's not available. And these are the things that we need to either invest in from public sector or from private sector to fill these gaps and to start these activities in the home care services. And how we worked on a pathway for each one of those. So if we took these interventions or services, we built pathways for each one of them. And that pathway, we mean the patient journey. What will happen with the patient since this service start until the end. And this is one example. It's the continued nursing skill care and how it will start, what will happen before the home visit, and how it will end, and how we integrate it with the different pathways and service layers, either last phase or chronic disease or keep well, how we integrate it with digitally with the virtual care, how we integrate it with primary care. So it's a full analysis of how we integrate the whole system around the patient. If the patient at home, that doesn't mean that patient or the healthcare team is isolated from the support of hospitals or primary care or virtual care. And then we need to make sure that we integrate the pathway. If the patient need to go back to urgent care, that is managed through the resource control center. Or if the patient need to go to long-term facility, then that is also available. So how we integrate the whole journey, and we see that person from the holistically, and we manage that from everywhere. And again, my take-home message is this: we need to be bold about it, and we need to shift care outside hospitals. We need, even if we have to, we need to admit patients at home, and there are some benchmark around this. So we need to be bold and aggressive in moving care outside hospitals, outside physical buildings, to patient home. And that's all from my side. Thank you. Dr. Zaki, for your valuable and very mashallah informative presentation. I think the questions and answer it will be at the end. So please keep your questions at the end of the session. Now we have Dr. Alia Zawawi. Dr. Alia Zawawi. Is she here? Virtual? Mashallah. Alia Zawawi, she is a consultant family medicine and senior consultant in Riyadh in National Guard. and Dr. Alia is expert in medical education as well. She is now the Associate Dean of the Continuous Professional Development in National Guard in Riyadh. She will present about the chronic diseases and mashallah, she's now here in front of us. She will talk about experiences in treating chronic kidney diseases. Dr. Alia, please start.
السلام عليكم ورحمة الله وبركاته. الصوت واضح؟
واضح.
Okay. Thank you for having me today, sharing with you tips and tricks in chronic kidney disease in diabetic elderly patients. Is the screen is clear? الشريحة واضحة؟
واضح.
ممتاز.
على سكرين تكبريها شوية عشان تبان.
على سكرين شو؟ أبشر. السكرين شو واضحة الآن؟
أيوة كويس ممتاز.
Okay. So in the upcoming 20 minutes, we're going to talk about how we can identify patients with chronic kidney disease, what it could be the tips and tricks to diagnose such a disease, and how we can stage it, chronic kidney disease related to the diabetes patient, and how we can progress in the follow-up, and what it could be the attritional and multidisciplinary follow-up for the patient. So as you know, by definition, chronic kidney disease can be identified as abnormal kidney structure or function. So it's either one of this, lasting for more than 3 months. Why we said more than 3 months? Because sometimes it can be acute after an infection or after any kind of acute injuries for the kidney. But when we label a patient with chronic kidney disease, that means that it's state date, the function of the kidney function, state date for more than 3 months. What is the indicator that we can diagnose patient with a chronic kidney disease? It's either related to albuminuria, urine sedimentation abnormality, or it could be related to renal images, or the serum electrolyte acid base, or as we know all, the glomerular filtration rate less than 60. And sometimes we consider the gradual decrease because we know that more than 100 is the normal glomerular filtration rate. But once we consider the patient has started to decrease, we have to alert ourselves. But we label the patient for chronic kidney disease if decreased less than 60. So as I mentioned, all related to serum creatinine and albumin, albuminuria, and serum cysteine. What is the clinical presentation patient presented to you with you consider to screen the patient? Because usually patients present to the clinic or even for the home health care visits, when to need to alert ourselves and look for the kidney function or even the image for the function. If a patient hypertension or uncontrolled hypertension, patient presented with edema, pruritus, sometimes elderly presented with unexplained pruritus, it's not related to dry skin, which is the common presentation related to the pruritus or any skin finding. Hiccups, very important for patient presented, and we have to look to the renal cause, uremic symptoms, gross hematuria, and flank pain. What is other clinical presentation? Asymptomatic, it's for routine exam, raising the serum creatinine, hematuria, and abnormal presence of the proteinuria in the urine analysis. As we know that there is no evidence recommend for screen for chronic kidney disease if the patient have no previous illnesses. So we do not screen any patient for kidney disease unless patient non-diabetic, non-hypertensive, elderly, and those who have a first degree relative with a chronic kidney disease, those 4 categories, yes, we do screen them. But as a general recommendation, we don't screen any patient for chronic kidney disease, but most of the patients present with chronic kidney disease, asymptomatic, we should screen them with those 4 categories. What are the stages of chronic disease? As we know that we have a first stage, second stage, third stage, and it's all related to what presented with the patient. So the first stage, what we can say that if a patient has glomerular filtration rate more than 90, so it's started to decrease from the 100, but diagnosed to have chronic illnesses. So this is we can and start to decrease in glomerular filtration rate. So this patient will start to alert us for stage 1. Stage 2, kidney start to have a damage with mildly decrease in the glomerular filtration rate. This is started from 80s to 60 with estimate progression. Stage 3, A and B, those patients start to decrease their glomerular filtration rate less than 60. It's in the range from 50 to 40 and from the 40 to 30. And stage 5 and 4, this is where patients start to be very alert, and this is where we start to share the care with the patient with nephrology if a patient needs to be referred for dialysis. And for the previous stages, and this stage first, for example, 1 and 2, this is what I will come to. We have to make sure which medication patients on. Do we do any harm for the diabetic medication or antihypertensive medication? Do we need to revisit patient medication to stop or change his medication? And this is what is coming in the coming slides. So this is what I mentioned related to the follow-up progression. Patient with a chronic kidney disease, patient should be have a serum hemoglobin at least annually. So we need to test his annually for his hemoglobin. Routine evaluation for bone density should not be performed because a lot of patients, they think they should look it up. And we looked at his glomerular filtration rate. What is the other measures we should include it in the follow-up with a patient with chronic illnesses, with chronic kidney disease? We should look at his serum calcium, phosphorus, parathyroid, because the parathyroid will be affected because of the negative feedback for the kidney, alkaline phos, 25, which is the vitamin level, vitamin D level, 25 hydroxy vitamin D level, because it's affecting the absorption of the calcium and affected by the vitamin D. So why anemia? Anemia is common with the chronic kidney illnesses. So we have to look at the anemia at the hemoglobin level for the patient with chronic kidney disease. And as per definition, it's less than 12 in the female and less than 13 in an adult male. Usually we have to consider to do it annually for stage 3, as I mentioned before, and twice yearly for stage 4 and 5. Iron status should be checked with the ferritin level, not only hemoglobin level, and usually consider the secondary cause for anemia for such a patient. And this is what can we define the patient comparing between the chronic kidney disease patients and anemic deficient, iron deficiency anemia. As you know that it could be related to the chronic illnesses, or it could be related to the chronic kidney disease. So we have to check on the ferritin level, total iron binding capacity, and serum iron. And with the comparison of both, so total iron binding capacity or the ferritin ratio to the total iron binding capacity, it could be show you the difference between the diagnosis. Is this anemia related to the chronic kidney disease, or it's related to iron deficiency anemia? Accordingly, we'll see. When to refer to the nephrology? So what is the indication? And when we said that this patient should be, we need a consult, we need to call the nephrology to take care of this patient with his kidney damage. When his glomerular filtration rate start to be decreased less than 30, persistent urine albumin creatinine ratio more than 300. So that's why we usually have to take care of that ratio early in a stage, not unless we reach that level. The evidence of lipid loss of the kidney function, as I mentioned before, and uncontrolled blood pressure, with blood pressure not responding to his usual medication. As a home health care or family physician, usually we have to consider that multidisciplinary approach for such a complaint. Primary healthcare physician is the primary physician should consider and plan all the follow-up for the patient with a multidisciplinary nephrology, as I mentioned, as needed. Other subspecialty like nutrition and health education. Why it's very important, sometimes forgetting, because the dietary advice is very important for patients with chronic kidney disease, and I will give you the details of that. We have to evaluate and manage common condition. Don't forget, with a chronic kidney disease, you only concentrate what's going on with the glomerular filtration rate and the kidney function. You have to look for the other parameters. Is that the patient diabetic? Which kind of the control of hypoglycemia? Is he hypertensive? Which kind of antihypertensive medication? Nutritional advice is very important. Smoking cessation in such a case. Sometimes we'll forget to check on the smoking level, and if he's heavy smoker, which kind of smoking he is, and we should advise us for smoking cessation in early kidney disease injuries. Exercise advice should be considered in such a patient. Medication review and adjustment according to the glomerular filtration rate. Cardiovascular disease prevention according to the presentation for the patient. Malnutrition, anemia, bone disease, as we mentioned, related to the check on the patient's status. Psychosocial support. Most of our patients, the elderly, home healthcare patients, they have a polypharmacy. Sometimes we are not quite sure who's the caregiver and who's giving the patient medication. We have to double check if the patient take the correct medication at a correct time, not doubling. Sometimes his refill medication give two brand of medication. For example, he's taking AC inhibitor or ARBs, and he went to the pharmacy, or the caregiver went to the pharmacy, they give another medication, but another brand. So we discovered that the patient take Vasartan or Losartan from the different brands, and they give it on the same time. So those, one of the issues is very common when discovered in the follow-up of the patient. One of the important issue, as I mentioned before, related to the nutritional guideline, we have to educate the patient or even his caregiver related to his dietary. Sodium intake, his DASH diet, the fruit, the vegetables, this is very important to consider in a patient with a kidney problem. Dietary protein affecting, and how much of dietary. Sometimes grams is not efficient for the patient indication. We are a physician or care health workers, we know the grams, but at least we can assuming for the patient, and maybe not physician, maybe referral to dietitian can give them the details. So at least half a cup of the protein per day, more reliable, not instead of the gram per kg. So they are calculated for the patient and give them the detail according to his situation. One of the very important things for the chronic kidney issues, and this is one of very important tips for caring of patient with chronic kidney disease, is a sick days medication. Whenever patient have a sick days, for example, he have an upper respiratory tract infection, he have UTI, he is complaining of gastric upset, or he have a diarrhea. So in those days he have a dehydration. So we have to take care of the nephrotoxic medication, and we can hold it just for a couple of days. And this is very important to teach it for healthcare givers, and to introduce them to the list of the medication. If a patient dehydrated, not eating well, he should stop those medication just for a while, couple of days, not for long, and should consider this because it's affecting their kidneys once they are not eating or they are sick. Was those medications, sulfonylurea, ACE inhibitors, diuretics, metformin, ARBs, non-steroidal, and SGLT2 inhibitors, because it's affecting their dehydration once they are dehydrated. Don't forget immunization. Don't forget immunization. For chronic illnesses, chronic kidney disease, diabetic patients, elderly, we have to remind ourselves regarding their vaccines annually. Shingles is once, not annually. Hepatitis is once, not annually. Influenza vaccine annually. And nowadays, if a patient not vaccinated with COVID, we have to consider this and plan it for them, even for the home health care. Just in a summary, life advice is very important for chronic kidney disease: exercise, diet, and weight control. Achieve a good control for comorbidity to achieve a good control for chronic kidney disease by controlling their diabetes and hypertension. SGLT2 medication should be on hold, as well as the other list of the medication once the patient have sickness days. Continue ACE inhibitors as ARS therapy unless serum creatinine is raised, because it's not a contraindication, but we have to consider because some of the patient with chronic kidney disease are in both ARBs and ACE inhibitors. So we have to make sure that do we need the both classes in once, and why, and we have to double check on that. Check the C annually for the patient with a stage 3 kidney disease and twice yearly for stage 4 and 5. Thank you, and I'm welcoming if you have any questions.
Thank you very much, Dr. Alia, for your updated review of the chronic kidney diseases and for keeping in time. We are honored to have the third speaker, Dr. Wafat Tuwajri. Dr. Wafat, she's موضوع عن بعد. She's not
ناخذ discussion مع الاثنين الموجودين.
discussion. She is not ready for the for presentation now, and we have with us now Dr. Zaki and Dr. Alia. So Dr. Alia, she just finished, so let us start by Dr. Alia if there is any questions regarding chronic diseases, kidney, any discussion or questions, Dr. Khalid? Anyone in the floor having questions for Dr. Alia? Right, mashallah. Dr. Zaki, your subject is very, he is the core business in this conference. So we have to have a lot of discussions in this. يلا بسم الله دكتور عبد الحفيظ.
ما عندي شيء.
ما عندك شيء. دكتور خالد. هل في أي إجراءات لتشجيع العمل الخيري لبدء في مشاريع لها علاقة بالرعاية الصحية المنزلية؟
من جهة يعني للأمانة لا زلنا في هذه المرحلة في مرحلة تصميم شكل تقديم الخدمة. في الغالب الخدمة ستقدم عن طريق جهات أخرى، أما عن طريق القطاع الخاص أو القطاع الثالث. طبعا الإجراءات اللي موجودة حاليا هي الإجراءات الحكومية اللي أعطت الأفضلية للقطاع الثالث في التقديم، طالما أنه أو القطاع غير الربحي بالكامل في تقديم الخدمات. إذا كان القطاع غير ربحي منافس فالقطاع الغير ربحي له الأولوية. لكنه للأمانة حتى الآن ما وصلنا إلى مرحلة أنه عندنا شيء جاهز للطرح حتى في تقديم الخدمات الصحية. في كل الأحوال التصميم موجود ومتاح للقطاع الخاص والقطاع الثالث لاستخدامه في الكرنت براكتس في what they do. يعني احنا we can share كل التصميم تبعنا في آلية تقديم الخدمة وتفاصيلها مع القطاع الغير ربحي والقطاع الربحي لاستخدامها في الكرنت براكتس.
طيب السؤال الثاني، معروف الطب الأسرة يرجع في الوزارة أو في إدارة معينة، المستشفيات ترجع نفس إدارة معينة، لكن الهوم هيلث كير لأي إدارة يرجع؟
طبعا هو التصميم الحالي أيضا احنا خرجنا من الإدارات القديمة وصار الجميع يرجع لإدارة واحدة، إدارة تقديم الخدمة الصحية. فالجميع الآن يعود إلى نفس الإدارة في التصميم الجديد. في التصميم الحالي الهوم كير مع إدارة المستشفيات، لكنه في التصميم الجديد الجميع يرجع إلى إدارة واحدة to integrate everything، لأنه الكير should be integrated across the board, across the continuum of care. فالمراكز، المستشفيات، الهوم كير، الفيرتشوال كير كلها حتكون تحت إدارة واحدة، إدارة الرعاية الصحية.
أعتقد الفيرتشوال كير مع الهوم هيلث كير حيخدم كثير موضوع
صحيح
جدا.
والهدف إنه إخراج كل الخدمات الصحية، أو خلينا نقول ما هو الكل، لكن أكثر شيء نقدر نخرجه safely out of the facilities we need to take it out of the facilities.
بارك الله فيكم. الدكتورة جاهزة؟
بس في شوية مشكلة هي موجودة
معنا الدكتورة. طيب في أي أسئلة أخرى عن الهوم هيلث كير؟ فرصة الدكتور معنا ما شاء الله خبير وأيضا مسؤول في شركة جدة القابضة الآن، حتى ممكن تسألوا عن أشياء التحول، ما التحول، ممكن يعطينا معلومات متحولة.
السلام عليكم دكتور زكي. When we can expect that we start the transformation?
احنا already we started يعني
completely the whole يعني picture will appear when.
طبعا الوقت لأنه نشوف يعني the full picture coming all together احنا نقول من 5 ل 7 سنوات، لكنه هذه الرحلة بدأت الآن، وفي نهاية السنة حيكون في big milestone في أن نطلق كل التجمعات في مناطق المملكة كلها، يبدأ تحويل الإشراف على الخدمات الصحية لشركة الصحة القابضة. لكن بعد كده تباعا التجمعات حتخرج إلى أنها كونها تكون شركات حسب جاهزيتها من النواحي المالية والإدارية لأنها تكون شركات. حسب جدولنا الزمني الحالي على الأقل في المنطقة الغربية إلى 2025 حنخرج كل التجمعات بأمر الله، الستة اللي موجودة في المنطقة الغربية. لكنها تسجلني يعني رحلة حناخذ فيها ماتيوريتي معينة لكل التجمعات، خصوصا من النواحي المالية، الاستقلالية المالية، وللإشراف على العمل اليومي، decentralization، الإشراف على العمل اليومي اللي يكون على ليفل التجمعات. كل هذا حياخذ له وقت في building capabilities والكباسيتي في التجمعات.
في عندها صوت الدكتور وفاء بس هي موجودة معنا، صوتها ما قدرت والربط ما تم.
خلاص لازم
خلاص بس نقدمهم. لا بعد سيشن نقول سيشن ثاني نقدم خلاص.
يلا تفضل.
We welcome our third speaker, Dr. Wafat Tuwajri. She is a consultant to family internal medicine, and she is a nephrologist. She's an assistant professor in King Imam Faisal in Dammam, and she finished her training in Canada, and she's now working in hemodialysis and peritoneal dialysis. She will give us update about hemodialysis and peritoneal dialysis at home. Welcome, Dr. Wafa. Can we start? We can see you now. We can see you now, but we need to see
the green screen. مساء الخير دكتورة وفاء. لا يمكن. طيب انت اسمعيني زي ما تشوفي. احنا شايفين المحاضرة الآن، بس اعتقد عندك في مشكلة في الكمبيوتر وفي الظهور. ممكن إذا عندك شير جرين سكرين تشيلي التك اللي عليه. إذا أنت عاملة عليه صح شيليه عشان تظهري، وإلا خلاص نبدأ المحاضرة على طول. وأيضا الصوت ما احنا ما وصلنا ترى. الشامي شبه محمد الله شبه من شبه يقول لكم وصلت الجواب أنتم تلمسان اسمع يعني في جدا بس ما وصل. تفضلي أبدأ المحاضرة، بس الصوت مو مسموع ترى، ما عندنا صوت. بس إذا بتسمعيني ممكن تخرجي بالمرة كامل وترجع مرة ثانية تستخدمي نفس الرابط. يجي بسرعة.
السلام عليكم جميعا. I apologize for the technical difficulty. I just wanted to check, can you hear me now?
نعم.
ممتاز.
Allah يعطيكم العافية جميعا. Allow me first to take this opportunity to thank Dr. Ashraf Amil, Dr. Abdel Hafiz Hoja, and all the organizing committee for giving me the opportunity to speak about such an important topic. Just to start, I have nothing to disclose with any commercial or industrial relationship. During this talk, I'm going to try to go briefly through hemodialysis and peritoneal dialysis, just the basic principles. I'll talk about home hemodialysis epidemiology, and then I'll talk about why was there a decline in home hemodialysis, advantages, and how it can we use to increase the use and to overcome barriers. And I'll talk about current and future landscape of dialysis in Saudi Arabia. First of all, what does dialysis mean? In chemistry, it's the separation of particles in a liquid on the basis of differences in their ability to pass through a membrane. And the medical definition is the clinical purification of blood as a substitute for the normal functioning kidney. Why do we need dialysis? What happens to the kidneys that makes us need dialysis, and what can dialysis do that's an alternative to a normal kidney. So when the kidneys fail, fluids start to accumulate. So dialysis can overcome that by removing excess fluid and treating volume overload. It can also remove uremic toxins, so it can treat uremia. It can help correct acidity by replacing bicarbonate, and it can help us remove excess electrolytes that we don't need, for example, high potassium or hyperphosphatemia. What are the modalities of dialysis that we have nowadays? So we have in-center hemodialysis, we have home hemodialysis, and when we talk about peritoneal dialysis, we have two modalities. We have what we call chronic ambulatory peritoneal dialysis, which is done manually by the patients themselves, and we have automated peritoneal dialysis, which is done by a machine. Just quickly about peritoneal dialysis. In order to perform peritoneal dialysis, a silicone catheter is inserted through the abdominal wall. It can be done by a nephrologist, by interventional radiologist, or laparoscopically by surgeon. And when the catheter is put in, the end of it is left in the pelvic cavity, and we use this catheter to instill dialysate fluid. As you can see here through in the solution bag, it goes in, we leave it there for a few hours, and then we have our normal functioning peritoneum. If you remember from anatomy, the peritoneum is composed of two layers. We have the parietal peritoneum, which lines the abdominal cavity, and then we have the visceral peritoneum, which covers the internal organs. So the peritoneum works as the dialysis membrane here. The toxins, the excess fluid, the excess electrolyte, the excess acidity passes through the peritoneum into the abdominal cavity to a lower concentration in the dialysate. And then we leave it there for a few hours, after which the catheter is opened and the dirty or the used dialysate is emptied, and we call that into the drainage bag, and we call it an effluent. So the peritoneal dialysis can be done in two different ways. Can be done manually by the patient, like you see on the left of the slide. So the patient is sitting, he hangs the dialysate fluid bag on an IV pole and manually instill it through the catheter into the abdominal cavity, leaves it there for a few hours, and then connects to a drainage bag, empties the fluid, and puts a new fresh fluid again. Or it can be done by the use of a machine. At the convenience of sleeping, the patient connects himself to the machine at night, and the whole process of instilling fluid in the abdominal cavity, leaving it there for a few hours, and then emptying it happens by the help of a machine. And the patient can sleep without needing to do it manually. This is just to show you in real life the size of such a machine. So it's a very portable, easy to put on a nightstand next to a bed or a recliner, and it's very user-friendly, and patients find it very easy to use. PD has lots of advantages. It's been shown to be associated with slower decline of residual kidney function, which is an important prognostic factor in end-stage renal disease. Patients on PD, they do peritoneal dialysis every day, which gives them the privilege or the luxury of having less dietary restriction compared to hemodialysis patients. The fact that they can be done at home gives them better quality of life and less interruption of their daily activity and work. And it also gives them more flexibility to work. We have lots of patients on peritoneal dialysis that can travel within the country and outside the country. And all what they need to do is call the dialysis provider, and the PD fluid or the dialysate bags gets delivered to their location, whether it's in Saudi or outside Saudi. And there is some data that shows there might be better survival compared to hemodialysis in the first 1 to 2 years. Who is the ideal candidate for peritoneal dialysis? Usually patients with significant residual kidney function, patients who have no previous abdominal surgery, because if they have previous surgeries, it can lead to adhesions and it can affect the free flowing of the fluid inside the abdominal cavity. There are patients who understand instructions and able to communicate, patients who have sufficient eyesight, manual strength, and dexterity. And if the patient cannot have that, then even their caregiver, it doesn't have to be the patient himself who does it. If he has a caregiver who's willing to help at home, then that's great. And then a suitable environment to store supplies and perform exchanges. And when we choose a candidate for PD, we review lots of things, one of which is if they have pets at home, if they have lots of animals at home. And if they do, we ask them not to allow the pets to go into the room where the PD gets performed. Like, for example, cats, they can bite into the tubing, and that can increase and put patient at risk of infection. But generally speaking, most patients are considered good candidates for PD. And the only absolute barrier to having PD is the lack of a functioning peritoneal membrane. So that's PD. Moving to hemodialysis. Hemodialysis is performed differently. Again, our aim is to clean the blood, but it's done through a different machine. Hemodialysis started in the 1940s. And the way it's done is that the patient blood is taken out of the body, passes through a filter, against dialysate. And this is all done by the help of a hemodialysis machine where the blood pump is put in, it measures the different pressures, it mixes the different electrolytes with the water supply that comes from a central water treatment system. In order to get the blood out of the body to be cleaned, it can be achieved by either having a catheter put in one of the central veins, like the internal jugular vein, for example, or by the use of a synthetic graft that connects the forearm artery to the vein, and by which we can cannulate and obtain blood to go into the machine, or ideally by the creation of an arteriovenous fistula, where the artery and the vein are sutured in an adjacent pattern to create high blood flow in the venous system that we can use into the dialysis machine. Generally speaking, when the word hemodialysis comes to mind, most people think about in-center hemodialysis. And this is what most of us as healthcare practitioners think is the commonest way of doing hemodialysis. Lots of people are surprised when they hear that home hemodialysis exists in Saudi or exists worldwide, while in reality, home hemodialysis actually began in the 1960s. And it was a way to provide dialysis to patients with end-stage renal disease at a time where funding for renal disease health insurance coverage was very limited. So it was a cheaper way and a possible way in a time of limited funds to give patients the opportunity to be dialyzed. Nowadays, home hemodialysis can be done at home by using the two different machine possibilities. So on the left, you see the conventional machine, the machine we're used to seeing it in hospitals. And to use such a machine, extra plumbing, special plumbing needs to be done in the house to create larger water flow. The water then flows into the smaller machine called the reverse osmosis machine, and it's used to purify the blood and purify the water, and then the water goes into the dialysis machine by which the patient can use it. Another available machines that can be used for home hemodialysis are portable low dialysate flow machines where you don't actually need a water supply. You can use pre-mixed dialysate bags, and it's way more portable. The only difference is the patient will need to dialyze more frequently. The patient who dialyzes usually conventionally 3 times a week will need to dialyze at least 5 times a week using the other machine to deliver equivalent clearance and outcomes. Despite the fact that home hemodialysis is an old modality and it's been there since the 60s, since the 60s, there has been major decline in the prevalence and incidence of home hemo. The orange or brown bar here represent home hemodialysis. The blue is PD, and the striped line represents in-center hemodialysis. And as you can see, since the 60s, it's been gradually going down to in the mid-2000s to very low percentages. This is from the US data. What about in an international level? In an international level, this is data looking from 2001 to 2003 across 21 high-income countries. And there's a huge variability, where in countries like Portugal and Iceland, it doesn't even exist. And in countries like Australia and New Zealand, the prevalence of home hemo is almost as similar as peritoneal dialysis, in-center hemodialysis, as well as transplant. So why did this decline happen in the States, and why is this variability between the countries in the prevalence of home hemodialysis? Multiple factors have been investigated, and it's been attributed to age and comorbidities. Like in the past, dialysis used to be only provided to younger patients, and older patients would die early because of comorbidities. But with the improvement in healthcare in general, not only in nephrology, but in the management of diabetes, heart disease, the mean age is increasing. And with that, the comorbidities are increasing, and less patients are willing to do independent home hemodialysis. Also, the improvement of availability of dialysis facilities have led to decrease in home hemo. The invention of peritoneal dialysis did not happen until the 1970s. And more patients were leaning towards PD rather than home hemo. The success of renal transplant, cadaveric, more living-related transplant, the improvement of renal rejection medications all led to more success and less dialysis patients. Not only clinical reasons, even some patients think that they should not dialyze without direct supervision from nursing. And lots of patients would complain that there is no satisfactory explanation about the different dialysis modalities. So this all leads to lack of motivation. And not only patients and clinical reasons, even the nephrologists themselves and the health providers themselves, there's lack of interest and experience among nephrologists and small number of experienced dialysis programs. Having said that, there's lots of advantages to home hemodialysis. The simple advantages and non-medical advantages is that it's less expensive to deliver if done without nursing assistance. Also, there is more autonomy. The patient does it according to his own time and own schedule without the interruption of their daily activity. And with that, there's definitely an enhancement of the quality of life. Not only the quality of life and the non-medical benefits, but there's actual medical benefits. One of the largest studies that looked at this showed that patients who are on frequent home hemodialysis, and here I'm not talking about 3 times a week, but I'm talking about 6 times a week dialysis, it's associated with regression in left ventricular mass. There is an improvement in pre-dialysis phosphate control. There is an improvement in blood pressure control. There is an improvement in quality of life. And other than this study, there has been multiple observational studies and randomized controlled trials that looked at the benefit of what we call frequent, which is either short hour daily or nocturnal, like home hemodialysis being done at night. This is a forest plot summarizing the effect of both frequent hemodialysis and extended hemodialysis on left ventricular mass. And almost all the studies show that there is an improvement. And although there's no hard endpoint in terms of survival and mortality, but we know that left ventricular mass and regression in that has been associated with better outcomes in dialysis and in patients in general. So just summarizing, there is improvement in blood pressure, there is regression of left ventricular hypertrophy, there is normalization of phosphate control, there is better kidney disease-related quality of life, short recovery time for dialysis, and one of the strongest indications that most centers do, even in-center, is improved pregnancy outcome. When we have a pregnant lady who is on dialysis, we do usually daily dialysis for her. And although some studies have shown that there might be improved survival in frequent hemodialysis, but there are concerns about selection bias in those patients. So despite all these benefits, it seems like the prevalence of home hemodialysis worldwide is still not as much as we would expect. The National Kidney Foundation have put lots of effort trying to investigate why did this happen. The most recent was a conference where they had the world leaders in home hemodialysis, patients and stakeholders investigate and try to find out what are the barriers and what can we do to overcome them. They divided barriers into 4 categories: clinical, operational, economic, and patient-related. The clinical factors are usually misconceptions regarding the dialysis. Lots of nephrologists believe that hemodialysis is too complicated. And lots of nephrologists even lack the competence in prescribing home dialysis, whether it's PD or home hemodialysis. And one of the biggest issues is the lack of proper exposure and education among nephrology trainees and practicing clinicians in prescribing and increasing their comfort into looking after home dialysis patients. Operational factors: lack of infrastructure that supports such services, lack of proper training to all the healthcare team and staff. Economic factors mainly on the patient. So abroad, because the patient does it independently, there's financial cost to the patient at home for modification and for need for space for storage. Lack of adequate housing. If the dialysis was to be done on the second level of the house, not having an elevator carries the risk of having to carry heavy material into the second floor of the house, and which might create difficulty to family members. And of course, there's lots of patients who lack the confidence to do it, and they're afraid of catastrophic events. So this is talking about home hemodialysis worldwide. In Saudi, it's totally different. In Saudi, our demographic population for home hemodialysis, whether through the government hospitals or through health insurance and private companies, is totally different. In Saudi, we select patients for home hemodialysis when they are dependent, elderly, they need nursing assistance, they have special physical disabilities for which it makes it difficult for them to commute to the dialysis center. While internationally, home hemodialysis is usually the option of choice for young, independent patients who live in the rural areas, or patients who are fully functioning, the patients who want to go to work from 8 to 5, fully work, and then they go home at night and they connect themselves to the home hemodialysis machine without the help of a nursing staff, and then they sleep and they do nocturnal hemodialysis and they wake up the next morning. So the demographic is totally different. The way we provide the service is totally different. And unfortunately, to date, we don't have any published data from home hemodialysis in Saudi. From my experience and working in different parts of the country and different sections in healthcare, we have the specialist hospital and the Ministry of Defense hospital. They are outsourcing their home hemodialysis patients through a private company, and this private company serves around 500 patients in the GCC. Their headquarters is in the UAE, and they have excellent results, but they use the low dialysate flow system. We have lots of home healthcare companies that provide home hemodialysis, both using conventional machine or the next stage machine, which is the low dialysate flow system. And then we have excellent results. And I think one of the speakers with Dr. Abdelrazak Amin, he's from Aramco, and I know Aramco has, or John Hopkins Aramco Hospital, they have few home dialysis patients who are outsourced through DaVita, and from what I hear, they have excellent outcomes. We have excellent example in Jeddah from the international medical centers where they're doing home conventional dialysis. To date, in Saudi, we've only had experience with one independent home hemodialysis. What I mean by home hemodialysis independent is that we trained the patient to connect himself to the machine, to operate the machine himself, to prime the machine himself, to troubleshoot the machine himself, and then to disconnect. This was done last year. It was just for a pilot period for 3 months. And it went smoothly. With zero complications, zero event. Unfortunately, the pilot period was stopped as the patient did not have health insurance to pay for it. And the pilot period was sponsored by an external company only. and it hasn't been published. The experience hasn't been published yet. But to be honest with you, I see a huge future for home hemodialysis in Saudi. If all of us, if we think 10, 15 years ago, where home healthcare did not even exist in Saudi, and nowadays there is these huge services provided to the highest quality possible in the different fields in healthcare, medication, physiotherapy, IV therapy, provided through both government and private-based home health company, and the results are amazing. I really think that there is a huge future for dialysis and home healthcare, not only the way we're providing it these days, but I think starting PD programs through home healthcare carries a huge potential. Starting hopefully independent home healthcare, which is limited nowadays as the government hospitals only allow it for the special needs patient, as well as the health insurance is only allowing it for bedridden patients. But with time, I'm pretty sure it will become an option to young functional patients to give them the option to live the best quality of life possible. And of course, if we're able to achieve independent home hemodialysis, then hopefully we can start performing frequent daily or short hour daily home hemodialysis and benefit from the extra medical benefits of that. By this, I conclude my talk, and I'd really like to thank the organizing committee for having me and for having such a well-organized conference.
Thank you very much, mashallah. Thank you very much for this excellent presentation and updated review for the hemodialysis. I have just a question. How much did you, this machine, how expensive is it? How expensive? The portable home machine.
Unfortunately, it's not about the cost now. The current one that's approved by the Saudi FDA and it's been used to the widest range, the company took وكالة حصرية of the machine. So they're not now selling it. They're trying إنهم يتحفظون for providing services only and not selling the machine.
Yes. سمعنا في العلم الكلية الصناعية البيولوجيكال كلام هذا صحيح ولا بس دعاية؟
There is research, but up to date, there is nothing that's, there is just one model that's being tested after a model, but it hasn't been generalized to a larger patient population, unfortunately.
In the name of the organizing committee, we thank you very much for this excellent presentation, and we'll transfer to the next session. Thank you.
Thank you very much. Appreciate it.
السلام عليكم ورحمة الله وبركاته. Inshallah, we'll move to the session number 9. It's on respiratory management in home health care. And we'll have in this session, inshallah, 3 speakers. Our first speaker will be Dr. Muhammad Shamma. Dr. Muhammad Shamma, he's a consultant intensive at MOH Jeddah. He started residency and fellowship training in USA and was certified by the American Board of Internal Medicine in Internal Medicine and Pulmonary Disease and Critical Care. He moved to Jeddah in 2008 and he worked with different other pulmonary and clinical care medicine in different governmental and private hospitals. And nowadays he's in East Jeddah Hospital. Dr. Shamma, inshallah, he will talk about approach and management of chronic obstructive pulmonary disease. Please, doctor.
طيب بسم الله الرحمن الرحيم. السلام عليكم. Good afternoon, everyone. I will be talking about COPD and especially as it relates to its management and especially the aspects related to home health care. So first, as an introduction, some key facts about COPD. COPD is a common disease, but despite that, it's still underdiagnosed and under-recognized. And maybe one of the reasons is that it has a spectrum of different severities. Some patients present with mild disease, cough and sputum production. A lot of the patients present late, and there is also a lot of comorbidities and associations with other systemic disease, especially coronary artery disease. The nature of the disease is that it's progressive, chronic and progressive. The main causative factor is smoking, and this you will hear me repeating it throughout the presentation, the importance of smoking cessation in all stages of the disease. It cannot be overemphasized. It should not be taken lightly. It gets the best yield, more important and more gives them more yield than any other intervention, smoking cessation and its advice. I hope by the end of this lecture, I'll be able to convince you or relay the message that COPD and home health care make a perfect match. Home health care offers a lot of opportunities for disease management because of the nature of COPD being chronic, being progressive, and being with a lot of facets or a lot of morbidities affecting different organs and systems. So as you know, COPD is primarily a respiratory disease presenting mostly with cough and sputum production, but it's not only that. Again, as I said, it's and we'll come to that in the following slides. There is many phenotypes, many aspects of the disease, many comorbidities, many associations with systemic diseases ranging from coronary artery disease to depression to osteoporosis. Multiple phenotypes have been described for COPD, and this is just not inclusive, but it challenges the traditional classification of COPD being either chronic bronchitis or emphysema. Now we know that it presents with a spectrum or with multiple other possibilities. One of them is the hyperactive airway asthma. It's called asthma COPD overlap syndrome. Some patients have predominantly chronic respiratory symptoms. Some patients don't have much symptoms, but for some reason suddenly develop sudden and frequent exacerbations. Some patients are emotionally frail and have depression because of the disease. Some of them have rapid deterioration of the lung function. And of course, as in any disease, and especially being a common disease and common problem, every patient is his or her own phenotype. This is just brainstorming or challenging the old thought. This is a slide from a famous study done by Dr. Shireen Mirza describing COPD phenotypes. Again, it helps just to stimulate the thinking that every patient is unique, and this is one challenge and one opportunity for improvement with patient-centered care. One hypothesis for the comorbidities in COPD is called the spillover hypothesis, postulating that the same inflammatory pathways, primarily by smoking, causes a release of cytokines, inflammatory markers, and sharing common pathways with other inflammatory. Our modern understanding for coronary artery disease is that also there is inflammatory pathways there. So that explains the comorbidities. This is controversial, and there is some other thoughts or other theories, but what's proven is the strong association of COPD with multiple other morbidities affecting other organs and systems. Our modern understanding is that it's a multi-system disease, again, affecting many organs ranging from depression, anemia, metabolic syndrome, osteoporosis, and coronary artery disease. And the psychological factors should be always kept in mind. It's a major factor. The patient is not depressed because, directly because of the symptoms, but the disease itself causes depression as a long-term consequence. The current recommendations or the current general goals go into two lines. Decreasing the symptoms, since it's a chronic disease causing chronic symptoms. So the symptoms are obviously very important and we need to control the symptoms, but also another pathway or another target is decreasing the deterioration in the lung function. Again, by the nature of the disease, the lung function is expected to continue to deteriorate. Now, some patients deteriorate faster than others. And one of the goals is to slow down this progression and slow down this deterioration, mainly by smoking cessation and pulmonary rehabilitation, but also pharmacotherapy, especially inhaler therapy, has a role there. So these are the current or the main targets for treatment. Another slide, hopefully will illustrate or will convince the importance of smoking cessation at any point in time or any point in diagnosis. It's an illustration of the natural history or natural progression of the lung function after a period of lung growth up to the teenagers. There is a plateau and plateau phase in the 20s and early 30s of age. And there is a normal expected physiological decline, slow decline of the lung function. But this decline is accelerated, especially in smokers and especially in smokers susceptible to the effects of smoking. Again, as many of us know that not everybody is affected the same by smoking. Some people are predisposed for some reason or another. There is multiple theories regarding that, but some people are more prone to the effects of smoking and it causes the rapid decline in the lung function. But as you see in the green curve, smoking cessation, even in the rapid decliners and even in the late disease, will slow some of the decline in lung function. This is as far as the lung function measured in FEV1, forced expiratory volume, in 1 second, but also measuring other parameters. Smoking cessation was proven to help decrease symptoms, improve quality of life, and decrease exacerbations. The guidelines of COPD management, again, is focusing on all that, on decreasing the symptoms and decreasing the exacerbation. The upper part of the graph shows the spectrum of the disease severity, starting from at risk to symptomatic and mild symptoms, as you see in the bottom. As the severity increases, symptoms increases, and the lung function decreases. So smoking cessation is an important intervention in all aspects or all the degrees of severity. And then the pharmacological management in the symptomatic patients and to improve the symptoms and to decrease the exacerbations. Pulmonary rehab becomes important as the disease progresses. And then other options, meaning advanced, so certain patients are candidates for lung volume reduction surgery or for lung transplantation. The general guidelines, just I will not go into the details of pharmacotherapy. Pharmacotherapy is mainly inhaler therapy, and inhalers, the current recommendations are 1, 2, or 3 of the bronchodilators and inhaled steroids. LAMA, meaning long-acting muscarinic antagonists, LABA, long-acting beta agonists, and inhaled steroids, and any combination of which, depending on the severity of symptoms and the exacerbations. 2 things we focus on, or to help us make the decision on which inhaler to choose. Obviously, in these most severe cases, all 3 are recommended in different combination. There's a combination now in 3 in 1, and one device containing all 3 inhalers or 3 types of medications, LAMA, LABA, and inhaled corticosteroids. But the point of the slide is to emphasize that it's not only the inhalers, not only the pharmacotherapy, but there is other important interventions. Again, smoking cessation is on top. And then vaccinations, influenza and pneumococcal vaccine. Currently, recently also pertussis vaccine is recommended for everybody above 50 years of age. Encouragement of physical activity. Physical activity very important, either in the patients with mild disease, encouraging the working out or walking. And as the limitation increases and the muscle mass is lost, then a structured pulmonary rehab program is recommended. So to the part that relates to the home health care, again, I think what I want to relay a message is that there is a good match between home health care and COPD because of the nature of the disease being presenting with different phenotypes or different ways of presentation. So personalized care offers a lot for that. And the best way, I think, to provide personalized care is by home health care. Another advantage is that for the most severe cases, when the disease itself it decreases the mobility, then the home health care by offering care at home and avoiding trips to the hospital can relieve that part. And then also by being a multidisciplinary, by offering a multidisciplinary team in the home visits, can assess the home environment, can offer training on the respiratory devices, which are sometimes indicated, which will come to in the following slides. What's the evidence? Obviously, the advantages are clear, but as in everything in medicine, we would like to see evidence and studies. So what's studied for the most part is treating the exacerbations at home, which with a model called hospital at home model or hospital at home services for COPD exacerbation. And this is the part that are most studied by the studies in the bottom. The studies have been there for some time. It's the largest one is a British study comparing the care in hospital versus the hospital at home model. Obviously, as we will see in the next slide, not everybody is a candidate. The most severe cases that we will need mechanical ventilation are not a candidate. But most of the patients can be treated with antibiotics, steroids, bronchodilators, and sometimes even non-invasive ventilation, which has a large role with CPAP or BiPAP machine, can be offered in the hospital, obviously, but can be done at home. So again, for most of the cases of COPD, the exacerbations are treated with the ABC, antibiotics, bronchodilators, and steroids. Here, steroids means systemic steroids, IV steroids. And then assessing the therapy for assessing severity for oxygen therapy, non-invasive ventilation for most of the cases, except the severe ones with deterioration in the level of consciousness or concomitant pneumonia or severe respiratory acidosis. Then these patients need intubation and mechanical ventilation. So what was studied is the different approaches for hospital at home. 3 pathways have been suggested, either direct from the clinic to home health referral, or referral to the emergency room, and then in the emergency room, that referral for home health is done, or patient gets admitted, hospitalized, seen in the emergency room or in the medical ward, and then referred for home health by what's called early supported discharge. Again, I think obvious contraindications are the most severe cases that are close to being intubated or might need mechanical ventilation. These are excluded. So the American Thoracic Society has recommendations for home healthcare referral in actually this recommendation is not only for COPD, but for all chronic respiratory diseases. They are, I think, logical and but pretty inclusive. Any patient, except in very mild cases, is a candidate. Ones with a new diagnosis, complex comorbidities, elderly advanced age, decreased mobility, complicated devices for assessment or for training. How do we provide home health care in COPD? Multiple opportunities, either a one-time visit to set up the equipment and train, can be episodic for follow-up, and then as needed for exacerbations, can be as the disease progresses, can be focused on comfort care. And again, the personnel or the team providing these services is tailored for the severity of the disease and for the patient requirements. And then chronic home health care services for the patients that are needing mechanical, long-term ventilation. Some patients undergo tracheostomy and are placed on mechanical ventilation long-term. Some patients need BiPAP or CPAP at night. as a treatment for COPD. So the components of the home healthcare assessment and care starts with the assessment and then includes treatment. But as always, patient and family education is a key component, and they go hand to hand, all these three aspects. I think for the most part, the message is clear that there is a good match between home healthcare and COPD. So in the next few slides, I will just put examples on the devices and equipment used for treatment of COPD that hospital at home can help with the setup, with training, and with follow-up, assessing and making sure of the adherence and of good technique, starting with the mainstay of treatment, which is the bronchodilators, either in the form of meter dose inhaler or dry powder inhaler, or in the form of nebulizers, which come in a different shapes and forms. And home healthcare offers the advantage of continuous follow-up assessment of the inhaler technique, education as needed, and making sure the patient adheres to the appropriate technique. Equipment used for treatment of COPD can be, as I mentioned before, CPAP and BiPAP at night, or if the disease is very severe, sometimes around the clock, or in a set schedule. CPAP and BiPAP for respiratory support, especially during the night, because there is a strong association between COPD and obstructive sleep apnea. And even without sleep apnea, COPD patients are prone for desaturation during the night because of the normal sleep physiology. Non-invasive ventilation and invasive ventilation. Invasive ventilation usually means that the patient underwent a tracheostomy already in the hospital and then are discharged on long-term ventilation therapy. Some patients have a problem of weak cough and accumulated secretions. So there are certain types of devices that will help with the clearing the secretions. The one in the bottom right is a cough assist device. It's like a vest. It actually is called a vest, which is a trademark, the vest, which causes positive pressure in a sort of percussion therapy to help clear the secretions. The one in the top left, its trademark is Acapella. The company mixing it's a peak device. It gives a positive pressure, helps also clear the secretions by delivering positive pressure, and the patient then exhales and coughs. Oxygen therapy, obviously, for the most severe cases, and home healthcare can help with the setup of the oxygen concentrators and oxygen tanks. Smoking cessation cannot be repeated enough. It's very important, again, in all stages of the disease. And home healthcare offers the advantage also of persistence, reminders, and making sure the patient adheres or if the patient quits, then they're making sure that they continue to avoid smoking. Pulmonary rehab usually is done in the hospital traditionally, and it's an important aspect of COPD management. It decreases the loss of muscle mass. Loss of muscle mass is one of the main problems of COPD. Actually, one of the indices used to assess the disease severity, it's called BODE index, BODE, and one of them is body mass index. And in this case, body mass index, the lower, the worse. We're not talking about obesity, we're talking about low muscle mass causing low body mass index. So that's one of the bad aspects of the disease. So one intervention that helps decrease that is increasing activity, and for the severe cases, in a structured pulmonary rehab program. Now, one modern idea or suggestion is home pulmonary rehab, using the wearable technologies that are available nowadays for wearable devices that measures the heart rate, oxygen saturation. Patient is given instructions for an exercise program at home, and then follow-up is done with feedback from remotely. By the way, a lot of the home health care got a boost, so to speak, from the COVID pandemic. It helped accelerate the progress in these interventions or in these approaches. in general, I think, but specifically for COPD management, it's the interest is revived because of the people wanting to avoid coming to the hospital for obvious reasons, and rightly so. So that's one of the maybe the advantages or the good outcomes of the COVID pandemic. So I hope by the end of the presentation, I was able to relay the message that COPD and home health care make a perfect match because of the chronicity of the disease, because it presents differently in different individuals. So personalized care is very important because of the complexity of the interventions sometime that need assessment of the home environment, that need setup for the equipment and devices, that need treatment. And then one thing as a smoking cessation is very important and can be also encouraged and enforced by reinforced, let's say, by home health care visits and by the education part is it of home health. Thank you very much.
شكرا دكتور شماع على for your nice and excellent presentation. And I think we can take the question for each speaker so they can leave if they want. Yeah, if anybody has a question, please. If you allow me, Dr. Shamma, I will start with a question. I have two questions. The number one is, we know that COPD is a chronic and progressive disease. And regarding smoking for those patients, does it differ in prognosis if from the time of quitting smoking and age and time of diagnosis?
Absolutely.
I mean, if patient, okay.
Absolutely. No matter what the outcome measure you're looking at, there is enough evidence and enough studies to support that. If you're asking about the symptoms, it does help decrease symptoms for sure. Better, less symptoms in the ones who quit at any stage of the disease, even in the very severe disease, even on people on oxygen. That sometimes people are on oxygen and continue to smoke, which is an obvious fire hazard. But even those that quit at that late, let's say late stage, it's not too late. So that's as symptoms, as far as symptoms is concerned.
So I mean, yes.
Looking at another parameters, FEV1, the lung function itself is also proven to, the decline is there. Again, there is even a physiological decline, but it slows down by quitting smoking. Another parameter or another thing to look at is the exacerbations, and that's also proven to decrease. Exacerbations are less in the patients who quit. So no matter what endpoint you're looking at, there is enough evidence that it's helped by avoiding smoking or smoking cessation.
Shukran, Doctor. Thank you. That's what I want from you, is that we have to take this message and to us and to the audience, and that we have to encourage people to smoke whatever the time of diagnosis of COPD, because we have a better prognosis in lung function. Is it?
Absolutely.
Not to smoke. Sorry.
Not smoke. Yes.
Finally, the second last question is regarding home care. I think COPD is a good candidate for home care.
Sure.
Now, what, from your experience, do you see we are moving a lot of patients nowadays to home care for COPD, or are we still in a hospital?
Yes, I think the part that is most studied is the hospital at home approach for exacerbations. I think that's still early, or maybe not the perfect situation in our resources or in our community or in our setups. I think the better candidates would be the patients with moderate to severe disease who are either on home oxygen, who are needing respiratory devices, respiratory support by CPAP and BiPAP. So those ones are, and I'm seeing that in real life, that there is good opportunity for, and I think the best model for this is the episodic home healthcare services, just maybe once a month, and then for exacerbations also by phone call, an additional visit for the mild to moderate exacerbations that can be treated at home with IV antibiotics by visiting nurse, and then by supplemental oxygen. So it has been done, yes, for that indication.
Okay. Any question, please? Okay, Dr. Shammas, thank you for your excellent presentation, and we'll move to the second speaker.
Okay. Our second speaker is Dr. Turad Tilmisani. Dr. Turad is a consultant family medicine and in geriatric. Okay. And he's assistant professor of family medicine and geriatric Al-Baha University, American Fellowship in Geriatric, Oklahoma University, American Board of Family Medicine, Texas University, and Clinical Research Fellowship in George Washington University. Dr. Turad will talk about herpes zoster, a review of clinical manifestation, presentation, and management. Please, doctor, you are welcome.
No, thank you. Okay. بسم الله الرحمن الرحيم والصلاة والسلام على سيد الأنبياء والمرسلين سيدنا محمد وعلى آله وصحبه وسلم. First of all, I'd like to thank you all for being here today, and I'd like to welcome the audience who are watching us through the cam. Secondly, I'd like to thank the organizing and the scientific committee of Salam conference and GSK for inviting me and giving me this opportunity to be presenting in front of you all today. So thank you again. Okay, so before I begin my presentation about the shingles vaccine in at-risk adults, first let's take a look at this picture over here. Here we can see a lady with a smile on her face. She's looking down into a cake or in a table. I think she's 50 years old. Of course, I cannot ask her such a question to a lady, but I assume she's a 50 years old female. And looking at those blown candles, we can see this red, smoky, sneaky snake shape looking toward her, raising the alarm that she hit the milestone of 50 years old, which is fine, but she's at risk to develop herpes zoster now. I have a few disclosures. I'm not a GSK employee. I am receiving an honorarium from GSK to give this presentation. All the presented information over here are aligned with the local product approved information by the Saudi FDA and the Ministry of Health, and the presentation might contain some promotional content. Okay. Our agenda for today, first I'm going to talk a little bit about the disease, then after that I'm going to talk about the disease in terms why we get some of the age population to become at risk. Then we will talk about the Shingrix profile of the vaccine itself. And finally, I will talk about the how we can administer, how you can implement that vaccine. And I hope this is the right presentation. Okay, let's see. Let's see here, double check on these things. This is not the right presentation, but that's fine. Okay, so even though this is the first slide, even in the other presentation, I would assume that 99.6% of everyone here in the audience do have the varicella zoster virus inside their body. Okay, I would assume that. The reason is, unless you are a 10 years old or a 12 years old who received the varicella vaccination starting from 2012, this means that you're like 12 years old attending this presentation. I don't think this is feasible. But our history with the VZV is pretty long, okay? It's not something new. The first introduction to the VZV or the varicella zoster virus start when during the childhood when we developed the chicken pox, or what we know here as al-angas. Okay, we get the virus, it caused the chicken pox symptoms. We suffered during that week. After that, the immune system is very resilient and overcome the infection, and they work and entrapped in the virus inside the dorsal ganglia alongside the spinal cord for our bodies. And it stays there for many years and decades under the check of the immune system. So no problem with that. Until we hit a milestone, usually that is the 50 years old. Then our immune system resilience get declined for many reasons, decrease the number of T cells, B cells, the antibodies and all that. Okay, so what happens after that? Whenever you face any kind of stressor, I mean, emotional stressor, physiological, psychological stressor, trauma, anything like that, the virus gets reactivated again and it break out of that prison in the dorsal ganglia. It is estimated that 1 in 3 adults, they will suffer from herpes zoster during their life. The incidence and prevalence is very similar across different parts of the world, different continents, different countries. It is estimated that there is a 1 million case in the United States, 1.7 million in Europe, and 1.5 million in China every year. Okay, after that, okay. So the herpes zoster, when it hits pretty hard, okay? Usually the presenting symptoms for patients coming to the clinic is that the first thing they complain of is either being fatigued, tired, or having pain, okay? The problem is that it's very tricky sometimes to diagnose and so treat herpes zoster in our patients. But there's different phases. So we have the acute phase, and this is the phase where patients suffer from what we call acute neuritis, So this is when patients start experiencing severe pain along with having this dermatomal red rash was physical that get developed into becoming filled with fluids that's filled with the virus. And patient described the worst severe pain ever that may experience, very excruciating. Patient may develop a lot of other symptoms, but the most severe complication is to develop post-herpetic neuralgia. And unfortunately, 30% of patients who have herpes zoster can develop that, which is the intense severe pain that stays beyond 90 days of the initial infection. And we will talk a little bit why is it problematic to have that such a complication. Other complication is the herpes zoster that involves the eye part called herpes zoster ophthalmicus. That's if the herpes zoster hit the facial region, the trigeminal nerve, ophthalmic branch. It goes there and it's very severe and pretty bad. It happens to almost like 25% of the patients who get herpes zoster, but in very rare cases, those patients may lose their vision, which is very unfortunate. There's other complications that may occur, like having cardiovascular or a CVA events, hearing loss, cutting, and clinical involvement. And of course, it's not just about people who get like 50 years and above who get the virus. No, it's also people who are immune compromised who can be getting hit with the virus. And those people could be at a very young age, 18 and plus, either receiving some chemotherapy, radiotherapy, have an HIV, AIDS, or receiving corticosteroid either. Okay. And this is not the right presentation, so I'm trying to reorganize everything in my mind, so bear please with me. Okay, after that, let's talk about why do we need to give, we need to be concerned about patients who are 50 and above from herpes zoster. And the reason is this. Study showed that for older adults who hit the milestone of 50 years and above, those patients, they have a natural decline of their immunity. It's something called immunosenescence. Immunosenescence, according to different studies, it happens when we hit that milestone. It gets worse and worse as we get older. So what happens after that, the virus will get reactivated. It will break out from that dorsal ganglia around the spinal cord, and it will destroy everything. Once there's this threshold, if we reach, the immune system is very weakened and the virus it waken again. So usually when these symptoms happen, it happens in a unilateral fashion. So one side of the body, either the right side or the left side. 56% of the time, it happens in the trunk, so the chest and the abdomen area. But of course, it can happen in the neck and the face, or even in the genital area. So it's very severe and very bad. They did a study to assess how severe is that pain or acute neuritis that happens to those patients. And for that, they used a scale, something called the Short McGill University Pain Questionnaire Scale. And what they found is that for the acute neuritis, which is the acute phase pain, the pain is actually worse than the labor pain, okay, which is pretty significant. But if you compare the post-herpetic neuralgia, it's very close to the severity of pain of patients who have fibromyalgia. So it's very decent. But the problem with such a pain, it can impair the quality of life big time. As a geriatrician, I have two things to focus on. First thing is that I want the quality of life for my patients to be the optimal. The other thing is that I want them to be independent on their own as long as possible. I have a pretty interesting story. I do a lot of home care, like a concierge medicine. A couple of months ago, I was called by a patient for the complaint of some abdominal pain, some back pain. He's an 88 years old male, amazing, very active. He do skiing, snow skiing, even though I visit him here in Saudi, and he swims every day. 88 years old, he just have a BPH prostate thing, okay? After that, I saw him, in the morning, he was seen by an excellent pain specialist in town for the same complaint, okay? After that, I visited him at night for the same complaint. The pain specialist told him, listen, you just have a muscle strain, okay, muscle spasm. Take this muscle relaxant, take some Solpadeine, and that's all. I saw him. I usually spend a lot of time doing history, especially, with the older folks. So I told him, this could be herpes zoster. The way you're explaining that you're having this stabbing pain, this could be a herpes zoster, but let me examine you. I examined his back, all the paraspinal muscle on the left side were in pain. It was tender, nothing in the abdomen, no redness, no rash. I tell him, I'm in doubt now. I don't think this is a herpes zoster. Okay, and we put a plan, eliminated anything that can affect his mentation because, Solpadeine have a codeine, it can have a bad effect. So he was also on tizanidine and other medications, but I told him, let's eliminate these medications, just stay on paracetamol. Let's see how things are gonna go. After 3 days, he told me, I feel excellent. And in the 4th day, he developed the rash, okay? So he was seen by 2 consultants, a pain specialist and a family geriatric medicine consultant, and we've missed it. Okay, let's start the antiviral treatment now. We give the prescription for valcyclovir TID 1 gram. They dispense the medicine from the pharmacy. They started taking the medicine, and he's not improving. He's not improving. 1 day, 2 days, 3 days, still we don't see any improvement. Okay, I double check with him. I told him, listen, send me the picture of the box. I want to see how much you're taking. He was very religious about taking his antiviral treatment, and still the rash is full-blown severe acute neuritis. And apparently he was taking the medicine 50% lesser dose than he was supposed to be. He was taking 1 tablet 3 times a day, not 2 tablets to reach, because the tablet is 500 milligram. So he wasn't taking the full dose. So it was a big mistake. And looking at the studies, this mistakes happens a lot of times, especially with older adults. He's independent in taking his medication his own. He's very stubborn, I would say. So it was a trip of hell for him. We prescribed pregabalin, Lyrica, gabapentin for him to control the pain. And as you all know, it's very difficult to give such a medication these days. It's strictly prescribed, and I don't like to give such a medications to older adults. The reason is it can give them confusion, sleepiness, increase risk of falls, and all that. But we had to. Still, no improvement of the pain. He was on Solpadeine, Lyrica. Still, I referred him to the same pain specialist who saw him. And I told him, listen, we need to do some nerve block. He did that, still moderate improvement. He went next day and he swam here, not elsewhere still, but he was in Solpadeine, Lyrica. We tried to increase the dose. I was very fearful for a fall and a fracture, waiting for the call for that. After that, still no improvement of the pain. So we ended up giving him oxycodone, and this is how bad it is for him to reach. So this is a pretty interesting story that I faced, and that's why I'm really happy that the Ministry of Health and Saudi FDA approved this medicine to be given for free for everyone who is 50 and above, especially the older adults. Okay, moving after that, see what slides available here. So let's talk about the vaccine itself. So the vaccine, and this is going to be very practical to all the nurses here, okay? So the vaccine comes in 2 vials, okay? The vial number 1 contains what we call the glycoprotein E, which is the spikes on the surface of the virus. And these spikes is very important because they are the most crucial and vital part in the vaccine. This is how we can recognize the virus. It's the primary target for the VZV immune-induced response, and it's the key for the virus response to be developed against using the cellular innate immunity. The second part is the adjuvant system, and this adjuvant system is the part that is responsible for stimulating the immune system. As we get older, our immune system tends to sleep. It's not as active if you give it any vaccine, okay? So we need to give it a push, a jump up. So, and it's called the AS01B. It have different components from a natural plant from the Amazon. It works on triggering the immune system to give a robust immune response against this glycoprotein. There's other vaccine, which is not approved in Saudi Arabia, called the, it's a live attenuated Zyzovox, is live attenuated vaccine, but it doesn't give a similar immunogenicity, which means the strong reaction of the immune system toward the virus. But this vaccine is available here. Okay, so when we give this vaccine, when we have the vials, okay, so we have 2 vials. The first vial have the glycoprotein E. It's like a white powder. The other part is a liquid form, and this liquid form contain the adjuvant system, and we mix them together. So we start with the vial with the liquid, we remove the cap, we put the syringe. We're gonna need 2 syringes, so 2 needles, 1 syringe to do that. So we do the mixture. I'm gonna show you a video about that. So, and when you make the mixture of that vaccine, it's ready to be given within 6 hours only. Okay, as long as it's been saved in a fridge, okay, refrigerator, not to be freezed, okay, refrigerator, in a temperature between 2 and 8 Celsius, okay. It's only given IM, preferably the deltoid, so intramuscularly, okay. And since we're in the mix of giving other vaccines, like influenza especially since we're in the season now, you can administer Shingrix and the influenza vaccine, but not in the same deltoid muscles, okay? If you give the Shingrix on the right side, give the influenza on the other side, okay? You can give other vaccines along with that, the pneumococcal one and the DTaP, you can give it too, but not in the same side when we give the Shingrix. How about the COVID vaccine? We cannot give the COVID vaccine along with the Shingrix, okay? They need to be spacing between the 2. One more thing, it comes, the Shingrix needs to be given in 2 doses. For patients who are 50 and above, the first dose, let's say someone received the vaccine today, the second dose should be at least after 2 months. And we have a period between 2 and 6 months to give the vaccine, okay? Okay, so this is the video that explain how you can administer the vaccine according to the guidelines from the manufacturing company.
This video will walk you through the reconstitution process for Shingrix, a non-live recombinant vaccine indicated for the prevention of shingles in individuals 50 years of age and older. To get started, you will need the following: 2 sterile alcohol swabs, 1 vial of lyophilized antigen, along with 1 vial of accompanying adjuvant suspension, a sterile syringe, and 2 sterile needles. Before preparing a dose, be sure to check the expiration dates on both vials. If expired, do not use. First, remove the plastic caps from the vials. Cleanse both vial stoppers with a sterile alcohol swab. Next, insert the sterile needle into the stopper of the adjuvant vial and withdraw all of the contents. Now, insert the needle and syringe containing the adjuvant suspension through the stopper of the lyophilized antigen vial. Slowly transfer the entire contents of the syringe into the lyophilized antigen vial. Gently mix contents to ensure that the powder is completely dissolved. The reconstituted vaccine is an opalescent, colorless to pale brownish liquid. The reconstituted vaccine should be inspected visually for any foreign particulate matter and/or variation of appearance. If either is observed, do not administer the vaccine, and GSK should be contacted. The vaccine is now ready for use. It should be used promptly, but it remains stable for 6 hours when refrigerated between 2 and 8 degrees Celsius. Do not freeze. Discard if not used within 6 hours, or if the vaccine has been frozen. Next, switch to a new sterile needle. Now withdraw all contents of the reconstituted vaccine. Use the window in the rubber stopper to ensure contents are fully withdrawn. Remove any air bubbles that may be contained in the syringe. You are now ready to administer the vaccination. Shingrix is only indicated for intramuscular injection and should not be injected intravenously, intradermally, or subcutaneously. The preferred site for intramuscular injection is the deltoid region of the upper arm. Be sure to disinfect the injection site prior to administration. Shingrix is given as a 2-dose series. The second dose can be administered as soon as 2 months after the first dose, and any time between 2 and 6 months.
Thank you all for your attention, and sorry, I was supposed to give this presentation tomorrow, but I'm pretty glad that you're all here and you all get the chance to see it. But I'm still going to be presenting the lengthy one tomorrow, inshallah. One more point that needs to be mentioned that a recent published study 2 weeks ago looked into the data regarding the Shingrix efficacy in terms of 10 years. So someone received the vaccine 10 years ago, they're still gonna have a good immunity after 10 years of 81%. With that, I conclude my presentation, and thank you very much.
Shukran. Thank you, Dr. Turad, for your presentation. And if anybody have any question for you, Dr. Turad, please.
Go ahead.
Hello. Good afternoon, doctor. I'm Ira, a nurse from Salam Home Care. So I have a very personal question for you. I have a friend who's 36 years old and with a history of asthma, GERD, and lordosis. And
take your time.
actually, I have 3 questions for you.
Go ahead.
Firstly, as someone who had a shingles before, is she still indicated to receive the Shingrix or?
Okay, that's a good question. This is the first question?
Yes, doctor.
Okay, good. Yeah, so they are eligible. There is a very low percentage of suffering from shingles again, between like 5 and 6%. So it's pretty low, but there's still a chance. So what I recommend that this is a shared decision making. So you explain that if they feel comfortable, because I'm sure that their experience was pretty bad. There's a low percentage of happening again, but yeah, that's option is available.
Yeah, she described the pain that she felt as stabbing and burning and worst pain in her life.
Yeah.
But anyway, what is the probability of her having for her to have the shingles again if she receive the Shingrix?
Excellent question. So does that mean if anyone who received the Shingrix, they're 100% protected from develop, right?
Yes, doctor.
It's not, they're not 100% protected. Okay, so anyone who received the virus, they have, according to the age, because someone who is 50 years old, they have a robust, more immunogenicity or better immunity not to develop up to 97%. But in people who are 70, they have around like 90%, even though still pretty excellent percentage. So it doesn't protect 100%, but it can protect up to 91% in the first 4 years, and after 10 years, it can protect up to 81%.
So there is a chance of her having this shingles again.
Yeah, but
Okay.
very low chance, especially I think for her since she had, the infection before, and then she received the vaccine again. So yeah, but still very, very low.
Okay, lastly, as a member of the multidisciplinary healthcare team, what are your advice and expectations on us as a nurses in providing a better care for our patients who is experiencing shingles?
Okay, so
Thank
you're
you.
experiencing shingles, like active shingles
Yes,
going
yes,
on.
doctor.
Okay, good question. So those patients, the number one thing that they will complain of, other than acute neuritis, the severe pain, is that it's going to impair their quality of life. And the number one thing is their sleep. Okay, so they will be erratic, they will be crying. It's going to be very painful. We need to listen to them, okay, to tell our physician, the consultant, or the specialist, listen, this patient needs some pain medication, okay? Because if they don't receive a proper pain management, especially for the geriatric older adults, they may go into delirium, unfortunately, because of that. So what happens, severe pain, they will not sleep well, and that's according to the study called ZOE 50. In ZOE 50, they looked into what the impact does the shingles do into our patients, and 63% of them, they were suffering from lack of sleep other than the pain. So beside the losing the enjoyment of their life, their mood is different. All these things together will affect the vulnerable brain of an older adults, pushing them into delirium, and they will get admitted to the hospital, unfortunately, okay? Just because of a simple thing. So being attentive, delivering those informations to the attending, honestly, attending needs to be more relaxed, giving proper pain control, pain management for those patients. Okay, thank you. Thank you.
Thank you, Dr. Pratt, for your presentation. I have one question. What will happen if we give the patient the first dose, the second dose was delayed more than 6 months?
Yeah.
What you will do in this case?
Yeah, once they realize that they missed their dose beyond the 6 month, they just can go ahead and take the vaccine, the second dose. There's still no data that's measuring how would the immune system level will be after that, but they just can go ahead and take the vaccine, the second dose. The mic, please.
We'll give just one dose. We will not repeat the 2 doses.
Okay, so for a patient who just received a single dose, the first dose, without the second dose, they will develop some immunity, but it's very modest in comparison to the 2 doses. The benefit of the 2 doses is that because of immunogenicity and the response, it can quadruple because of receiving the second dose. And that's why, if you want to reach the 91% benefit from getting the vaccine, you need to receive the 2 doses.
Yeah. Think about chickenpox vaccine at the pediatric age.
Yeah.
What extent it is safer or protecting the baby from this vaccine?
Yeah, theoretically, you would assume that if I'm protecting myself from, developing chickenpox, doesn't that mean I will not get the herpes zoster in the future? And theoretically, this seems to be very appealing and nice to think about. There's no study about that still now, but even if you get the natural infection, the primary infection of the VZV developing the chickenpox, and you'd have an immune response, circulating antibodies against that. During your lifetime, you can get exposed to the VZV without knowing that. Okay, so the virus get the chance to enter the body. Your immune system will overcome it with no problem, but it will be there. So the benefit of receiving the vaccine is to overcome the acute infection, the primary infection, but the virus already entered the body and it will be enclosed in the dorsal ganglia. Still, there is no data that looks into, okay, for those children who receive the vaccine against the primary infection at an early age, is it going to protect them from the herpes zoster in the future? We still don't have the data regarding that. There is no research about it yet. But yeah, I understand your point.
Thank you very much.
Thank you.
Any more question, please? Okay, may I ask the last question, Dr. Turad, if you allow me? What is the chance of having zoster after the vaccine? I mean, what is the chance of the vaccine inducing the zoster?
Okay, good question. So for patients who receive the vaccine, it's not the virus that we're giving to the patient. It's just the glycoprotein A. So we're talking about 2 weeks after receiving the vaccine or so. Okay, so after 2 weeks, it won't be related to the vaccine itself since there's just a glycoprotein A, but could be because of the virus for some reason get reactivated from the dorsal ganglia, get released and so on. It could be, even though after 2 weeks it is expected that there's gonna be some circulating antibody from the vaccine, but after, to get the full benefit is after receiving the second dose to reach pretty significant level of immunogenicity, circulating T cells, B cells, and antibodies. So it won't be from the vaccine. Would it be possible if someone received the live attenuated version of this vaccine? This was the concern before. That was the concern, especially immunocompromised patient or patient who were going to become immune compromised either because of getting chemotherapy or radiotherapy. It's not going to be from the vaccine itself, but probably it get triggered again, reactivated, and that's why.
Thank you very much, Dr. Termisani, for this very informative and useful lecture for all of us. And as long there is a limited time or between the two doses, the second dose should be between 2 months, after 2 months or 6 months.
Yeah.
If not taken after 6 months, am I going to take the first dose again and then to take the second?
No need to redo the whole thing again. You just can go ahead and take the second dose and this should be enough. Yeah.
After 6 months, still I can't take.
Yes. Yeah.
But it is better within the first 6 months from the first one.
Yeah, because based on all the research that was done, the data that we have available is just for the second dose to be given between the 2nd month and up to the 6th month. We still don't have any data looking into what's happened beyond that. So we need to stick to the manufacturer label and the approved information by the Saudi FDA regarding that. Yeah.
I remember that you said the chance of getting the disease for those who took it already.
Yeah.
5 to 6%.
Yeah.
And if they took and you advised to take the vaccine, even if they have the disease before.
Yeah, so this is really.
But still, you said after getting or the protection, not 100%.
Yeah.
It is 90, 91, 92.
Yeah.
So it is very near to each other.
Yeah.
Do you personally advise one of the family, for example, to take the vaccine?
Yeah.
Got the disease before?
Okay, so this is really depends on the shared decision making between you. You give all the information to the patient and let them to decide. Okay, because you don't want to give the patient the impression that you're pushing this vaccine on them. You don't want to, because you're gonna lose the trust of that patient. So, and this is very funny because this is what happened to the same person, the 88 years old who used to do snow skiing and swimming. I told him, listen, there is a vaccine, okay, but the chance for that to happen is very low. But I mean, he's a very well-established man, and I was surprised that no one offered him the vaccine, since he doesn't live in Saudi, he lives in Europe, so no one offered him the vaccine over there, even though he's 88. Listen, this is very unfortunate what happened to you. I don't want this to happen. The chance for that to happen again is very low, but even though I'm obligated just to tell you that there's a 5 to 6%, even though you're 88, your life expectancy is not that great, honestly, but I'm still gonna offer it, and the decision is yours. He told me no. I told him, excellent. That's you made the decision. I made the offer. You made the decision, and that's fine. Thank you.
شكرا دكتور طراد, and we are looking forward to see you tomorrow for the second presentation.
Inshallah. Thank you.
Our third speaker is Dr. Mani Al-Shahrani, and Dr. Mani is a consultant family medicine and sleep medicine at King Fahad Medical City and King Faisal Medical City. Dr. Mani will speak about sleep disorder diagnosis and treatment at home setup.
السلام عليكم ورحمة الله. الصوت واضح. طيب أسعد الله مساكم جميعا. Did you hear my sound?
حياك الله دكتور مانع. We hear you. Yes, you can start.
Okay, presentation is clear now.
لا. Share screen.
I shared the screen. Did you see it?
Yes, now.
Clear.
بس كبرها شوي ما يعني.
It's full screen now.
فول سكرين؟
Yes.
عرض الشرايح؟
Yes.
طيب اخرج من الباوربوينت وارجع تاني.
Okay.
ايوه نعم ايوه
Now.
احسنت ممتاز.
Clear.
Start now. Yes.
Clear.
Yes.
Okay. Good evening, everybody. First of all, I want to thank the organizing committee to give me a chance to talk in a great event. I will talk here about the sleep disorder in the home care setup. By the end of the lecture, we will talk how to approach the patient with the insomnia, how to approach the patient with the narcolepsy, approach the patient with the parasomnia, also approach the patient with the obstructive sleep apnea. We will talk about the patient with the RLS or restless leg syndrome. Finally, we'll go to the through home sleep test as a modality can be used in home sleep setup. Sleep medicine is one of the important specialty. Recently, it became independent specialty. Usually, it is a multidisciplinary team. And according to the national, international sleep disorder classification, there is more than 87 diseases that has been classified into 7 categories. Now we'll go to the first sleep disorder, which is insomnia. It is one of the most common sleep disorder in the general population. Regarding from chronic or short-term insomnia, it is prevalence from 30 to 50% of the people who suffer from short-term insomnia, while 5 to 10% of the adults have chronic insomnia. Usually, insomnia is a multifactorial interact by biological, physical, psychological, and environmental factors. And there is also many risk factors has been addressed by the papers, which include old age, female sex, unemployment, low socioeconomic status, shift worker, other comorbidity like medical condition and psychiatric disorders. We define the insomnia. Insomnia is defined by terrible or to initiating or maintaining sleep associated with the daytime consequences not attributable to environmental or circumstance or inadequate sleep hygiene or sleep opportunity. Regarding the international classification of sleep disorder, they classified insomnia into mainly 3 types, which is a chronic insomnia disorder lasting more than 3 months, short-term insomnia disorder lasting less than 1 month, other types of insomnia such as paradoxical insomnia, psychological insomnia, and other insomnia secondary to medical issues. If we go to the assessment, the proper assessment of the insomnia is to exclude other causes such as medical and psychiatric illness. Also, you go to it is a vital role to assist the patient sleeping pattern by asking the patient detailed history from himself, or by asking or take the history from the bed partner to be concerned more, is it insomnia or is it poor sleep hygiene or is it circadian rhythm disorders. Physical examination is aimed here to detect the possible risk factor for insomnia such as obstructive sleep apnea, comorbid medical condition or endocrine condition, substance use, stigmata. The mental status exam is helpful to detect the mood and memory and concentration and alertness of this patient who is suffering from the insomnia. A sleep log or sleep diary is a helpful tool to detect the sleep pattern of the patient. It will help us to discover this pattern is regarding it is such matter of insomnia, or it is related to poor sleep hygiene, or it is related to shift worker, or circadian rhythm disorder in general. This is the diagnostic criteria of sleep or of insomnia that has been published and addressed by international classification of sleep disorders. It is must be all criteria must be addressed from criteria A enter the criteria A. The disturbance of nocturnal sleep that the patient report either by the sleeping partner or by the sleeping parent in case of children. He must be suffering from one of the following: difficulty initiating, difficult to maintaining, or wake up early than the desired time. Also, maybe here is a complaint from resistance to going to the bed with inappropriate timing, also difficult to sleeping without parent. This is in the pediatric age group. Criteria B, there is a related daytime impairment, which is the patient report or the patient parent or caregiver notice one of the following symptoms during the daytime, which is a fatigue, malaise. There is a problem or decrease in attention, concentration, or memory impairment. There is impaired in the social, family, occupational, and academic performance. Also, there is a daytime sleepiness, or one of the important symptoms, which is behavioral problems such as hyperactivity, impulsivity, and aggressiveness. Criteria C, the report sleep-awake complaint cannot be explained by inadequate sleep or poor sleep hygiene. Criteria D, the sleep disturbance is said with the daytime symptom at least 3 nights per week for 3 months. The sleep disturbance is said with the daytime symptom has been present, as we mentioned, for 3 months. This symptom is not explained by another sleep disorder like circadian rhythm disorder. Regarding the management of insomnia, we go to the non-pharmacological and pharmacological treatment. The non-pharmacological treatment we called cognitive behavior therapy for insomnia, or we call CBTI. It's combined with the cognitive therapy and behavior treatment like a stimulus control, sleep restriction with or without relaxation therapy. Cognitive therapy is we try to change the patient offer values and belief about on unrealistic expectation about his sleep. It has strong evidence for management of the chronic insomnia in long term. It should be done as specialized one. It is actually needed from 5 to 6 sessions. Regarding the pharmacological treatment, I will go over like some recommendation or some point for this pharmacological medication. We talk about the over-counter herbal medication like valerian and melatonin. It is a show mixed efficacy on trial, and we didn't recommend it for the chronic insomnia. Regarding other off-label medication like antipsychotic, antidepressant, sedative, antihistamine, we again use it for the chronic insomnia or for insomnia itself alone without pre-existing condition for it. Short-term benzodiazepine is not recommended due to high risk of the abuse, tolerance, increased risk of accident, and increased risk of falls, especially in the geriatric group. Non-benzohypnotic, we call Z drug like zolpidem, zolpidem, isobuclone. This drug has been approved for treatment of insomnia, but it is contraindication in the following group. They are pregnancy, lactation, neuromuscular disease due to the high risk of respiratory depression and drug dependence. One of the class of the medication was good for treatment of insomnia, which is unfortunately available in Saudi Arabia, which is melatonin agonist, we call Ramilton. This has a favorable side effect compared to the other medication. It is have a good effect to improving the sleep quality. Now we're going to throw the second sleep disorders, which is narcolepsy, which is one of the type of the under category of hypersomnia. It is a chronic sleep disorder characterized by irresistible attack of sleep. Estimated prevalence of narcolepsy with the cataplexy in Saudi Arabia is 40 per 100,000 per people. Both sex has been affected, but there is a predominant in the male gender. Usually we have 2 types of narcolepsy, type 1 with cataplexy and type 2 without cataplexy. The clinical feature of the narcolepsy, usually it is a 4 cardinal symptom. The most symptom is excessive daytime sleepiness, which is an irresistible attack of sleep that happens during driving, during reading, during talking, during many circumstances. We check or we measure this sleepiness by Epworth sleepiness scale. It is a metric used or like questionnaire used to assess how the patient is sleepy. Second cardinal symptom is a cataplexy, which is a sudden brief episode less than 2 minutes of the muscle weakness, usually happening by strong emotion like laughing, anxiety, agitation. It is the pathognomic feature of the narcolepsy type 1. The third cardinal symptom is sleep paralysis, which is a temporary inability to move voluntary muscle during the episode of from sleep to awake transition. The fourth cardinal symptom is a hypnagogic hallucination. It is like a vivid dream-like hallucination that happens beginning of the during of sleep. All the patients who complained from daily sleep or sleep lapses should be checked for how our detailed history about the symptom of narcolepsy. It could be other differential, not exactly narcolepsy. It could be sleepiness secondary to other sleep disorders. We check for some labs like CBC and thyroid function test. If narcolepsy is suspected, we should refer for the sleep specialist for the sleep lab. Usually for diagnostic method, we do polysomnography followed by multiple sleep latency tests. Regarding management of the narcolepsy patient, we have non-pharmacological and pharmacological management, which is non-pharmacological, which is most important things. We have regular sleep schedule, adequate sleep at the night, schedule napping, we call the strategic napping. The most important thing is address the safety issue like driving of the heavy meter or those with the critical job like pilot, surgeon, or those soldiers, those dealing with the gun. Also, we prepare him for sleep position to start medication. We have two types of medication: stimulant medication and medication used as anti-cataplexy. Now we go to throw the parasomnia as one of the category of sleep disorders. It is undesirable event or experience that occur during entry to the sleep or within sleep or during after or arousal from the sleep. We have two categories of the parasomnias. We have non-REM parasomnia. It is characterized or can be categorized into confusional arousal, sexsomnia, sleepwalking, sleep-related eating disorder, and sleep terrors. REM parasomnia, which is like REM behavior disorder, nightmare disorder, recurrent isolated sleep paralysis, and we have something we call normal variant like sleep talking. One of these points is a specific disease and needs specific time to talk it. We will not go through in detail, but we will go to the general characteristic of this category. For non-parasomnia, it is a recurrent episode of incomplete arousal from non-REM sleep, usually occur in the first third of the night. There is a lack of response to external stimuli during the episode. There is a lack of dream imagery. Could be partial or complete amnesia from the event. This nocturnal disturbance is not explained by another sleep or medical or disturbance secondary to medication or psychiatric illness. This usually happens in the prepubertal or children. Usually it is decreased with the time, and usually they have family history in his father or mother. Regarding the REM parasomnia, we have most commonly during the second half of the night because it had happened during the REM sleep. It is fragmentary to the total dreaming recall. Eye usually closed during this event. It is erratic movement. Usually both non-REM parasomnia and non-REM and REM parasomnia is diagnosed clinically, except RBD, which is called REM behavior disorder, which is need polysomnography. Regarding management, usually we screen to avoid any precipitating factor or medication. Usually we advise again and again maintenance for regular sleep schedule and sleep hygiene. The most important thing is that universal safety precaution should be addressed at safety and preventive measurement, like removal of the sharp objective, lowering the matrix to the floor level, cover the sharp obstacles, window and the door alarm and locks. Now we'll talk about the obstructive sleep apnea, which is one of the famous disease under the categorized of sleep-related breathing disorder. It is happened during, there is a partial closing of airway breathing, which is called hypopnea, or complete closing of the airway, which is apnea, having at least 10 seconds as a duration. Prevalence of obstructive sleep apnea in Saudi Arabia, there is a two hallmark study done. One done by Professor Ajwali. They revealed around 8.8%. It is 12% in the men and 5% in the women. Another study done by Prof. Hammam, they found 3 out of 10 of the Saudi women and 4 out of 10 Saudi women are high risk for obstructive sleep apnea. So what is the risk factor of obstructive sleep apnea? Usually there is a money risk factor. One of the important things is obesity, BMI more than 30. We have large neck size, more than 43 centimeter for the male and 41 for the female. We have gender itself. As we know, male is more than the female. Increasing with the age, also people with the skeletal abnormality like craniofacial, retrognathia, micrognathia. We have also children with the Down syndrome because due to the craniofacial abnormality. There is some medical conditions that have been associated with obstructive sleep apnea, which is end-stage kidney disease, congestive heart failure, copulmonal, atrial fibrillation, resistant hypertension, which is also considered one of the most cause of resistant hypertension. We have also type 2 diabetes mellitus, nocturnal arrhythmia, cerebrovascular accident. We have pulmonary hypertension and obesity hypoventilation syndrome. Also acromegaly and hypothyroidism, chronic lung disease, secondary polycythemia, polycystic ovarian syndrome, and Parkinson's disease. So what is usually the patient complaint of what when he is coming to our clinic? Usually patient complain from restless non-refreshed sleep, snoring, awaking with a gasping or choking, witness apnea, sleeping fragmentation, excessive daytime sleepiness, drowsiness, decreased concentration and memory, morning headache, morning dry mouth, nycturia, motor fecal accident secondary to sleepiness, and erectile dysfunction. So we have a 2 questionnaire can be used for screening of the patient with obstructive sleep apnea. One of the famous one, it is Stop Bank questionnaire. It is the best validated tool for screening of obstructive sleep apnea. We have other Epworth sleepiness scale, which is assess how the patient is sleeping. Regarding physical examination, usually we look for the BMI, neck circumference. We look for the Merambati score, which is a simple classification to describe how the crowding of the airway. Also, we look for the craniofacial abnormality, like as we see in the picture with the micrognathia or retrognathia, which is one of the most important sign of the obstructive sleep apnea. Usually, when the patient suspected or coming with this symptom and sign, we refer for sleep lab to do polysomnography or home sleep apnea test. The management, we have our gold standard and organ for treatment, which is the CPAP, which is the standard treatment option for moderate with the severe obstructive sleep apnea. If we have another alternative treatment like positional therapy and weight loss for those with the positional OSA, we have oral appliance for those with the mild to moderate obstructive sleep apnea. And last thing, we go to for the surgery like adenotonsillectomy, which is the most common treatment option for pediatric group. Also MMA surgery, which is maxillomandibular advancement for those with have retrognathia and micrognathia. American Academy of Sleep Medicine, they recommend it should be incorporated into routine health evaluation and suggest 3 opportunity to screen the OSA, which is at a routine health maintenance visit. If the patient reports clinical symptom OSA, if the patient has a risk factor. But the US Preventive Task Force conclude that the current evidence is insufficient to screening for obstructive sleep apnea. So what is the complication of obstructive sleep apnea if you will not treat it? We have drowsy driving and motor vehicle accident. In our country, Saudi Arabia, they reporting around 12% of the driver accident secondary to sleepiness. Also, we have neuropsychiatric dysfunction like depression, anxiety. We have cardiovascular and cerebrovascular morbidity. We have pulmonary hypertension or right heart failure. We have can be lead to metabolic syndrome or type 2 diabetes mellitus. Also, it is a risk factor for non-alcoholic fatty liver disease. Now we go to the restless leg syndrome. It is one of the most common sleep-related movement disorder. Regarding the prevalence in Saudi Arabia, it is range from 8 until 12%. There is essential criteria to diagnose RLS. All these criteria must be met. The first one, it is an urge to move his leg usually, but not always accompanied by a comfortable or unpleasant sensation in the leg. This urge or this move the leg worsening during the night or during the period of the rest or an activity. This urge to move his leg or this sensation relieved by the movement such as walking or stretching. This occurrence of the above feature is not slowly accounted for another symptoms such as neurological disorder or such as myalgia, venous status, leg edema, arthritis, or other cause of these symptoms. There is, we call something secondary RLS can be produced by some medical condition such as end-stage renal disease, pregnancy, iron deficiency, anemia. RLS occur 30 to 40% of this patient with this medical condition. When this issue resolved, usually the symptom will be resolved. There is some medication can produce or exacerbating RLS. One of the important things, it is antidepressant like SSRI and SNRI. So what is the RLS morbidity? It is the affect the patient quality of the life. It is impaired daytime function and work productivity. It is lead to the sleep disturbance. It is linked to the cardiovascular disease and blood pressure or hypertension can be evaluated in some studies. Regarding management, we do, first of all, we do some workup. We check the ferritin level, vitamin D, vitamin B12, hemoglobin A1C to rule out the secondary cause of this symptom. If the patient with RLS symptom could be or established, you should refer for a sleep specialist to start the approved medication for RLS. Regarding management, we have behavioral management, we have pharmacological management, behavioral management as again and again sleep hygiene, adequate time of sleep, avoiding of a trigger factor like alcoholic, like coffee, like prolonged inactivity. Also, we check the ferritin level. If the serum ferritin level is less than 50, we start by increasing the ferritin level above 275 microgram per liter. If all these non-pharmacological not correct the symptom, usually we go to the approved medication for treatment, which is the dopamine agonist, like bromhexol, robenilol, reticutin, or alpha-2 ligand anticonvulsant like gabapentin and pregabalin, or third line, which is low-potency opioid. The final part of the lecture, I will go to through the home sleep test modality.
دكتور مانع سامعنا؟ الصوت راح، ما في صوت. دكتور مانع. إذا سامعنا أخرج وأدخل تاني. لسه ما في صوت يا دكتور مانع.
سوري الظاهر قطع
أيوة تمام. بس حط البرزنتيشن يا دكتور.
طيب دكتور. Do you see the presentation now?
أي تمام ممتاز، تفضل.
Okay. Advantage of the home sleep apnea test I was mentioned, patient may be sleep better at home and with an environmental and suitable environment for him. Patient may be prepared to study at home as we mentioned. This is one of the type of polysomnography, as we have 4 types here: type 1, type 2, type 3, type 4. The most recommended one and the most famous one, it is a type 3 of home sleep testing. It is have 4 leads per channel, which is airflow, effort, oximetry, and ECG. It is unattendable, that means doesn't need sleep technologist. Utilize at least, as we mentioned, 4 channel for respiratory movement, channel for cardiac monitoring and oxygen saturation. Do not record the signal need to determine the sleep stage of sleep disruption. There is no EEG electrode, so we cannot determine which stage the patient has the issues exactly. This is one of the example of the home sleep testing. Is have the flow, check the flow of the airflow during the sleeping, snoring. Also, we have thoracic belt to detect obstructive sleep apnea and central sleep apnea. We have pulse oximetry to detect the saturation. We have channel for heart rate and body position and plethysmography for the staging or the positioning of the patient during the attack of obstructive sleep apnea. This is the sample of screening during monitoring. What is the limitation? The type 3 or portable, they cannot detect arousal from the sleep because there is no channel for EEG. Apnea hypopnea index, which is the metric or gold standard metric for diagnosis of obstructive sleep apnea, can be overestimate or underestimate due to we don't know the stage of sleep exactly, or we don't know how much the sleep efficiency by calculating the total sleeping time over the total recording time. Other thing, it is don't record when the patient is lying in the supine position or lateral position, but some machine can detect that. Cannot be, as we mentioned, distinguish REM sleep from non-sleep because there is no EEG channel. There is a condition for successing of using home sleep testing, which is the proper patient selection, appropriate portable recording application, interpretation by qualified sleep technologists, also accessibility to BST lab if needed, or systematic follow-up. Because home sleep apnea is highly specific, low sensitive, that means when you diagnose the patient, we can start up for management, but When the result is coming negative, we cannot rule out. We should refer the patient for polysomnography to do the gold standard test. Regarding the recommendation of the American Academy of Sleep Medicine, all patients undergo portable monitoring about to receive follow-up with the sleep technologist to discuss the result and start the appropriate treatment. They are not recommended for children and the patient with the old age above 65. It should not be used in the case of central sleep apnea, periodic movement disorder, insomnia, circadian rhythm disorder, and narcolepsy, because we need EEG and we need EMG channel, which is not available in the home sleep test. As we mentioned, it is highly specific and low sensitive, and that means when it is positive, you can start management. And thank you so much for giving me a chance and for your listening.
شكرا دكتور مانع على المحاضرة القيمة. إذا كان في سؤال بالأودينس. Any question please? طيب شكرا دكتور مانع. الله يعطيك العافية.
العفو.
بكده
Thank you.
شكرا لك.
يعطيك العافية جميعا. شكرا.
Yeah, we come to the end of session 9 now, and we will start with Dr. Abdul Hafid, session number 10.
أنا أستأذنكم في الخروج لأن عندي عيادة.
دكتور شكرا لك.
لا شكرا في أمان الله. شكرا.
السلام عليكم ورحمة الله وبركاته. شكرا دكتور خالد بواكد على إتاحة الفرصة. أنا الدكتور عبد الحفيظ خوجة، أحد أعضاء لجنة التنظيم للمؤتمر، وأيضا أحد أعضاء اللجنة العلمية، ولي الفخر في ذلك. I'm so lucky to be now as a moderator for the 10th session in this conference, international conference, and more lucky to meet my colleagues, those I don't see a long time now, as I am retired already. The first speaker is Dr. Abdullah Al-Badri. He is consultant dermatologist, venereologist, and allergology at King Fahd General Hospital in Jeddah since 2029 to present. And now we congratulate you, Dr. Abdullah Al-Badri, to be the head of the dermatology department in King Fahd Hospital. Dr. Al-Badri, he has dermatology German board, Vivantes Hospital, Charity University in Berlin, Germany. From his clinical point, he is a clinician in general dermatology, surgical dermatology, allergology, cosmetic and aesthetic medicine, pediatric dermatology. Dr. Abdullah Al-Badri, some of his affiliations: Saudi Council Medical License Exam, Medical Council of Canada Evaluating Exam, Germany Medical License, member of the Aesthetic and Dermatology in Germany. And he is member of the Skin Center for Dermatology and Cosmetic in Berlin, Germany. Dr. Abdullah Badri, you are welcome, and I will leave the floor for you to start your lecture, please.
Assalamu alaikum warahmatullah. Thank you very much, Dr. Abdul Hafid Khoja, for the introduction. Thank you for all for coming today and give me the chance. I would like to really thank the organizer here for the Salam Congress, second, for give me the chance to talk about a common dermatological problem in elderly. Okay, I'm Dr. Abdullah Al-Badri. Okay, we will start with presentation. نمشي السلايدز. Okay, I will make it simple with cases. This old man complaining of severe itching all over the body. Most of our patient population in the elderly complaining of severe itching all over the body. As we see, if we look in the skin of this patient, we see a lot of cracks with whitish, this whitish scaly of the skin with rough also, as we see here. What is the most common cause of pruritus in elderly? It's cirrhosis cutis, that means very dryness of skin. Almost 40 until 50% of all patients with pruritus. What is the causes of dryness of skin in elderly? That is physiological change, because there is increase in the water loss of the skin. Also in old age, also reduce the sweat production, also decrease the natural moisturizer factor, okay, in the skin of elderly. Don't forget also the systemic disease that can cause pruritus in elderly. For example, metabolic endocrinal condition, I mean hyperthyroidism and hypothyroidism, also diabetes mellitus. Don't forget the medication also can cause pruritus in elderly. Okay, morphine and steroidal anti-inflammatory. Also, don't forget renal problem, renal failure, because increase of urea, and also liver problem with obstructive jaundice due to increase of bilirubin. How can easy treat pruritus in elderly? The best thing, hydration of skin, that is very important, 2-3 times in the day with moisturizer product with containing glycerin or glycolic acid, very important. We can add topical corticosteroid also for short time to reduce itching. I prefer to use also in elderly the oral antihistamine fixofenadine, that is Telfast 180 milligram once daily. I prefer it because no need adjustment of the dose for this patient. Okay, if we have this patient with well-demarcated erythema in the diaper area, okay, sparing of the fold with sometimes with erosion and discharge, that is picture of irritant contact dermatitis, that is called diaper rash or diaper dermatitis. What is the cause of diaper dermatitis? This is very important for the sisters in the hospital also. This patient have prolonged contact of urine and feces, especially if patient have diarrhea. Also mechanical friction of the area in this area. Okay, how can we treat this patient? Okay, first of all, frequent general measures, okay, keep the skin dry and clean, always diaper-free time, make the area dry, ventilate the area, very important. We can use large size diaper to reduce contact of friction, okay. Also very important to use protective ointment that containing zinc oxide. Prescription treatment, we can apply topical corticosteroid, hydrocortisone cream twice daily for 2 weeks to reduce the inflammation. We can apply antifungal cream 2 times daily, clotrimazole or something like miconazole if suspicion of candida infection. That is about diaper dermatitis. If we have all patients with this skin lesion, raised, elevated, plaque, hard, okay, don't worry. That is old age, that is seborrheic keratosis. What is it? It's benign tumor of the skin. That is the most common type of benign tumor of the epithelial origin, okay, unknown cause, harmless, and sign of skin aging. How can we treat? no need treatment. If needed, we can use cryotherapy, curettage, or electrocautery or ablative laser. Number 4, if we have this patient with soft skin-colored papule all over the body or the face, okay, that is also skin tag, extra skin, okay, it's benign tumor, okay, and soft harmless lesion for unknown cause, okay, often found in the skin fold, okay, for the groin also, on the neck, armpit also, okay, we see a lot of patient, if patient obese or diabetic patient type 2. How can we treat? No need treatment. If needed, cryo-electroablative therapy or surgical excision if needed. If we have this patient common is red papule all over the trunk, don't worry, that is Sherry angioma. What is its benign tumor or vascular harmless lesion for unknown cause due to proliferation endothelial cell. Treatment, no need treatment. If needed, electrocautery, surgical excision, or laser therapy. If we have these moles in old patient, please you must to be worried about this lesion. If we have black dot moles with irregular border, okay, multiple color, tend to bleed without healing, that is malignant melanoma, you must to refer this patient to dermatology to make biopsy and surgical removal. If we have this papule in the skin exposed area, tend to bleed without healing or make ulcer erosion without healing, that is basal cell carcinoma, need biopsy and surgical excision. If you have this patient in skin exposed area for the skin with ulcer, with in the surface with keratosis, that is sign of squamous cell carcinoma, tumor of the skin, need biopsy and surgical removal. If we have this patient for acute 2-3 days with well-demarcated erythema, with painful and swelling, with increase in the extensive size of the lower limb, unilateral, this patient can have DVT. We must to rule out the DVT by doing D-dimer and duplex ultrasound. If negative, think about cellulitis, that is bacterial infection of the lower dermis and subcutaneous tissue. It's always in the lower limb. What is the most common cause? It's Streptococcus pyogen or Staph aureus. Treatment, if patient not ill, severe ill, not have systemic manifestation, fever or something, we can also as outpatient, okay, with beta-lactam, amoxicillin or augmentin, cephalosporin, good choice. If allergy for penicillin, we can use clindamycin. This herpes zoster already talked with previous lecture. If we have this between the toes, white maceration with fissure, that is fungal infection. It's very common in elderly. This diagnosis called tinea pedis, that is fungal infection of the skin caused by Trichophoton rubrum. How can we treat this tinea pedis? It's very important to use local antifungal therapy, cream or spray. I prefer spray or powder to make the area more dry. If not responding, we can use systemic therapy, terpenafine 250 for 3-4 weeks. The most important thing to treat this patient is the additional measurement. Please keep the area dry between the toes. We can insert cotton between the toes to prevent or reduce humidity and the friction. Okay, and also very important, disinfect the shoes and daily change socks. If we have this in the toe, the nails is discoloration of the toenails with yellow discoloration proximal, or also white streak in the both toes of the nails that is with very hard to cut it. It's very common in elderly, that is onychomycosis, that is the fungal infection of the nails caused by Trichofoton rubrum. How can we treat this onychomycosis? Local therapy. It's not benefit from the cream or spray. We can use antifungal as polish once weekly, amorolfine or cyclopirox once daily. Very important, if more half of the nails affected, we can use systemic therapy. Very important, terpenafine 250 milligram once daily for 3 till 6 months. Very important to treat the candida or the fungal infection is the protective measurement. Okay, additional, treat the tinea pedis between the toes. Okay, and remove the affected nails area if hard. Okay, by using urea 40% or plaster. Okay, very important also, boil socks and also disinfect the shoes. Okay, if we have this patient in the groin area, old patient, severe ill patient, prolonged admission in the hospital with well-demarcated erythema, as we see here also, the scaly in this diaper area with papule outside the erythema called satellite papule in the fold area between armpit, axilla, and also between the fold, or submammary. In this patient has Candida intertrigo. What is it? It's superficial skin fold infection caused by yeast, Candida albicans. What is the cause of Candida intertrigo? It's infection caused by Candida albicans. We see a lot of patients, as I said, in prolonged hospitalization with comorbid disease, immunocompromised, diabetes mellitus, with patient also increased skin friction. What is the therapy of the Candida intertrigo? We can use local antimycotic therapy, nystatin or azole, 2 times in the day till healing. Then we can use topical steroid, okay, hydrocortisone for the inflamed skin. The role of hydrocortisone to treat the Candida infection only for reduce swelling and reduce itching and allow good penetration of the antifungal to penetrate and affect the skin. If this patient not good effect topical treatment, we can use from azole group. I prefer fluconazole 50 milligram once daily for 2-3 weeks, or itraconazole. Please, if you have patient with Candida intertrigo, please don't use terpenafine. No effect. What is the therapy continued? This is additional measurement. As I said, very important before you start the therapy is keep the area dry. Frequent for all sister here. Please frequent change the diaper. Dry the area after bathing. Okay. Also ventilate the area. Avoid a lot of moisturizer or ointment. We can use only zinc oxide. This is good for protective the skin. And very important to put barrier between the fold to reduce friction. Thank you very much for the I'm ready for any questions if you have.
Thank you very much, Dr. Abdullah Al-Badri, for this very nice and informative, valuable lecture. If there is any question, please, from our. Yes.
Good afternoon, doctor.
Good.
I just want to ask, because we have a patient from our home care that has a dermatitis. He was diagnosed with dermatitis because of diaper rash.
Yes.
Which he has the redness from the back and the front and up until his legs. I'm sorry I was not able to catch up on the management that you've mentioned before. Can you please try to re-explain it further? Thank you.
Diaper rash?
Yeah, yes, doctor.
Okay. Very important thing for the diaper rash. Okay.
I'm sorry, we're only using a pseudo cream for it.
Yeah, okay, you can use it, okay, but we can also, this is also the treatment of diaper rash, okay. You must to make the area free, okay, between the change of the diaper, okay, for 30 minutes to allow the air to come, okay. Number two, please don't make a lot of emollient, only zinc oxide. This is protective, okay? Make the skin barrier good. Don't penetrate the candida or the infection inside the skin. That is also, please, you can select it large size of the diaper to reduce friction, okay? Of the very important between the fold, you must to put gauze or anything barrier to reduce friction. If extended, we must to think about candida infection. Okay, we can make swab, send to lab, or start antifungal therapy. If patient diaper dermatitis, also very important to use hydrocortisone. It's good in this area. 3 weeks, no problem, till inflammation will decrease, then antifungal infection.
Thank you. Another question, please? No? So let me ask, as long we are speaking about home care and your lecture about elderly dermatological disorders, elder people using usually a lot of drugs. What is the effect of multi-drugs without supervision from the family or follow-up with the doctor? What dermatological problem, and if happen, what he's going to do?
Thank you, Dr. Abdulhafiz, for the nice questions. The important thing for us as dermatology, for using a lot of medication, this all medication of elderly, okay, may cause severe dryness of skin and severe pruritus. That is the only what we are seeing here. This way, we can discontinue this if not necessary. We can continue. All medication can cause pruritus, okay? Also anti-diabetic, EC inhibitor, antihypertensive, okay? The analgesics also, Dr. Abdulhafiz, aspirin, morphine, codeine, may cause severe dryness of skin with severe itching. This way, if the medication is necessary, I advise all patients to use a lot of emollient without irritant, okay, to make good hydration of the skin. That is only from our side as dermatology. We have a lot of patient also has allergy from medication, can cause severe allergy, urticaria, or TEN syndrome, Stephen-Johnson syndrome. For example, allopurinol, anti-gout. We have a lot of patients in ICU. This way, a lot of medication without doctor advice is not good.
So I understand that it doesn't mean that he will never use this type of drug, but stop it for a time, then start again. Maybe that time is only the time he has this eruption.
No, if patient has allergy from one medication, please don't use it again.
If he knows.
if he knows this medication can cause allergies, zum Beispiel German. For example, okay, antibiotics, okay, make urticaria, angioedema, please don't use it again. But if patient has, okay, mild pruritus from any medication, we can use antihistamine plus the medication and good hydration of the skin.
Thank you very much, Dr. Abdullah Badri. We enjoy too much your presence with us and this very valuable lecture. Thank you very much. The next speaker. بارك الله فيك. شكرا دكتور عبد الله. الله يسعدك. الله يحفظك. زياد ما في. When he's done.
You want I will call.
معلش المتحدث our next speaker he is in the way, he is coming and few minutes he will be here. So during this time, let us enjoy a cup of tea or coffee, please. And we will be back after 5 minutes. المحاضرة جاهزة؟ المحاضرة بس من عندنا بس. Next. We welcome you again in the last session for today, and I'm going to introduce the second speaker, Dr. Ziad Al-Shami. Dr. Ziad Al-Shami is Director of Advanced Neuromusculoskeletal Care Center, Consultant Neurology and Headache in Department of Advanced Neuromusculoskeletal Care Center at Dr. Samir Abbas Hospital in Jeddah. Dr. Ziad Al-Shami, he was a consultant neurology and headache Department of Neurology at the International Medical Center in Jeddah and was Director of Pain and Headache Management Center of Excellence in Jeddah. Dr. Ziad also fellow and clinical instructor headache and pain in Cleveland Clinic Foundation in the Department of Neurology, Cleveland, Ohio, USA, early in the 23 to 5. I welcome you, Dr. Ziad.
جزاكم الله خير، شكرا على استضافتي.
أهلا وسهلا. Dr. Ziad, you can start now your lecture, please.
Okay. منتظر تنزلوا لي الليكشر.
First slide. شايف الليكشر لسه؟ طيب دقيقة.
ايوه دحين شايف الليكشر. طيب who's gonna advance the lecture?
1 minute, 1 second please. I will. يلا you can start now.
الادفانسمنت تبع الليكشر كيف اسويها؟
بس قول next واحنا
اوكي. طيب
مجرد وقفة بسيطة نعرف انه next، اذا ما حصل قول next.
طيب السلام عليكم ورحمة الله وبركاته. أتشرف دائما كما كنت دائما ترعرعت 15 عاما في ظل الفاميلي ميديسن أن أكون معهم وبهم نمضي. نتكلم اليوم عن موضوع جدا مهم ألا وهو migraine prevention and the importance of it and the importance of acute management accordingly in order not to let it chronify. And there is a reason behind that. Next. The impact of migraine is huge. نحن بنتكلم out of 8 billion on earth, there is 1 billion, up to 20% of the population who have headache and migraine. So basically, it's a huge number. The migraine is a combination. Number one, it's a disease. Since 2017, it is a disease. It's a changes that is a combination of vascular changes in the brain, neurological changes in the brain due to vascular constriction and recurrent inflammation, in addition to changes cortical and subcortical due to different recurrent aura and electrical changes in the brain. And there is psychological changes with migraine, with behavioral changes that happens over years. And this is why we have a combination of people who are more depressed if we don't control their migraine, people that have dysfunctional behavior and dysfunctional day where they cannot achieve things, and patients who have compromise in everywhere. The migraine that happened more than twice a month at this point need to be addressed, And if we're reaching 4 and above of migraine headache days, then we have an issue. Migraine becoming a burden because it affects the quality of life and affects the productivity at work, and it affects every function. So if it's recurrent and if it's even chronified, which is daily, it's even worse. The problem, we don't really have a medication for so many years that are specific for migraine. We've been treating migraine by proxy, symptomatically, like flu symptoms, we're treating migraine. We did not, we had insulin for diabetes, we have antibiotics for infection, we have anti-inflammatories for inflammatory, but we created for rheumatology a very specific drugs, not for migraine. Not until in the 1990s when we started having the first specific drug for migraine, which was triptan. Next. So basically, in order to understand migraine, you have to go to the classification of headache in general and understand that migraine is a complex component of 3 different entities, which is electrical and vascular, as well as there is peptide changes and there is inflammation with a material called or peptide called CGRP. And this why when you want to classify it, you will say that these episodes are recurrent and could last from 4 to 72 hours because they go through stages, pre-dawn and prodorm, the prodorm, and the migraine itself, and the post-dawn. And during all of that, there is a changes that happen in all different entities of the brain, including the brainstem and including thalamus and subcortical and cortical. And this is why you see the symptoms when you say, I'm gonna classify this as a migraine. Oh, it has to be one-sided. Why? Because it takes one side of the brain with the blood vessels and it's pulsating and there is pain and there is other entities that's happening with it. Or it has to have nausea and vomiting and phonophobia and photophobia. Nausea and vomiting because it's taking the area in the hypothalamus and the others as it's coming spreading to the thalamus and affecting the sensory component and causing other changes. Phonophobia and photophobia because of the other thing. So we are talking about a brain disease changes. Next. So basically, when we classify, and then we will go, well, we're going to say a migraine with aura, a migraine without aura, a migraine with reversible and irreversible. Oh, why do I have a visual and sensory changes and aura? Because of the changes that happening in the brain and affecting the cortex and affecting the blood vessels and causing motor weakness and causing brain stem changes with the baseline migraine and the vestibular migraine, the retinal with the flashes that happen. And this is where I go and say, if it has an aura, doesn't have an aura, positivity, negativity, this is a brain disease again. And there is inflammation in it. There is electrical cortical changes in it. There is vascular changes in it. This is why we need specific management for it, acutely and preventatively. Next. So basically, pathophysiology for migraine. So it's a brain disease, brain dysfunction, inflammation, and activation of different areas, including the covering of the brain, which is the meninges that follow for blood vessels. And there is an activation of nociceptors where it comes together, and there is activation of a trigeminal. The way I look at the brain is like a tree. And the way I look at the tree, there is a brain stem at the stem of the tree. And there is comes up and comes the pollen and comes the rest of the brain. And then at the branches of that tree, which go to the 3 different dimensions of the face, the front of the face, the middle of the face, and the third part is the trigeminal nerve V1, V2, V3. And at the beginning of it, this is where all the activity between the brainstem and the thalamus that's happening, where the migraine come up and down, and then catch up from below, from the neck, where you have cervicogenic migraine and you have the other sensitivity. Next. So here comes the real pathophysiology of migraine. A migraine is an electrical, vascular, inflammatory changes where there is an activation of a molecule that's called CGRP that create a cascade of changes that cause vasodilation, that released from the trigeminal ganglia, get elevated in the blood vessels, and that is doing all the changes that we see, the pulsation, the changes in mood, and the sensitivity of the nerves, and the allodynia, and the hyperpain, and the spread all over the different area of the brain is like you are flooding the whole brain, and you are soaking the brain with the fluid. If you soak any device, if I soak your iPhone with a fluid, can your iPhone function? Why do we allow the brain to be soaked with the fluid? The brain is more important than an iPhone, okay? So basically, this is where the importance of preventing the CGRP to go on and acutely stop it. Next. So basically, when I do migraine management, I have to do trigger avoidance in my lifestyle, and to avoid and prevent, and there is a new neuromodulation, but the first 3 are extremely important. Next. Trigger avoidance and lifestyle, life changes, the obesity, and all the secretions that happen with obesity and the sleep disorder, which affect different area in the brain and the recharge of the brain, and so forth. However, what's really important, and I'm talking to my colleagues, beloved colleagues, primary care, family medicine, and internist, to avoid opiate, to avoid tramadol and tramal in headache, to avoid soaking the patients with a lot of gabapentin and others, and treat the real cause of disease. Next. So basically, we have current preventative and abortive of migraine, and they're good. And basically, it's a combination of symptomatic treatment, where I have a vascular disease, I'm treating the vascular disease with antihypertensive and angiotensin receptors. I have electrical wave and seizure-like activity. I'm doing anti-epileptic. I'm doing for vascular beta blockers. And the closest thing that happened in the 90s and early 2000s was the triptans, because it worked immediately on the receptors that mediate the neurovascular component, the serotonin receptors, and which will come the somatriptan and elatriptan and fovatriptan and so forth, and naratriptan, and Botox, botulinum toxin, because they work on the CGRP concept and on that junction. And then we have the CGRP targeted antagonist, and the CGRP receptor targeted, and so forth. So basically, all of this, in addition to the good medication that worked in the past, but some of them became dangerous today. Ergotamine, that was, kind of magical in the past, and combination medications, including a combination of membrane stabilizers like antiepileptic, with a magnesium, with antiemetics, and so forth, which worked in the past, selective serotonin, of course, receptors. There is a previous that worked in the past and still works very well as acute therapy, and there is a new treatment which is more central and peripheral as well, which is the F receptor that we'll talk about, and it's there. Next. So basically, when to start preventative treatment prophylaxis. Nowadays, you look at four episodic and even 2, but 2 to 4 or 4 or more, depending on what you're looking for. If you're looking for acute therapy, you look at 2. If you're looking for preventative therapy, for episodic preventative therapy, you look at 4. You look for significant debilitating attacks despite appropriate acute management. But remember, each time you want to allow it to become debilitating, you want to make these attacks come worse, and think about it like getting your wife angry. Do you really want to get your wife really angry? None of us want to get his wife really angry. You just learn over the years to stop when the face change or when she make a click with the eyes or eyebrow. Then you stop and change and, fix it. Because once it's spread, the inflammation spread and the changes happen all over. Difficulty tolerating or having a contraindication to acute therapy medication overuse. Of course, the medication overuse is a very big stuff in addition to other issues. Next. So basically, the older migraine preventative often have low adherence. And as we look at the number of compliance, we'll find it in the 20s and the 30s with different categories of what's there. Next. There's poor adherence, there is high discontinuation, and there is compromise in achieving optimal therapy. The reason why you want to taper it, and you taper it, you say, like to pyramid, you cannot really start at 100, and 100 is the ultimate, and 100, the number change as per weight. Sometimes you need 150, sometimes you need 75, with people who are in the 40s or whatever, and you need to go, go slow and gradual. By the time you hit the target, you are 2 and 4 and 6 and 8 weeks, and you are working already with a chronified service and an inflammation. It's like you wait until people are very angry and dissatisfied with the job until you fix their problem. Then they don't like you as a manager. Next. So adherence to prevention of migraine over 12 months and follow-up patient with migraine CGRP antibodies versus a preventative treatment being done, and the proportion of adherence of patients comparing to others show where CGRP antibodies, monoclonal antibodies, there is better adherence in compared to other preventative, which because of the other things that we talked about. Next. One of the medications that I'm asked to speak about today, and part of it because of my experience over the year as well, is galactosumab. We have at least 1 year in Saudi Arabia, and we've been working with it through other neighboring countries where patients being prescribed the medication and they used to bring it and they used to apply it now since 2019. Next. So basically, when they've done the galactozumab and compare with erizumab, eptizumab, and the others, they wanted to have a study that look at it. And it's basically, they've done the Evolve 1, the Evolve 2, which is basically have looked at episodic migraine. Again, episodic migraine is different than a chronic migraine. It's different in so many things. The whole brain is wired differently in episodic because it's coming like, 4 or more versus a daily migraine, a daily headache with a lot of fluid and chemicals and changes in the brain. So basically, when they've done the Evolve 1 and Evolve 2, it was episodic migraine, 6 months double blind, and they brought 1773, and they've done, they looked at the primary endpoint, which is monthly migraine headache days change from baseline, which was done in all different studies, and that's what they look at it with all different anti-CGRP medications. There again, it was for chronic migraine, 3 months double blind, and 9 months open label extension. And they had 1113, which is 1,113 monthly migraine headache days, what the endpoint. And then they've done the Conquer, which is also for treatment-resistant migraine, episodic and chronic, 3 months double blind and the 3 months open label, 462, and the long term, which is episodic and chronic, which is 12 months, but this time all the 12 months are open label. Next. So basically, when we're looking at the Evolve 1 and Evolve 2, and we compare the line with red, which is galactozumab, 120 milligram, and basically the galactozumab, the first dose will be 240 usually, and then you go to 120 every month. Here, when they compare the 120 milligram to placebo, there was a drop. And this drop was significant in the number of days in compared to the placebo. Next. So you will see the drop by 4.7 comparing to placebo 2.8 in Evolve 1. And in Evolve 2, 4.1 to 2.3, and in Regain, 4.8 to 2.7, and in Conquer, 4.1 to 1 point. And if you minus the 4.7 to 2.8, you will see they're significant in the number of days. Next. Episodic migraine response rate, defined level of reduction in monthly, again, migraine headache days, month 1 to month 6. So basically, they looked over 6 months, and you will see the difference in the number of response. To get to 50% of reduction, you will see the placebo in gray and the Emgality in black, and you will see the number of reduction was 38%, 38.6, 50% of the patient achieved 38.6 response reduction in the number of days, where when it goes to 75% of the patient got 19.3 and 100% got 6.2, which is basically, it's hard to get a very high level response, but 50% to get that number is pretty high. Next. Also, for the low frequency and the high frequency episodic migraine. And when we look at the impact on MIDAS, MIDAS is dysfunctionality, and where the migraine are, the patients are pretty much dysfunctional. And this is one of the things that they look at it in research, is the patient dysfunctional or functional? If he's functional, then we are gaining. If he's dysfunctional, we're not winning. And there was a very marked improvement in the MIDAS score with Emgality. Next, both in high frequency and low frequency. Emgality significantly reduce the functional impact of migraine in patient life. I mean, if you look at the functionality, you will see the changes between the placebo and the people who took Emgality. Okay, and basically anti-CGRP, to be fair to all of them, in general, they have very good results in that. Next.
Ziad, 2 minutes more, please.
2 minutes more. Oh my God. Okay.
You exceed the time already.
Okay. So basically, we could look here and okay, and you will see its effect in different parts throughout the treatment. Next. In general, Emgality was well tolerated, low discontinuation rate, and this is when we talk about prevention. We really need to have patients be loyal to avoid the chronicity. Next, easy to use. It's basically like any monoclonal antibody. Autoimmune is, it comes in a, you know, like I don't want to mention the brand name, but it's like Ozempic and the others. Next.
Conclusion.
Conclusion. In general, I mean, can I go to the acute therapy? Let's skip the next slide and another. And the next slide. Next slide. Next slide. This is all talk about the guidelines, how to use anti-CGRP, which next slide. Okay, so okay, next slide. For abortive therapy, there is another medication called lesmetivian, and basically next, what I want to show about this, that this one does not affect the vascular component. If you have cardiac and have other vascular brain issue, you could still use. However, it is central to a point where it causes dizziness, and its protection is for longer time and persists for longer. And this is one of the new medications that's also coming in the market, and it works as an abortive, but also it could sustain for better prevention. Next. And this is a point that I've been mentioning. When you work on this tree and stop the inflammation early, acutely and subacutely, by working on something that works peripherally and centrally with the minimal side effect, and have the patient compliance, would be the best. Conclusion. In conclusion, the message I want to get today, that migraine is a disease that affects the brain. And looking at this picture, it affects the cortical and subcortical, and there is atrophy with time because of the stress and anxiety and changing in peptide that cook the brain. There is vascular compromise due to vascular constriction. There is the dementia that happen usually in time for people that have multiple strokes also affects the memory in the brain from the constriction in time. And there is dysfunctional ability with behavioral changes, we need to have a medication that address for the new now 2020s and the next 20 years, address the pathophysiology of migraine, it to stop the attack early and prevent, because migraine is a real disease and there is a real change that's happening. And thank you very much.
Thank you very much, Dr. Ziad Shami. Indeed, we enjoyed too much your very valuable lecture. And we are going now, I can say to you, thank you very much again. And we will shift to the next lecture. The speaker, I am very proud to introduce Dr. Asim Muhammad Al-Shambari, Dean of Faculty of Medicine in Batterjee Medical College. Since 2020 till now, and Dr. Al-Shambari, well-known family and geriatric medicine consultant in my clinic in Jeddah, starting from 2018 to present. Dr. Shambari, please.
Everybody loves Dr. Shambari, patients and doctors. God bless him. Thank you very much.
The pointer, is it working? شغال البوينتر؟ Bismillah ar-Rahman ar-Rahim. Thank you so much for having me today. I know the last lecture should be the lighter one, so it wouldn't take long time. I will be brief to discuss the common respiratory problems and how we would manage it in patients at home. General goals for home care for individuals with respiratory disorders are to increase the survival, decrease the morbidity, improve the function and the quality of life, support independence, and the self-management, encourage positive health behaviors. There is a specific goals. Actually, those specific goals, it depends actually on the patient. And we would negotiate that with the patient and families. The most common diagnosis of patients with respiratory disorders referred to home health care is COPD patients. This is actually based on US numbers. COPD and pneumonia are respectively the 4th and 5th most frequent reasons for hospital discharge for Medicare patients to home care, respectively. Those are the list of the, common cases and diagnoses that required care at home. Airway disease for asthma, bronchiectasis, COPD, restrictive respiratory conditions, neuromuscular disorders, sleep-related breathing disorders, and others like patients with lung cancer and pneumonia and pulmonary hypertension who discharge from hospital needs extra care. The general assessment includes relevant history, examination, body assessment, evaluation of the patient's management and of the response of medications. The nurse playing main role actually in the management as well. The nurse evaluates challenges to management of the respiratory conditions presented by the living environment and the impact of the disease day-to-day living. Focused assessments of functional and cognitive status, potential safety problems, ability to access emergency help, psychosocial and learning needs. This is what we are talking about as a team taking care of patients. So we are giving the patient a lead where he would, whenever he has a concern or have a questions, have any emergency, he would contact the doctor or a nurse, where that would decrease the ER visits or visiting the hospital. In-depth respiratory assessments includes pulse oximetry at rest and with ADLs, IADLs, walking or exercise, a peak expirometry flow rate or portable spirometry, and if indicate, home apnea monitoring. Observation of inhaled medication technique, evaluation of airway clearance maneuvers, and management of the home respiratory equipments are the other thing that we would consider. The home health plan of care is based on assessments, findings, and the physician's determination of medical needs. Medications for chronic respiratory diseases are prescribed for general goals of symptoms reduction, management of complications, and maintenance of the lung function. Let's go through the some guidelines. The global initiative for chronic obstructive lung disease recommends the following for patients at home. Short-acting bronchodilators are as needed for symptoms management, routine administration of long-acting bronchodilators in moderate to severe COPD, use of short-acting beta agonist and anticholinergic medication combination. The thing is all about beta agonist for those patients or older adults. We should consider the tachycardia and arrhythmia in those patients. Just to give you, a brief about that. Those patients need special consideration. We have to see if they have regular heart rate or not, but generally speaking, avoiding it at home, it's good. Considering annual or biannual flu vaccination, routine inhaled corticosteroids are recommended only for severe or very severe COPD. Treatment of exacerbation with bronchodilators, oral or intravenous corticosteroids, and antibiotics when sputum is virulent or increase in volume. The other recommended, antibiotics, we would go with azithromycin as it has anti-inflammatory effect that would decrease the hypersensitivity around the bronchus, so decrease the constriction. The National Asthma Education and Prevention Program recommends the following. Inhaled steroids for mild resistant asthma in patients for any age, low to medium dose inhaled steroids plus a long-acting beta-2 agonist for moderate and severe persistent asthma, high dose inhaled steroids plus a long-acting beta-2 agonist and oral corticosteroids are needed for severe persistent asthma. Antibiotics are recommended for treatment for exacerbation only when there is fever, virulent sputum, pneumonia, or bacterial sinusitis. In cystic fibrosis, thanks God, we don't have that much patient actually under my care, but I would say I had one patient with cystic fibrosis, really difficult to manage at home. However, a good communication with the specialized doctor pulmonologist should be on board for taking care of such patients. Generally speaking, nebulized tobramycin and colistin are commonly administered for maintenance therapy. Nebulizer tobramycin has also been effective against Pseudomonas infections in patients with bronchiectasis. Acute serious exacerbation generally required intravenous administration, most likely, at hospital. This is what we are, facing now, the seasonal variation. We are almost heading to January. As you see, we have the whole monsters around us, and we can see the spike of the infections around, for the upper respiratory tract infections. Here is the summarization of the common cold differential diagnosis. I wouldn't go through it, but generally speaking, for bacterial sinusitis, most of the time it comes with fever. The cough, it goes with special kind of cough, whooping cough with pertussis infection. And as you see with pharyngitis, the most common presentation might be the sore throat. The difficult, decision that you would, or the difficult part is facing the patient that he doesn't need antibiotic. And this is, it has to go through, it's a skills actually to convince someone about your thought, but convincing a patient who already come to you or you visit him at home, asking you to give him an antibiotic, explaining why antibiotics not helpful. Most of the time going easy, viruses and bacteria, the difference is that the antibiotic doesn't fight a virus. So make it as simple as you can. Suggest treatments that might be helpful, and we will go through some literature review which one it might be recommended as an alternative medicine rather than giving the patient antibiotic. Managing expectations. So cold viruses. So what is next? Why? For how long I would have this? So you would explain cold. Viruses can make you feel lousy. Most people start to feel better after about a week. So you would talk to the patient about the progress of his illness. The other thing, discussion of the steps if the patient doesn't improve. So you need to give him, a way back to you, red flags in case that he needs any help, he would visit you anytime. This is based on the literatures, the effective medications. There is kind of like Cochrane review for acetaminophen. It's helpful. Very interesting that in my practice, I would go with the important thing, lactobacillus. Lactobacillus, randomized control trial shows that for 1,072 older adults found significant improvements in duration of colds and in cumulative days with cold. So we do, personally, I do recommend it for my patients. It's 200 grams per day, might be helpful for them. So you would start it during the season of, common cold and flu. The other thing, what is the ineffective treatment for cold? Based on literature, as you see, antibiotic, antihistamine, codeine, intranasal corticosteroids, vitamin C, vitamin D, vitamin E, even like the interesting part is vitamin E. Having vitamin E, it shows in a randomized control trial a significant worsening upper respiratory tract infection. So we need to be careful having those kind of vitamins. We think that it might be helpful. Unfortunately, it's not, regardless the big advertisement about it. They won't be happy about this, but anyway. Effective treatment for cold symptoms in children. So as you see here, honey is in randomized one randomized control trial. It has significant reduction in symptoms, and we can have it for the ages like 2.5 ml from 2 years to 5 years, and we can go from 10 ml from 12 years to 18 years. For vitamin C, as you see, like in children, it might be helpful. And as we said before, in adults, it's not that helpful based on the randomized control trial. However, we can see that there is kind of like reduce the symptoms of, but not reducing the period of illness. The ineffective treatment for cold for symptoms in children, it's like antibiotics unless that you need it. However, all of that, steam, vitamin D, oral prednisolone, it's not working with kids. I was trying to make it as fast as possible to make it lighter. However, I'd like to thank you all for having me today. And thank you so much for you to be as an audience for this lecture. Thank you.
Thank you very much, Professor Asim Ashambari, for sharing us in the success of our conference by sharing in this very valuable lecture. By this, we come to the end of the second day of Salam International Second Health Care, Home Health Care. أشكركم جميعا، أشكر جميع المتحدثين الذين شاركوا معنا يوم الأول واليوم الثاني في المحاضرات، ونقدر المعاناة التي بذلوها للتحضير والوصول إلينا رغم أنها أيام عمل ولم تكن ويك إند. شكرا جزيلا للجميع، شكرا جزيلا للحضور سواء فيزيكال لدينا في القاعة أو الذين حضروا فيرتشوال. نلقاكم بإذن الله تعالى يوم غد في اليوم الثالث عند الساعة 9 صباحا، وسيكون البث في جميع المحاضرات فيرتشوال افتراضي. شكرا والسلام عليكم ورحمة الله وبركاته.